Good morning, respected dignitaries, faculty members, and my dear colleagues. We welcome you all to the PROACT PuneCon 2022. Let us now proceed with the scientific program of the day. Moving on to our first session. Pregnancy is considered a natural process for a majority of women. A limited proportion of pregnancies and deliveries can present with a broad variety of complications that may require admission to the critical care. I hereby request Dr. Joy Shankar Jana to kindly come up on stage and introduce our chairpersons and speakers for this session on obstetric patients needing critical care.
Chairpersons कौन है?
Dr. Shalini and Dr. Jyoti.
A very good morning to one and all. Welcome you all for this physical conference of PROACT we are having since 2016 when we started. In the middle, as said, because of COVID, we could not meet. So we meet here in this August gathering. We'll start the first proceedings of this meeting. Let's invite our chairpersons, Dr. Shalini Sardesai ma'am and Dr. Jyoti Kale ma'am. I welcome you all, and I then hand over the session to our chairpersons. Speaker, you will introduce. Chairperson. कुठे ऑडिओ विज्युअल पहिल्या सेशनचे स्लाइड्स लाव ना. या
Hello. Good morning, everybody. First session is on obstetric emergencies. In our routine practice, everybody comes across the different obstetric emergencies. Actually, obstetric emergencies are very predictable, and if you take due care, they are manageable. But there are certain conditions in obstetric patients that will come that we cannot expect, or it is very difficult to diagnose, and it will create a lot of stress for us to manage. Patient with cardiomyopathy, definitely these patients present with unexplained tachycardia, hypotension, dyspnea, without any cardiac disease. So in such patients, diagnosis is also difficult and even management is also difficult. So now today we are highly privileged to have Dr. Pandya sir here to enlighten us on different obstetric emergency, mainly obstetric patients with cardiomyopathy. Actually, there is no need to introduce Dr. Pandya. He is a very well-known obstetric anesthesiologist attached with AIG Hospital, Fernandez Hospital, and PACCS Healthcare Private Limited. He is an instructor for many life-saving courses like ATLS, ACLS, CCLS, CTLS, He introduced for the first time and conducted several workshops on LAWS, CCO, WS, critical incident WS, started obstetric anesthesia fellowship program first in India in 2007. Also, he introduced AOA task force guidelines for us. So now I request Dr. Pandya to start your session. Thank you.
Thank you for the kind words, madam. A very warm good morning to each one of you. It's always pleasure to come to Pune n number of times. I get a lot of love and affection. And thank you very much, Pune PROACT, for this kind invite. Can I have the presentation, please? Not able to move the slides here. Can I have your assistance, please? So, how many of you have encountered peripartum cardiomyopathy in your experience, in your practice? Knowingly, unknowingly? Unknowingly? Aquatic. And that's what PPCM is about. Yeah. So, PROACT is something which is dear to my heart because it takes into account not the theoretical part but the practical experience, and that's what helps or interests us, most of us. I'm not able to move the slides. Sorry for the audio-visual glitch, but nil conflict of interest, and the pictures and photographs that have been shown in my presentation have been obtained with the prior permission of the patient, and we do take consent. So if you review the maternal mortality rate, and this is one of those very, very authentic embrace audit from the United Kingdom, which tells us the exact cause of the maternal death, and cardiovascular are the leading cause of maternal death in the United Kingdom. And if you see, the PPCM remains the leading cause of non-obstetric fetal maternal morbidity and mortality even in our country. I review my own ICU data, and more than 5% of ICU admissions are because of underlying cardiovascular disorders, and a sizable chunk are peripartum cardiomyopathy patient. I would say that on an average, we encounter a patient a month, is what the statistics says. So how do we define PPCM? It's a rare form of cardiomyopathy in pregnancy that occurs in the last trimester and can occur up to 4 to 6 months after delivery. And it is basically a diagnosis of exclusion. It requires a high index of suspicion because patient may not have the classical telltale signs of heart failure, and other risk factors like obesity and other things might coexist with the entity. So straight away I jump onto the cases. In between the cases, I've tried to interpret some of the theoretical part just to have a greater insight. So this was a patient, WF, 23-year-old gravida, 2 para 1 live 0, had a term IUFD, sudden because of abruption. Again, slide is not moving. See, it's clinical bedside sign of peripartum cardiomyopathy. Yeah, breathlessness is a terminal, like delayed presentation. But before that, subtle sign. Tachycardia. Persistent, unexplained tachycardia, an insidious onset of breathlessness. Not a sudden onset will happen terminally. It's moving now? No, it's still not moving. So, the persistent tachycardia is a very subtle sign. Tachycardia, again, there's multiple causes. Pregnancy itself can cause increase in heart rate. And if the parturition is in labor, the heart rate increases further. And we know that all the peripartum medications like oxytocin also can cause tachycardia. So when you have persistent tachycardia, you need to have a underlying insight. Is it because of sepsis? Is it because of cardiomyopathy? Is it because of underlying cardiac disease? Is it because of hypotension? Because of hemorrhage? Multiple causes are there. Just you need to have an eye to pick up appropriate cause and treat appropriately. Is moving now? Yeah. So this was a lady who was 23-year-old, had a IUFD at term, leading to crash cesarean section because of pulmonary edema. A patient survived because of short-term elective ventilation, and subsequent pregnancy, she came to us around 14 weeks. She was a diagnosed case of peripartum cardiomyopathy in previous pregnancy, leading to abruption and IUFD and heart failure and pulmonary edema. We advised clinical workup and repeat echo. Unfortunately, the patient disappeared from the radar. She never turned up. She had persistent, as I said, persistent tachycardia, distended jugulars, and subtle or dyspnea and exertion are the subtle signs. All the other signs, again, it's not moving here. Okay. Okay. So persistent tachycardia, insidious onset, it doesn't matter. Insidious onset of breathlessness are the subtle signs, and of course, if you look closely, they may have distended jugular. And if you look at the risk factors, there are multiple risk factors, but importantly, from our side, it just, can I have the pointer? Preeclampsia was the risk factors in this case in the previous pregnancy. Otherwise, all these are the risk factors in pregnancy. So how do we do a diagnostic workup? As I said, it's a diagnosis of exclusion. We need to look for clinical features. ECG may show non-specific T-wave inversions globally or specific leads. LVH, by default, all parturients have LVH, all the chambers are enlarged and left ventricular hypertrophy is there because of pregnancy-induced changes. But yes, some of them, they have a prolonged PR and QR interval, and sometimes they present with arrhythmias. Echocardiography is the diagnostic feature of PPCM, and chest X-ray, if you do, then it shows cardiomegaly, and it also helps us in ruling out other pulmonary causes of breathlessness. ABG shows type 1 respiratory failure most of the time, and biomarkers, most of the time, the biomarker that we use is NT-proBNP, N-terminal pro-bariatric, mean natriuretic peptide, which is elevated even in preeclampsia and HELP syndrome, but if the levels are high, then it signifies that there is underlying heart failure. Cardiac MRI helps us in delineating morphology, and of course also helps us to delineate if there is an underlying myocardial inflammation. So if you find any myocardial inflammation, the chance of arrhythmias in the perioperative period are very, very high. And of course now you have this panel of genetic testing, and all these things are available. But yes, we know that there is a genetic element in about 25 to 30% of patients who have recurrent cardiomyopathy, and this is the then which you can always advise. So this patient came to us, we did a repeat echo, ejection fraction was 30%, we advised termination, and she disappears from the radar. Unfortunately, after about 4 months gap, she turns back with breathlessness. Basically, this was a serious family issue. They had either you give us a child or you divorce, something of that sort. So she continued pregnancy, risking her life, and we had to optimize her medically. Ejection fraction was same, repeat echo was done, and patients and family were counseled. So what counseling we do when the patient comes again around 30 weeks? We started steroid for fetal lung maturity, but again, these are the things which you need to look at the echo. If the left ventricular end diastolic diameter is more than 2.7 centimeters square, then it definitely indicates that the chance of recovery are better. But if it is, if the LVF is more than 30%, the chance of recovery are good. And similarly, smaller size LVESD, like left ventricular and systolic and diastolic diameters, are good prognosticators. So looking at the echo, you can always prognosticate. Again, diagnosis of PPCM and counseling depends from which area she originates, because patients who have preponderance present from Africa and other places, the prognosis is bad. And if you look at the presentation in Europe and Asia, most of the time the severity is high, and incidence of long-term complications, like if you see thromboembolic events, rehospitalization rate and mortality is also high. So we need to take into consideration all these things when we need to counsel this patient. So basically, we put this patient on loop diuretics, optimize the preload, afterload, and of course ACE inhibitors we didn't start, but we counsel them. We will start in the postnatal period, and she was put on low dose heparin, low molecular heparin, and because the facility was available in Hyderabad of heart transplantation and AICDs, we have counseled this also, because sometimes they present with malignant arrhythmias. And again, this is a very important part we need to counsel, because we know that there's specific therapy available to treat PPCM is bromocriptine, and once you give bromocriptine, lactation failure happens. So we need to advise them so that appropriately they're mentally prepared to give formula feeds to their child once the birth is given. Management of anesthesia part also has to be discussed, because we feel, at least I'm very passionate about neuraxial anesthesia, and that too graded epidurals for all cardiac elements. The technique of choice is graded epidural with invasive outline. CVP may not be necessary, but yes, it is a technique of choice. And if the EF is more than 45%, you can give single shot spinal also. If necessary, just be a standby vasopressors, inotropes ready. But if the patient is having refractory failure, heart failure, then of course GA is the technique of choice. Walking epidurals, low-dose mixtures, hardly they cause any cardiovascular instability, and they are the technique of choice. They're given a choice. And as I said, invasive monitoring is needed if the patient belongs to NIHA class 3 and class 4. This patient comes back around 36 weeks. We did an elective section because they were wanting previous cesarean section. They didn't want a TOLAC or a VBAC, which was a little difficult in this case because of unlike medical comorbidities and family issues. But she refused tubal ligation. Again, she wanted one more child. Postpartum thromboprophylaxis was given for 6 weeks. One of the important point which we have to remember is peripartum thromboprophylaxis has to be given not for 5 days, but at least for 4 to 6 weeks in patients who have low ejection fraction, because the incidence of prothrombotic state is very high and DVTs and pulmonary embolism is significantly high. And when the patient is on PPs, peripartum prophylaxis, then we want the catheter to be exited from the body at our desired time, not spontaneously. And hence, we always secure the catheter with a clamp so that we can remove the catheter at the time we want to remove it. Post-operative analgesia, the contingency plan is very important because many a times what happens is you are caught in blue. Suddenly this patient has massive PPH on table. How do you manage? Because we know that the classical management of postpartum hemorrhage or intraoperative hemorrhage envisages rapid infusion of oxytocin, 10 units per hour, rapid bolus, and all those things which can cause hemodynamic instability. So whenever you're handling a high-risk patient, over the period of years, we anticipate what are the common problems, the medical problems pertaining to underlying medical conditions, and optic-related issues like eclampsia or hemorrhage. How do we manage so that we have the wherewithal? So we always put this plan on paper so that we know what to give at what time and what to avoid and what to. So basically, oxytocin boluses are sort of a death warrant in these cases. Never give any bolus in these parturients. And postpartum analgesia or postoperative analgesia is multimodal analgesia, because generally we give neuraxial morphine 100 to 150 micrograms along with fentanyl. And if the patient is under GA or spinal, tab block also can be given. This patient comes back again after 2 years with third pregnancy. First was IUFT, second was the normal delivery. Cesarean section with normal outcome. Third pregnancy, ejection fraction is marginal improvement. So recurrent pregnancy is a stress onto the heart, and there is always chance of recurrent PPCM. And we had explained to her, but she was aware of all these things, and she underwent cerclage under saddle block. Everything was fine. She had elective section under tubal ligation. We gave created epidural, uneventful recovery. She was discharged home like any other normal patient on the third POD with EF of 35%. But what happened? After about 3 weeks, she lands up with orthopnea and cardiovascular collapse. And when we diagnosed, it was a massive pulmonary embolism, needing intra-aortic balloon pump, multi-organ supports, and we could somehow manage to save her and discharge her. The problem is because of her normal state and deceptive appearance, we didn't continue thromboprophylaxis for long. As like any routine case, she was given for 5 days, and patient also took only for 3 days. The moment she was discharged, she didn't took the remaining 2 injections, and that's it. So one of the things take home from this experience is never undermine the incidence of perioperative complications in underlying medical disorders, especially PPCM. You need to give LMWH at least for 4 to 6 weeks. This is another interesting patient, a 27-year-old, booked early for elective section. Again, previous delivery was an intrauterine fetal demise. I only gave CACA. It was uneventful single shot combined spinal epidural. And what happens? Within 2 minutes, she developed bigeminy, and within the 3rd minute, you see VTAC. Patient went into VTAC, and by the time they were just scrubbing the abdomen with betadine, I said, just pull out the baby first because we don't know what we are dealing with. We got the defib and we gave amiodarone bolus, stabilized the mother, and we managed as a cardiac patient because we didn't know what was the problem. We again reviewed the PAC chart. It was unpickable. There was no uneventful. There was no medical comorbidity in the PAC chart. We started NORAD and dobutamine because the pressure was on the lower side. And we managed the cardiac case. So how do you manage the parturient with suspected cardiac disease? very important. There are 5 principles which I call as Panchamantra. The pulse rate, the rate, the rhythm, the preload, the afterload, and contractility. So you have to maintain adequate heart rate, stable rhythm, adequate preload, adequate afterload, and good contractility. So your anesthetic, when you are planning, see that you maintain all these 5 parameters stably, so that so preload in pregnancy, we know that supine hypotension syndrome, aortic cable compression can happen. So by giving a tilt or a left uterine displacement, you can improve the preload by almost 25 to 30%. They delivered a child with good Apgar, and blood gases were normal. Again, we managed, as I said, no boluses were given. Fortunately, she stabilized. And carbitocin. Many of you are fond of using carbitocin now. What do you say? Would you want to use carbitocin if this patient has BPH or as a prophylaxis? Because you can give intramuscularly also carbitocin. Again, all cardiac diseases, suspected cardiovascular diseases, or suspected turbulent, stormy post-delivery period like severe heart disease or anticipating major hemorrhage, please refrain from using carbitocin, because it's a long-acting medication. It acts for about 4 to 6 hours. It's the same like oxytocin, but it's a synthetic preparation and long-acting. So the SVR reduction, tachycardia, all these effects stays for a longer time. The oxytocin is switch on, switch off. The moment you switch off the infusion, within 5 to 7 minutes, the half-life is just about 14 minutes. The action wears off, but oxytocin, carbitocin action stays for a longer time. So you have to keep that in mind. So no carbitocin in patients with poor NIHA class 1, class 3 and class 4 patients. We took a post-op CTG, ECG was normal, bedside X-ray revealed pulmonary edema, managed with non-invasive ventilation. She stabilized and put an arterial line. And subsequently, we did lung ultrasound, revealed B lines, that means classical. You could see the pulmonary edema, heart failure chances. And you can see the LV bedside transthoracic echo, global hypokinesia. We got the finding confirmed with the cardiologist, and she was having a occult cardiomyopathy, which got presented after spinal. It's flared up, and basically she recovered, but she recovered. EF was 27%. The point which I want to emphasize is, intraoperative post-spinal, if you encounter any hemodynamic instability, there are anesthetic causes, there are obstetric causes, there are surgical causes. So have an algorithmic approach so that you can pinpoint the diagnosis and give the best. And this is what she was treated with, and subsequently you need to have a wide differential diagnosis so that you can give appropriate treatment. I was very curious because there was a previous IUD happening in our same hospital. She pulled out the old case sheet from the medical record, and basically she had early onset severe preeclampsia with acute pulmonary edema, improved with conservative management. Echo was advised but was not done. So echo was advised but was not done. And basically, even in the discharge summary, patient said she'll get the echo done outside, and that's what we failed to follow up. So your protocol, the moment in our institute, the protocol for pulmonary edema is ABG, X-ray, ECG, and 2D echo is mandatory for any pulmonary edema, because we need to rule out any coincidental cardiovascular causes. And we didn't follow our own protocol. So follow your own protocol diligently, and if at all you advise anything, see that you close the loop. So closed loop communication is very important. Another interesting case, basically primary, 28 weeks, acute pulmonary edema. She has a creatinine of 3.2, present with acute pulmonary edema with CKD. We don't know. The EF was 24%. And pharmacotherapy stabilization, she stabilized with NIV. The obstetrician decided to terminate the pregnancy. She's around 28 weeks. So what anesthetic you want to plan? How many of you are for spinal? Epidural? Or rather general? Well, think beyond anesthesia. She started diuresing. So she was 28 weeks. So why not prolong the pregnancy? So assess the fetal assessment, fetal well-being. In fact, the obstetrician was keen to put the knife on the tummy, and we said, just hold on. If the baby is fine, mother from our side is stabilized on no inotropes. She's diuresing well. She is a non-adequate renal failure for whatever the cause. why not we prolong it? Yes, they thought we'll prolong. So day by day, day became week, and we prolonged the pregnancy almost up to 34 weeks. We did an elective section. So basically, the moment the surgeon says a section, don't think of what type of anesthesia. Think if the other alternate possibilities also. So we gave a programmed epidural anesthesia again. Again, this patient also refuses tubal ligation, but had an uneventful recovery. And she comes back again after 17 months, a short interconceptional period, with a 16 weeks pregnancy. EF was 39%, fortunately. Creatinine stabilized at 3 milligrams, non-aortic renal failure. This time also she has uneventful cesarean section under graded epidural. And she was advised to consult a nephrologist because a preemptive renal transplant was what we suggested, so that before she goes on dialysis and other things. Lovely 2 kids she had. But unfortunately, what happened is a few months later she died. So, leaving 2 orphans behind. So the lessons that we learn from is, don't take cardiomyopathies for granted. Every pregnancy, 9 months of physiological changes is a stress on the cardiovascular system. So even if the patient goes off smoothly from your intraoperative period, it's a life-threatening condition for her. And she would have been happy with 1 child, but because everything went off smoothly because of medical optimization, she got sort of pseudo-well-being state, and then ultimately that led to her death. So never take PPCM for granted. So what is the risk of recurrent PPCM in subsequent pregnancies? If the ejection fraction is more than 55%, 17% recurs. And if the EF is less than 45%, almost 66.7% of the time it recurs. This was the data by the URI-LCAM. And there are several studies where subsequent deterioration has happened. So even if the EF recovers or to the more than 55%, there is always a chance that the recurrent risk is very high. And subsequent follow-up, subsequent pregnancy, you need to have a protocol. This was another case of PPCM, stabilized medically, and you can see cardiac output monitor, high output failure they have. They're almost 14 of high cardiac output, 14.5 liters per minute, and I'm happily walking. She delivered normally. And the last case, she came with acute florid pulmonary edema, collapsed in the ER. And if you see, she was flooding. We immediately ACLS we did, and we delivered the mother in the HDU, like in the triage, and then shifted to OT for further closure. So basically, this is a perimortem cesarean section, and it was a non-compacted PPCM, non-compacted LV, part of congenital peripartum cardiomyopathy, EF of 26%. But fortunately, the mother and the child recovered, the proud father with a healthy child, almost 3.8 kilos. But the problem is, the non-compacted LV was known to the patient. They had concealed this history from the in-laws side. Again, this is very common in obstetric practice, where they try to conceal the medical disorders from the husband, thinking that it can be a source for disputes in the family. So the lesson that we learned is eternal vigilance, regularized protocol drills, and post-resuscitation ICU care are very important. We conduct drills in our hospital regularly. Both are Shailajas, one is obstetrician, one is anesthetist, and this is the thing we do every quarterly in our hospital. And you should remember that these are the subtle presentations, but sometimes the patient can have a florid presentation of pulmonary edemas and heart failures. And these are the patients who require the best of ICU care, the prone ventilation, even sometimes you require intra-aortic balloon pump as one of the patient needed, or sometimes they need ECMO also. And fortunately, we have all these facilities in our hospital. But importantly, you have to be ready and be prepared for perimortem cesarean delivery in, if at all, this case. This was the task force guidelines that came out just last month, and we have those infographics. It's available freely on the net. So the take-home message is, PPCM is a diagnosis of exclusion, needs prompt diagnosis and immediate stabilization, have an algorithmic approach. It is not only that because I'm discussing on PPCM, all hypertension can be peripartum cardiomyopathy. It could be something else also. So is it hypertension, is it hemorrhage, or is it sepsis, is it cardiac, or whatever it is. So you need to have an algorithmic approach. Biological markers can have a predictive value. Bromocriptine helps recovery, faster recovery in PPCM. But yes, you need to stop lactation. A type of anesthesia captain is important. So you want to give GA, you want to give spinal, you want to give epidural. It doesn't matter as long as you know the Panchamantra. If you follow carefully, you can minimize and optimize the perioperative period. Dopamine stress echo is a good predictor of predicting any, if the patient comes as a pre-pregnancy counseling, then DSC is one thing which you can have. And multidisciplinary team approach is what is important. And importantly, I request and urge all the anesthesiologists to learn the skills of at least basic views of echo, transthoracic view, transxiphoid view, just to know the global hypokinesia and at least volume status of the patient. These two things, if you can learn, subsequently you can go up the rung. I invite you for this live workshop that we are conducting in the month of December. Those who want to register can always get in touch with us. Thank you very much for the opportunity, madam, and sorry for the audiovisual glitches initially. I must have exceeded the time also. Thank you.
It was a wonderful lecture, and thank you, Dr. Pandya, for sharing your experience. You have enlightened us on different case scenarios. From this, we can conclude that cardiomyopathy can occur at any stage of pregnancy, especially late pregnancy and after the delivery. It is very common. And as he said, eternal vigilance, early diagnosis, and timely management of cardiomyopathy is very, very important. We will remember the Panchamantra, what he has given, that is, we will monitor rate, rhythm, preload, afterload, and contractility of myocardium. If we able to manage this, definitely we will manage the cardiomyopathy. And as he said, low molecular weight heparin, don't forget it, along with multimodal analgesia for the management of cardiomyopathy. Thank you, Dr. Pandya. Thank you once again.
Thank you so much, Dr. Pandya. So we go on with the next topic of high-risk obstetrics. It's a panel discussion. And I invite the honorable panelist. Slide. First is Dr. Nilima Gandhe. I request ma'am to take the stage. Second, of course, is Dr. Sunil Pandya. And third is Dr. Satish Fadke. Slides. High risk obstetrics. Play kar.
I think we have to move aside.
No, it doesn't matter because nothing written.
Okay.
Just questions. So till that's, this is the panel discussion. So the first topic to be discussed, since it is problem-oriented or PROACT, the theme. First is the HELP syndrome, HELLP, that is hemolysis, elevated liver enzymes, and low platelets. Next slide. So this is the questions on which we'll have the panel discussion. So the first opening statement on HELP syndrome will be done by Dr. Nilima Gandhe. Ma'am.
Hello.
Hello.
Next slide.
Hello.
HELP syndrome is one of the most severe obstetric complication, considered to be a variant of severe preeclampsia. Even if it is considered as a variant of severe preeclampsia, majority of the patients of HELP syndrome do not have hypertension or proteinuria. Now the syndrome was first coined, HELLP. The acronym was first coined by Winston in 1982, and this syndrome consists of hemolysis, elevated liver enzymes, and low platelets. The diagnostic criteria for HELP syndrome include hemolysis, which can be seen by abnormal peripheral blood smear, elevated LDH above 600 international units per liter, indirect hyperbilirubinemia above 1.2 milligram %, or there is microangiopathic hemolytic anemia. Red cells, they get fragmented by passing through the narrow vessels with fibrin deposits and endothelial damage. Also there is low platelets below 1 lakh per cubic millimeter. This thrombocytopenia is a physiological thing in pregnancy, but in HELP syndrome, the levels of platelets are below 1 lakh per cubic millimeter. And the elevated liver enzymes are thought to be because of hepatic blood flow obstruction because of deposits of fibrins in the sinusoids.
So, if in your prior practice you encounter such patients, how will you go ahead in the management, and how will you go ahead with the pregnancy, whether you want for normal delivery or for cesarean section, whether you will manage it in the small nursing home or whether you will refer it to a tertiary place?
Usually, severe preeclamptic patients, they have a very high incidence of HELP syndrome. Approximately 20% of patients of severe preeclampsia have HELP syndrome. So we need to investigate them for all the blood investigations, including the coagulation profile, the platelet count, and all these things. And the differential diagnosis includes the hemolytic uremic syndrome and thrombotic thrombocytopenic purpura. But if you are now confirmed HELP syndrome, in that case, the management is totally dependent upon the correction of hypertension and coagulopathies. But the only management is the delivery of the baby.
Yes.
But if the gestational age is above 34 weeks of gestation, we can think about the delivery, either a normal delivery or a cesarean section. But if the gestational age is less than 34 weeks of gestation, we may consider to optimize the vital parameters and then consider about the fetal maturity. By giving corticosteroids, we can optimize the mother and then take her for cesarean section.
So, you advise to be shifted to a higher center?
There is no need of shifting the patient to the higher center.
Your opinion, sir?
Well, I would just like to add few things to what she has said. As Madam has rightly said, at least about 15-20% of HELP syndromes are asymptomatic. They are only biochemical derangement. So unless you evaluate them, you may not have the telltale signs of a clinical, like hematuria or any of those things may not be there. But once a HELP, yes, the only way of definitive management is termination of pregnancy, removal of placenta.
Yes.
And because of the HELP syndrome, can turn into fulminant variety. So it is always better that patient is managed in an institution level rather than at a nursing home level, because we never know. Sometimes the deterioration can happen post-operative period or postpartum period. So that is one important thing. Coming to mode of delivery, yes, if the child is a very small and fetus is a very small, unlikely to survive, then you can always give a trial if the parameters are stable, because there is something called stable HELP syndrome, a fulminant HELP syndrome, and catastrophic HELP syndrome. A stable HELP syndrome is LDH, SGOT, SGPT are elevated, but the trend over 24 to 48 hours remains stable. And probably you can give a vaginal delivery trial, provided the fetal chances of survival are very, very low, or a patient is almost as present in labor and is about to deliver. So I think the decision is best taken by the combined anesthesia, critical care, obstetrician and fetal medicine team, but about the mode of delivery. But yes, definitely this case has to be handled at an institute level, because a small entity can go into multi-organ dysfunction syndrome, multi-organ involvement, which can be life-threatening.
Sir, your comment, sir.
Yes, as rightly said by both the speakers, I would like to add something. The pathophysiology of preeclampsia and HELP syndrome may be somewhat similar, they say. So the main thing is high risk of suspicion. Whenever they have upper abdominal pain,
Yes.
so that has to be taken into account. And second thing I will like to add is repetitive investigation. Every 12 hours they say you have to repeat and diagnose the progress of the disease. So if it is early, and so in a private institution they are going to deliver the baby, it's okay and fine. But as sir has said, if the disease is progressing, institutional management is mandatory.
So at what intervals you will keep on repeating the platelet count? Every 6 hourly or 12 hourly?
Initially, yes, you need to establish a trend. So every 6 hourly for at least 24 hours, and then subsequently you can do once a day, and then by then the fetal lung maturity is almost 36 hours to 40 hours, it's over. And then you take a call whether to continue further or just to deliver her. Because ultimately, one episode of seizure and a HELP syndrome, the definitive treatment is delivery.
Yes.
Stop the progress of pregnancy.
So, Nilima, what would be the method of delivery? Whether if it is normal, whether you go for epidural anesthesia or whether for cesarean section, what is the type or what is your choice for anesthesia?
If the obstetrician is planning for a normal delivery, the lumbar epidural is the choice of analgesia, because 2-3 things happen. Because of lumbar epidural, we give excellent analgesia so as to attenuate the pressure response to pain. Then it will reduce the circulating levels of catecholamines, and so the intervillous blood flow is very well maintained, the fetal well-being improves. And the third thing, we have a mean whereby we can convert analgesia to anesthesia in case of emergency cesarean section so as to avoid the general anesthesia.
So only risk factor is the low platelet count and hemolysis.
Yeah, there are some specific indications for general anesthesia. If mother is already having abruptio or she's having continuous bleeding, there is an abnormal coagulation profile, she's having pulmonary edema or altered sensorium, all these scenarios we need to give general anesthesia.
So in HELP syndrome, there is no contraindication for regional techniques.
If the platelet,
Yeah, always look for the platelet count and the trend in the fall in
Yes,
platelet counts.
that's
The trend is very important because suppose the patient's platelet count is 4 lakhs and has dropped to 1 lakh and next is 70,000. 70,000 is still not a contraindication of starting an epidural, but the trend in which the platelets are falling will be vary. But suppose if the patient's platelet count was 90,000, now it is 88,000, now it is 80,000, then yes, definitely there is a case where you can safely start an epidural. But rapid fall and the magnitude of fall both have to be considered. Because many a times you put the epidural at 70,000 and postpartum or intrapartum and subsequently it can fall to 30,000 or even 20,000, which is very significant because sometimes the epidural catheter removal is more hazardous than insertion.
Yes.
So patients can develop duraxal hematomas at removal. So you have to be very, very cautious. So rapid fall in platelets, I think I would refrain from using an epidural, but stable platelet count trend, then definitely you can put in epidural. But again, all these gray areas, always take into consideration the patient version also, because they may not opt epidural, they may go for alternate modalities also, which is justified in this scenario. So you need to tell the patient what are the modalities of analgesia that you have and give them the option, the pro and con, and let the patient decide. And if you want, you can give your influence or influence yourself from the patient safety viewpoint. But bottom line, don't compromise on the patient safety.
Yeah. So if any questions from the audience, yes, sir. Wangshi, sir.
This is a very common problem. What is your cutoff? I know it is a gray area when we say cutoff, but what is your cutoff of INR and platelet count for epidural, and whether to go for cesarean section with epidural or say with spinal? Of course, GA will be there, but I am only interested in, because regional technique is always better. Suppose the platelet count is something like 40,000, 60,000, INR is at higher side. So in this situation, and of course liver is again problematic. So in this situation, you will go for epidural or spinal or GA.
See, when the INR is elevated beyond 1.5 with low platelets and bilirubin also is high, then definitely no epidural. We have to be safe, as I said, from primum non-nocere. First of all, do no harm. Very important. Second thing is, yes, airway, difficult airway versus borderline coagulopathy. We know airway is going to be difficult in pregnancy, that too with HELP and preeclampsia. Single shot spinal is still a better choice if she comes for cesarean section. Because we know that a patient can have delayed recovery. One of the things which is very important in severe preeclampsia HELP syndrome is metabolic acidosis. If you do a blood gas, the base deficit will be more than -10, -12. And to an extent, this can contribute to delayed recovery. And majority of the time, these patients also are on magnesium sulfate therapy because by default, HELP syndrome, MAGSELF has to be started immediately. Because even with normotension, this is one entity where magnesium sulfate therapy is, you don't have to wait for imminent signs of preeclampsia for initiating MAGSELF. So the moment you have preeclampsia with HELP syndrome, without imminent signs also, magnesium sulfate therapy has to be initiated. So magnesium sulfate therapy, metabolic acidosis can all contribute to delayed recovery. So borderline coagulopathy, INR of around 1.5 with bilirubin of around 2, 3 and platelets around 70,000, I would still opt for a single shot spinal but not epidural.
Thank you, sir. Any more questions?
one
from
more point.
Harad Kedkar, sir.
What about giving FFP?
FFP,
Just if time permits, can we give FFP or platelet if available?
see,
And go for the regional as
again,
or epidural?
again, administering platelets and fresh frozen plasma for giving regional is not advisable.
Correct.
The safe is, if you are giving FFP, I presume that she has deranged coagulopathy and you want to correct for surgical cause, but not for giving spinal anesthesia. That is not advisable. So generally, platelet count of 70,000 is okay for surgery. We don't anticipate much of blood loss. We don't have to transfuse platelets because blood, again, all blood and blood components, they come with a rider of coagulopathy or blood transfusion related acute injuries, acute lung injuries, trialis, tachos, and sepsis and other things. So blood and blood components should definitely be reserved, but should be used judiciously, not just because INR for 1.5 may not warrant.
More than 1.5?
Yeah, if it is more than.
Can we give FFP and then after 2 hours?
That's what. Do not give FFPs and platelets for giving neuraxial anesthesia.
My question.
Yeah.
Yeah, please.
What's the role of thromboelastography or point of care testing? That will give you a better idea
Yes.
rather than empirically using these coagulations.
In fact, there
Platelet
have been
function
exten-
analysis. Platelet function analysis.
There have been extensive studies on thromboelastography and regionals. But again, thromboelastography, yes, it tells us the deranged coagulation parameters. But again, there are no studies where there is neuraxial hematoma and TEG is abnormal. There are positive case reports. So a normal TEG, probably you are safe to give neuraxial like spinal, but not epidural. So you need to go, more importantly, not by the reports. Look at the patient. Look at the clinical signs. Because as sir said, persistent epigastric pain. Is it subcapsular hematoma? Is it acute pancreatitis? Because we know that HELP syndrome virtually affects every organ. So persistent pain in the epigastric region, persistent pain in this could be beyond Glissen's capsule distension. It could be subcapsular hematoma of the liver and other things. And we have seen many, at least 5 cases of ruptured liver we have seen in HELP syndrome. So you have to keep everything in mind.
Yeah, just one question to Phadke sir.
I would just like to add one
Yes,
thing
sir.
because we are discussing about practical aspects.
Yes.
Regarding, as sir said, whether to do it in an institute or in a private. Many of us have experienced such cases in the private setup.
Private, correct.
So at that time, you must keep in mind the liver rupture and abruptio. These are the two dreaded things which can happen anytime.
And
So
DIC.
whether the institute is
And
geared
DIC.
to treat that and arrangement of blood and blood component, whether it is possible in your institute or not, whether the person and relatives are going to run for blood and everything, if that is not possible, better to shift in time rather than wait, because that is the crucial thing for treatment, and a backup of surgical team may be required for treating the liver part.
Okay. So if there are no more questions, we'll go to the next question. So this is press posterior reversible encephalopathy syndrome. Dr. Pandya sir can start with the opening statement. And
Yeah,
then we'll
if
discuss.
you press, is it a new entity or an old entity?
It's a
Yeah, I'm glad that so press syndrome has come into vogue with a defined parameters, the FLAIR and T2 weighted images because of availability of MRI. But press has been there on Earth since the time eclampsia and preeclampsia have been there on Earth. So basically, if you look at what is press, posterior reversible encephalopathic syndrome, it is basically breach in the blood-brain barrier because of uncontrolled hypertension. So with uncontrolled hypertension or acute hypertensive crisis, accelerated hypertension breach the blood-brain barrier, and there is vasogenic edema of the cerebral cells, which leads to blurring of vision and headache. And if you see imminent signs of eclampsia are blurring of vision and headache. So if you see all parturients who have preeclampsia with imminent signs, severe preeclampsia with imminent signs, you do MRI, you'll find press syndrome. So press syndrome is basically, we do it because now the availability of MRI is there, and the vasogenic edema are picked up on the MRI with FLAIR imaging. There's fluid attenuated images and T2 weighted images that gives a good contrast. So it's not a new entity. But definitely, yes, you have to be very vigilant because the vasogenic edema, if you don't treat the blood pressure, it can become cytotoxic edema, because whenever the blood enters the cell, the neuron, it can cause inflammatory cascade, and which can cause infarcts and arthritis, and it can cause cytotoxic edema, which can have lingering, long-standing effect.
So the question is that every patient with headache and visual disturbances, as you see in PIH, should go for MRI to diagnose?
No need.
Ah,
No
that's
need,
right.
actually.
So how do we do it at the nursing home level or even the tertiary level?
See,
That this patient
there is a
can go
possibility
for?
that, see, all patients who have blurring of vision, preeclampsia, they have some subtle press syndrome.
Yeah.
So you can, at the nursing home level, control the blood pressure. One of the significant important treatment modalities, keep the blood pressure under control. Systolic not more than 150, diastolic not more than 90 or 100, definitely not less than 80 also if the patient is antepartum period, because it can cause fetal distress. So you have to keep this parameters under control. So management of hypertension is very important, and prevention of seizure is very important, because whenever there is vasogenic edema in the neurons, the CNS excitability is high and the chance of seizure also are high. So prophylactic MAC-self also has to be initiated.
Yeah,
In
so
fact,
whenever there is
in
press,
indication, yes.
MAC-self has to be started.
Started.
Always. So madam, how do you progress if this patient with press comes for delivery, whether normal or cesarean section?
In small nursing homes, majority of the times the headache and seizures, if post-eclamptic, she completely regains her consciousness and they're taking up a cesarean section, we give neuraxial analgesia,
Yeah.
neuraxial block for the cesarean section. But if there is recurrent convulsions, in that case, we might have to give continued MAC-self along with some antiepileptic
Yeah.
or mannitol.
And manage the blood pressure. That is the basic bottom
Management
line.
of blood pressure is the crux.
Yeah.
It has to
Yes,
be
sir.
done.
Again, the same way I will talk it differently.
Yeah.
Understand the pathophysiology.
Correct.
It is the exudate which occurs in the brain is because of hypertension. So need to control the blood pressure to avoid the edema and subsequent press. So it should not be too rapid also, because that can have ischemia of the brain. So controlling of blood pressure in a proper way.
In a gradual way. So any role of mannitol, furosemide, dexamethasone to get the ICP down?
Unless the patient has intracranial bleed
Yes.
with mass effect, there is no role of mannitol, there is no role of steroids, and there is no role of diuretics also.
This is the take-home message. No role.
So just give antihypertensives, again not profound hypotension, avoid hypotension, because we need to maintain perfusion of the gray areas, gray zones in the brain, very important. So antihypertension, the drugs of choice are labetalol and nifedipine, but not sublingual nifedipine. But see that antihypertensives are given, and magnesium sulfate is given, because magnesium sulfate is an excellent medication. It has a membrane stabilization effect and also prevents seizure.
So any questions from the audience? You can continue. Yeah.
Even if MAC-self is given, sometimes the patient convulses again.
Yes.
And in that case, we might have to give mannitol, because there is continuous irritability, refractory hypertension or recurrent convulsions. They are not getting controlled with MAC-self. In that case, mannitol is required, and it is required in very high doses.
Okay. Any questions from the audience? Yes, ma'am. Nicardipine.
If we look at
Nicardipine
the
is
management of recurrent eclampsia or status eclampticus, probably I differ from my panel co-panelist, but basically, if the patient, while on magnesium sulfate, has a seizure, again one more seizure, the drug of choice again is escalate the dose of MAC-self. Generally, we give 4 grams of loading dose and 1 gram per hour as an infusion. And many a times we have checked magnesium level at the end of 12 hours and 24 hours because the patient is oliguric, and we have found that the magnesium level, hardly they attain any therapeutic level. So there is always a scope of escalating the dose, give another 2 grams loading dose, and step up the dose of infusion to 2 grams per hour, as long as the clinical safety profile is maintained. Level of consciousness, the respiratory rate, the urine output, and deep tendon reflexes. If all these 4 parameters clinically are fine, you can safely escalate the dose and step up magnesium sulfate. Alternate anti-epileptic medications are indicated only if the patient is anuric, or if you have a complex seizure or a partial seizure, or as madam said.
Yeah.
And think of
Okay, madam.
differential diagnosis.
Any questions from
Alternate
outside?
diagnosis.
If
Yes,
there is a thrombosis or some such thing, you go for MRI immediately
Sango.
if the convulsions are not stopped.
I always have this question. Patients with convulsed in a peripheral area and have... Sorry, so the patient is convulsed in a private nursing home, and the obstetrician gets the patient to the tertiary center, and we get a call saying that patient convulsed, we have to take up immediately. So what is the correct interval between these events? How soon should we take up, or how should we...
Yes, it is very important, because post-convulsion, post-tonic and clonic seizure, if you run the CTG, it is always the beat-to-beat activity is reduced and type 1 decelerations are common. But eventually, if the hemodynamic stabilizes, the fetal heart rate also stabilizes.
Yes.
So based on that momentary transient CTG abnormality, there is no need to rush the patient for cesarean section. But yes, we see that post-seizure, the post-ictal phase persists for 30 to 45 minutes. And generally, if the patient comes back to alertness immediately, if the alertness doesn't comes back after the seizure, then you need to look whether it is any Press syndrome or any bleed or any of those things. You look for a bedside clinical assessment, CNS examination, look for any lateralizing sign like 6 nerve palsy is quite common, especially this intracranial pathology or any severe cerebral edema. So you just have to look for those things, and then ideal time can be decided based on clinical condition. But yes, at this moment of time, if the fetal jeopardy is happening, continuous fetal jeopardy, then yes, risk versus benefit, you may take a patient under general anesthesia. I would give spinal, provided the GCS is 15, there are no lateralizing signs, patient is alert, conscious, and clinically fine, stable.
Fantastic take-home message.
I've seen certain anesthesiologists, especially the juniors, convulsing patient. In a convulsing patient, the immediate reaction as an anesthesiologist, they start giving midazolam and thiopentone or propofol, whatever comes in their hand. I think this is where we should try to avoid.
Yeah, I think you made a very good point,
Fantastic
Indranee
point.
madam. See, there is no role of polypharmacy. Polypharmacy will herald the onset of respiratory depression. By the time you wrote midazolam and give thiopentone, yes, seizure ceases. There is no need to give. We are giving magnesium sulfate not to treat the current seizure, but to prevent the subsequent seizure. Yes, thiopentone to an extent abolishes the current seizure also. But what happens is by giving those potent central CNS depressants, you are causing the risk of aspiration increases. As such, with tonic and clonic seizure, the risk of aspiration is there. And with this, you are further jeopardizing the airway, and you may compromise and patient might aspirate. So there is no need to give midazolam, no need to give thiopentone. The only indication for midazolam or thiopentone or propofol is recurrent status eclampticus, seizure after seizure. And probably that case, as the podcast said, sir said, we have to screen for MRI and do think beyond eclampsia.
Okay. Any more questions?
I have
Then we can-
six nerve palsy. I remember one case. I had put an epidural and waiting by the side of the patient. She was to be delivered in maybe 2-3 hours or so. Suddenly the sister came and patient said, "Mala asha kaitri vega distay." When I checked her, one eye was straight and one eye was moving. There was a six nerve palsy.
Henua.
And within 5-10 minutes, she converged in front of me. Immediately, I had to put Maxelf and
Yeah.
Sunil,
she was
we
not
This is
hypertensive
one more
at all.
good take-home message.
clinically presumed to be pressed, but we did see some CVST and some ischemic infarcts as well, especially maybe in post-COVID times. So do you define particularly which is the right time for MRI or what clinical signs will drive you to go for MRI?
The ideal neuroimaging for all patients who have seizure or any of those neurological disorders like seizure or press or this thing is MRI with MR venogram.
Yeah.
And generally MR venogram is important because MRI can sometimes miss out deeper infarcts, and MR venogram can pick up those deeper infarcts also. And plain CT scan will not pick up anything. And plain CT scan is useful only for quick differential diagnosis, like massive intracranial bleed. So the sensitivity is otherwise, if you are doing MRI, CT is normal and patient is still drowsy, just don't sit idle because the CT is normal. Just take the patient. Once the patient stabilizes, I'll always have an MRI. So ideal time interval is at least once the patient stabilizes, get an MRI done. MRI with MR venogram.
Venography, that's
Yeah.
Okay. So if there are no questions, we'll go to the third question. So this is the perimortem cesarean section, and this is a very dreadful condition. One must not face it. I have not faced it. If anybody has faced it, let's share the experience. We'll start with our Panda sir. Please say about what are the AOA guidelines present, ACOG guidelines, which is recommended.
Like if you look at 1970s and 1980s terminology, is perimortem cesarean section is
Yes.
little morbid terminology actually, and it's an archaic terminology because you are doing a cesarean section in a dead parturient. So in 2010 onwards, the resuscitative hysterotomy was the terminology that came into existence. That means resuscitative hysterotomy because perimortem cesarean delivery is a part of ACLS in pregnancy.
Yes.
So if you cannot achieve ROSC with your aggressive BLS and ACLS within 4 minutes, then 4th minute begin your cesarean section, 5th minute deliver the baby, and that is what is resuscitative hysterotomy terminology came. But from our experience, we have had 12 instances of PMCD in our center, and we found that quite often it is not just mere hysterotomy or evacuation of products of conception, but it has ended up with either internal ligation or peripartum hysterectomy or B-Lynch or any of those intrauterine, extrauterine procedures. So we, as a task force guidelines, we introduced the term resuscitative, resuscitative uterine interventions.
Yeah.
So it could be anything. It could be hysterotomy, it could be hysterectomy, peripartum hysterectomy, or any of those this thing. But remember that perimortem cesarean delivery, you should not encounter, but if you encounter, then don't waste any time. You have to go by clock. Every second is precious. Effective BLS, 1 minute, and within 2nd minute, patient has to go to ACLS, and within 3 minutes of ACLS, if you're not able to achieve ROSC, 4th minute, put knife, and 5th minute, deliver the baby. Because if you follow this 5 minutes rule, the survival chances are pretty good. Almost about, I would say, 60% of women can have a healthy child as well as a healthy brain. That's what we want. Effective cardiocerebral resuscitation.
Ma'am, you want to add something? Because our experience
have
with
any
this is very limited. I mean, sir has the maximum experience amongst us. Any questions from the audience on this part?
How you are going to counsel the relatives after this?
That's more.
See, one good thing is when they see the hangama and all these things, they also understand that something is wrong. And it's very easy. Like as I said, 12 patients, none of them had any, we had any difficulty in counseling. But yes, when you sacrifice the uterus in a primary gravida with IUD, then it becomes difficult. We have one patient I remember where patient amniotic fluid embolism, primary gravida, we had to sacrifice the uterus, dead baby, young couple, just 1 to 1.5 years of married life, and we had to counsel the family for adoption. But they were very good actually. So those are the scenarios which comes by experience, and you have to counsel them left, right, and center. But one thing you have to remember that when you are doing perimortem cesarean delivery or resuscitative hysterotomy or RUI as we have coined, there is no need to take consent at that moment of time.
Okay.
There is
Very
no need to
important
take
message.
consent because by default, consent, you are obliged to do this procedure. In fact, you
save the
can be
baby and
liable medico-legally if you don't do hysterotomy in this patient because it's a part of ACLS in pregnancy.
Fantastic, sir. Very good take-home message. Anything,
What I think is that we should think about what are the causes of maternal collapse. If it happens in a hospital scenario, everything
okay.
is good. At 4th minute, you have to take the decision.
At home is
if
difficult.
If it happens on the street, nothing is useful.
Nothing can be done. Yeah.
Only thing for resuscitation of the mother.
The mother is the most important.
Mother is important.
More important.
No, but see, baby is already gone, but we are doing resuscitative hysterotomy for mother,
For the
not for
mother.
the baby.
So the message is that we are trying to save the mother and not the baby.
In the process, the baby also can be saved. But primary objective is to save the mother.
Correct.
Just because the baby is dead, it's okay. No. Because we know that the preload in a gravid uterus is reduced. Unless you remove the baby and debulk the uterus and pull the uterus away from the IVC and aorta, the preload is not going to happen. And we know that uteroplacental bed almost has 2 to 2.5 liters of blood. So the moment you deliver the child, baby, almost 2 liters auto transfusion happens, and that's what kicks and achieves ROSC.
Yeah.
So that is very important.
Okay. Next.
How
question.
is your experience about reciprocation from obstetrician friends?
That's exactly. You need to do drills.
Yes.
I
Mock
put
drills.
in my previous slide. So regular drills and regular CMEs and workshops, definitely they also come into they are on the same page and they sync with you.
So
Okay, if
counseling.
there are no questions, we'll go to the next last question. It's about COVID-19. Of course, COVID-19 is fading away, and with cesarean sections, many of us has faced this with COVID-19 patients coming for cesarean section. Next session is, of course, on COVID. So, sir, just a few lines each can say your experience with COVID-19 and cesarean section.
Thank you, Dr. Jai. Thanks to the vaccination, these protocols and guidelines and whatever.
Thanks to Pune for vaccination.
Vaccine, yeah, that is true. We are here.
And Hyderabad.
Good line of
And Hyderabad.
Nobody wearing masks and sitting together. It's a good thing to happen.
Hyderabad have been up for vaccines.
Yeah. So most of the data comes from 2020, And nothing has changed much so far, because whatever I was searching for the literature, most of the data comes from 2020 only, even not from 2020. Nothing has changed much. Of course, the variants has changed. Initially, it was a Delta. It was a very
Virulent.
dreaded disease process we had. Coming to COVID and pregnancy, per se, pregnant patient is not susceptible to acquire COVID compared to other population. But there is increased chance of complications, COVID-related complications. Progress is more in pregnant patient, and pregnancy-related complications are more in a patient who is COVID positive. The COVID per se, it doesn't cross the placenta, the virus. The drugs, steroid, NSAIDs, and monoclonal antibodies, there is no contraindication to administer in pregnant patient if it is indicated. Then COVID is not an indication for LSCS. Patient can progress with early labor analgesia is recommended, because chances of emergency cesarean will be tackle will be easy. Then if the patient goes to LSCS, there's of course any surgery in a COVID positive patient, chances of complications are more, that you have to keep in mind. For cesarean section, a dedicated OT has to be arranged. It should be a last case or some such things. Then minimize the staff moving inside the OT. Neuraxial anesthesia is preferred. Early epidural is preferred. Thromboprophylaxis, you have to have a very low threshold. Whatever obstetric condition, if it is additional there, go for thromboprophylaxis, definitely. Then transit precautions to be taken, like a fluid-resistant mask put on the patient's face while traveling from ward to OT and afterwards also. Then there is another concerns of care of healthcare personnel. So proper PPE kit, N95, everything is known. Preferably GA is to be avoided because it is transmission is more. But if in case if required, and even during neuraxial, you have to be ready with a backup of GA. Rapid sequence intubation, avoid AGP procedures like LMA, and don't ventilate till the cuff is inflated properly. Two virus filters to be applied, one to the machine, one to the endotracheal tube before intubation. Actually, you have to apply directly to the tube and intubate. So even if the patient coughs on the tube, the expired air will be filtered. Double glow, avoid auscultation, check everything on capnometry. Care of machine and proper doffing and sterilization process of the OT. That's what I conclude.
Thank you so much. Anything you want to add, sir? Sir?
I would just share my experience. The COVID one, fortunately, was nothing much happened in the pregnancy except they tested positive. But yes, because of the protocols were just emerging and nothing was clear, most of the patients ended up with cesarean sections for COVID season 1. Season 2, yes, we were more aware, we were more educated, and our vaccines were just being the level 2, phase 2 trials were on, or still not in pregnancy. But importantly, we saw a lot of severe cases. Yes. We have had patients with prone ventilation, we have had patients with ECMO, we have had patients requiring, one patient requiring lung transplant, ECMO and lung transplantation succumbed, unfortunately. But again, we saw, at least I remember 2 cases of pulmonary embolism and 4 cases of CSVT also, thrombotic complications. So phase 2 or COVID season 2 was very dreadful in pregnancy. And fortunately 3, and now it's again back to normal, I would say.
Decision of cesarean section was a conflicting.
Yes.
Yes. See, whenever the PF ratios of more than 250 are not able to achieve with PEEP of 10 and plateau of whatever the best ventilated parameters are giving, then terminate the pregnancy. Because it is definitely going to help in terms of recruitment and also in terms of proning the patient. Because once the pregnancy is beyond 24 weeks, complete proning is possible only when you terminate the pregnancy. Otherwise, you need to keep the patient elevated. Now you have these prone pouches and prone beds available in the West, where there's a shallow support and this thing. But again, those things are still experimental, not much of studies. But if you feel that PF ratios are not improving, mother is important, terminate the child. In fact, 2 patients we had in swine flu, we had connected on ECMO and we delivered the babies on ECMO. Of course, they had a lot of bleeding and other things, but both of them survived. This was swine flu time. COVID time, ECMO patients have not survived, in our center at least.
Yes, madam.
I want to ask one question to Dr. Phadke sir or Dr. Pandya. Was there any high incidence of thromboembolism in pregnancy because
That's what I
of,
said.
yeah, and second is what about the mucormycosis? Have you reported
Yeah,
any?
fortunately, mucormycosis in pregnancy was, I have not seen a single case.
Yeah.
I don't know why, but
Summer pregnancy you have not seen.
second wave, we saw a lot of thrombotic cases, like pulmonary embolism, 2 cases, and 5 cases of CSVT. Generally, with CSVT, we see 1 or 3 cases, 1 to 2 cases a year. In this season of 4 months, we saw 5 cases. That means definitely was very high.
Okay, so with the want of time, I'll end these sessions. So I thank all our panelists. This is not moving again. So the next session is COVID. So I thank our panelists, Dr. Sunil Pandya, Dr. Nilima Gandhe, and Dr. Satish Phadke, and of course, all honorable members of ISA who participated in this panel discussion. I'm sure you must have taken away good take-home messages from this panel discussion. Thank you, and I hand it over to our chairpersons.
Thank you all the. I now request the chairpersons, Dr. Shalini Sardesai and Dr. Jyoti Gai, to felicitate our panelists, Dr. Nilima Gandhe, Dr. Sunil Pandya, and Dr. Satish Phadke.
Check. Check.
I request Dr. Milind Belsare and Dr. Shripad Gokhale to felicitate our. I request Dr. Milind Belsare and Dr. Shripad Gokhale to felicitate our chairpersons, Dr. Shalini Sardesai and Dr. Jyoti Gai. I request Dr. Shalini Sardesai and Dr. Jyoti Gai to felicitate our coordinator, Dr. Joy Shankar Jana. I now hand over the mic to Dr. Rohit for our next session.
Good morning, everyone. Everyone in this auditorium is well aware about the terrors caused by novel coronavirus, and we have learned many critical lessons regarding COVID pandemic with respect to rapid response and large-scale surveillance. To shed some light on the COVID-19 issue, we have our next session on COVID-19 lesson learned from the pandemic. I call upon stage Dr. Harshad Dongre to hand over the proceedings for our upcoming session.
Good morning. As all of us know that we have faced the worst nightmare of our life, the COVID-19 pandemic, and still we are not over with it yet. To discuss the lessons learned from the pandemic, I will like to call on the stage our chairpersons, Dr. Surekha Shinde ma'am. She is Professor Anesthesia and Critical Care at BJMC Pune, and Dr. Yogesh Gavli sir. He is also working as Professor Anesthesia in BJMC Pune. Thank you.
happy to know that Yogesh will be working in BJMC as my co-professor. All the best to you. Hope it comes true.
I request our chairpersons to kindly introduce the speakers for this session. Our first speaker is Dr. B.D. Bande, sir.
It's a norm to say that this person doesn't need any introduction. But for Dr. Bande, I think this holds very true. So everybody in the audience must know Dr. Bande, isn't it? If he has to stay in Pune, right? Yeah. So he's our senior consultant. And the peculiar thing about him is he's done MD anesthesia, MD medicine, and intensivist. So 3 chairs to him for 3 faculties. Okay. So he's senior consultant. Now, see, they have changed because everybody knows your introduction. So currently he's a senior consultant at Noble Hospital, and he's done a lot of work in COVID. So for today's session, I think COVID work introduction is more than enough, right? Thank you. Over
Even
to you.
otherwise, it is more than enough. Okay. Thank you so much. And being on the center stage for last 2+ decades, and I don't think I need to elaborate on that. Thank you so much for this thing, introduction, as well as how to move the slides.
See the extensive
Which one? This one.
slide.
All right. Thank you. So when the program was shown to me, I was little unhappy because I said last 2 years people have been talking on COVID and again COVID for another half an hour to 45 minutes. But I asked Saroj, who's been my wife, attending the meetings. I said, is it okay if this topic is not there? So no, scientific committee had decided. I said, what is my topic? Said, preparedness, pandemic preparedness. I said, I've been working hardcore intensivist for last 2 years, still been working. It is better to have a therapeutic topic, but this topic doesn't suit. Then I said, who is the scientific lead? She said, I am only the scientific lead. Shanti. No arguments. So I accepted the topic, but then I made another attempt and I asked Pradnya whether this topic can go to somebody. Professor Borse, who is my classmate, professor of medicine in Vijay Medical College. He's into administration, so why not give this topic to me and I take more important therapeutic topic to me. That failed because I think he wanted to enlighten us on drugs, which we'll be doing later on. And the other choice was to displace Tanima and give her that topic. I said, no, my student, brain and beauty, I can't make her naraz. So I didn't make that attempt and accepted topics of pandemic preparedness. So then I looked into and I started looking into, because theme is lessons learned from experiences. So I said, have I done anything for preparedness? Then I counted, and first time I jotted, I had a big list which I'll share at the end of the lecture. But preparedness has been there for ages, and as I will go through the slides, because preparedness is something which we needed, and whether it helps or not, time decides. Basically, preparedness is one step to curtail the consequence of this. Just to declare, I have been a scientific advisor to one of the ventilator makers in Pune. That is the small conflict of interest without any financial interest as such. Now, nobody in the audience would forget that this particular face, which kept on coming on television as well as in the news, is Anthony Fauci, who is the director for last 40 years in the National Institute of Allergies and Infectious Diseases from United States of America. And he served during all these big list of 7 presidents, and he continues to serve, and he's decided now that he will step down in December. Why this slide? Because in 2001 and 9, in that period when George W. Bush was flying with him for one of the projects of some infectious diseases project in US, so George W. Bush asked him, what is the threat in the future, what will be there? So that time on the flight, Professor Fauci told him that influenza, which is there, endemic in the United States, but some infectious variety might come up in next 10 years or something. So that was the first guess probably made. And what I'm trying to say, this is the preparedness in the United States has been tremendous, and they have been preparing on this. And you can see the list of viral diseases, which he himself has been in 1981 when he came across first HIV virus, he started working right at that point. And there have been many other diseases like anthrax, Ebola, Zika virus, and West Nile, and all the mutations of the influenza virus of the H category. And ultimately, we had H1N in 2009. So they have been preparing for all these diseases. I do not know whether there is a bioterrorism angle to this, but they have been going on studying this particular. And look at the budget. this particular one institute out of 27 under NIH, what is called a National Institute of Health, US, this is one of them, and budget is 45,000 crores annually for this year, which is equivalent to BMC budget, Bombay Municipal Budget is this much. And total budget of NIH is 7 times the total budget of our country budget, $2,800 billion. That's the amount these people are spending on research, preparedness and all that. So that was the background for this. These were the epidemics which came, and US has been leading in the research on this, and obviously we all have been benefited by some or other way. Nothing to enumerate about this. But all the preparedness, and look at what happened. America led the total number. They recently approached 1 million, that is 10 lakh deaths, despite of so much billions of expenditure. So Professor Fauci was a few months back asked by one of the anchor on the television, we have spent billions and billions of dollars, could not save these 1 million people, what do you want to say about it? He said his answer was natural. At least we could save others because we spent billions. So maybe we need to spend more. That's what his answer was. So there's no limit to expenditure, and despite of the best of the preparations, best of the resources in the United States, the tally of death and maximum per million population. And look at the China, whether they declared or whether they did not have, the total number of declared patients equivalent to the deaths that the US has faced. So we do not know what is happening in China. China is still closed, it's still not open. Everything else is opening, but China is not opening. People are not going in, not coming out. So when did the preparation, you will get surprised that 2014, one of the speeches by Dr. Barack Obama, the US President, he said at that time, 6 years before we faced the pandemic or epidemic, he said we have to be ready. I do not know why these people are predicting and then not able to even achieve what they want to achieve. So he predicted in 2014, US to prepare for pandemic back in 2014. And he kept on saying that, and he obviously observed that we have to be ready for the pandemic and more preparedness also, etc. So, but it was in 2015, and it was very surprising that in one of the TED Talks when Bill Gates, you can see the picture. This in 2015, we were not even aware of this picture. 2015, he came up with this. He said, which is the worst threat we are going to have. He said, not the nuclear weapons or all that. It is going to be one of the infectious virus in future. And he predicted at that point of time, prediction was coronavirus is going to be the prediction. So we don't know what exactly goes on in the minds of these people, and he predicted it 5 years before the pandemic actually started, and it's going to be highly infectious. He said at that point in time only. Okay. So, but we have actually invested very little. So his point was invest more on this, be prepared that this is going to come anyway. So I do not know how they had this, and of course the last pandemic was over 104 years before, that is in 1918, having these kind of deaths. So when Bill Gates said this, and there was a rumor that whether Fauci and Bill Gates are actually having investment in China, in Wuhan, where this virus came from, and another thing was remdesivir, which Professor Bose will touch upon. That article came as remdesivir drug in search of the disease. It has been tried for hepatitis C. They tried for Ebola, not much of a success. Now they are waiting, the Gilead, which is the company, which wanted to test it for corona. They did not have much success, but eventually FDA approved it, and we are all been using it. So vested interest versus predictions versus preparedness, it's a complex subject. So this was the rumor, and even it was rumored that these people have interest, vested interest, and whether they are the part of bringing in this kind of epidemic. So that's a part apart, but this was in 1997. This paper came in 1997, and there also they said prediction for human influenza pandemic is quite likely, H1, H2, and all those H. So people had all predictions about this, but we still could not save people which are gone. Anyway, going further, epidemic triad, this particular coronavirus, it fitted everything into this. Preparedness is one thing, but highly infectious, susceptible host. We had obese and diabetic people with hypertension getting more affected. And I believe that in America, that is probably one of the causes. I saw, especially in second wave, when we were treating Delta variant, a lot of young obese people died in front. We could not do much. We did not have much knowledge about how to save these people, and the exudative reaction was so bad that no ventilation or modality could save them. And of course, agent reservoir, and it is ubiquitous that it is everywhere, including air, which was declared by WHO later on that it is airborne. So which was denied in the beginning. So why do we need preparedness? Of course, there's unpredictable situations can come up. A lot of emergency situations happened, especially in second wave. We were helpless to see that people were dying on the road without oxygen. We did not have adequate resources to treat them. But faster responses, quick control were achieved, and government had appropriate policies in place at all the levels, right from WHO to local level. But resources of shortage was there in second wave, I must say. Subsequently, of course, we were much better prepared. So preparedness strategies are very obvious. I don't know to elaborate because all of us have been into that right from the beginning. So anticipation, prevention, detection, control, and management, and minimize the impact. So what were the levels? Right from WHO, WHO always remain into problems because of its conflicting statements coming every now and then. And I think we went by little pinch of salt, and of course we applied what we felt is appropriate. Government, local bodies, hospitals, and community, and to the citizens. Basically, each level there has to be a preparedness. There is no doubt about it. Now, all these agencies will be there, and all this kind of levels will be there. There will be governance. There will be health workforce. We had task force. We had rapid response teams from the central government, and of course technology to detect, to diagnose, and of course to manage also. Health delivery was there. Well, what we go by, we did need some regulations, legislations in place, because we cannot have, unless there is some kind of control from center, we cannot have. But these kind of acts were already there, and partly they were invoked whenever necessary, because in March 24, 2020, we had the first lockdown at national level. So what did government India do? They did anticipate, because you remember before March lockdown was in, they already started having evacuation from China. The students were evacuated, and of course that was anticipation that we need to protect our people and bring them back, and of course we'll look into our this thing also. That evacuation was the beginning of the whole process. National task force was there. Ministry of Health and Family Affairs, they came with guidelines, legislations were there, first lockdown was there. Then of course funding was done as per their allocations, whatever it was, what was available. And of course the best breakthrough was the vaccine, and which Sunil already mentioned about it. We had Covishield, Covaxin, and even Sputnik brought in later on. So all three were there, and their allocation was done appropriately, those who needed this thing. So that was a good preparedness. So vaccination really, this was the first evacuation on 1st of February. China tried to play some trick, but then of course they were brought in, and there I think quite a few flights. This is the first flight where 324 people were brought in. India, mostly Indians, but there were a few Maldivians, etc. So were there. So National Task Force obviously had their own role to play. Preparedness went on very, very on the higher level kind of a priority. And I don't want to go through reading all this, but task force was needed at every level. We had up to district levels basically, and local level also was there. So each district had their task force in even in Maharashtra, including the state level, and we kept on listening on the webinars. So various kinds of interactions took place. Government also had a lot of public awareness programs for this, to make people aware that something dangerous is coming, and right in the beginning they had a helpline numbers, etc. And they also kept on declaring what are the number of cases, what are the vaccinations achieved, what are the deaths, the bed availability, etc. was also communicated. Even Pune, they tried to have a dashboard where availability of beds there. It did not work completely, but it was a guideline, and of course to some extent it helped us. So the worst was obviously the second wave. As you can see, May 21, of course the first wave was there, and the worst mortality and the number of cases were in the second wave, and that was a tough time for all of us, we know. But we were reasonably prepared at that point. We never expected that the number will be so outnumbering our abilities, but still we were reasonably prepared. Now, after second wave, of course, there have been spikes, third and fourth wave, people define them, and these are the kind of graphs or numbers of the cases. Third wave, Omicron was there, and it was less infectious, less severity, etc. So we were better off by that luck. Now, what was Pune doing at that point of time? In Pune, obviously, corporation, there was one group of hospital owners, CEOs, doctors, IS officers, and maybe a few of you must have been on that group. Dr. Saleh was in that group. Pune PPCR, that is called as Pune Platform for COVID Response, and that played a big role actually, and it was a good preparedness from their side, where they kept all 7 IS officer top division, like from divisional commissioner to CEO of JDP, they were all on the group, and they were continuously giving feedback from the professionals like us, and of course hospital administrators as well. And second wave, of course, we had this kind of a preparation: 18,500 beds without oxygen, 7,500 oxygen supported beds, 1,100 ICU beds, and 850 ventilator beds. And I remember Sasana Hospital, Dinanath, Noble, they laid the whole list, and I think at Noble we had about 55 ventilated beds, and the preparedness was Dr. Saleh took an instant decision of spending 2 crores and buying 15 ventilators right away. That was during second wave, so that kind of preparedness I think every hospital went through, and we were reasonably prepared. The third wave, there was little scare because children will be affected more. That was a scare. So actually, it didn't happen luckily. But in fourth wave or whatever ongoing, when children are getting little more, though not very acute, but children seem to be getting affected more. At national level, of course, we always had a national disaster management team. This kind of plans were already in the place for third wave, and one good thing which government did was there was a staggered opening. People opened themselves because after first wave, Gram Panchayat election, Diwali, and all the weddings, etc., took enough, and probably that helped to generate some herd immunity. Retrospectively, we can say that because our second wave, though it was bad, in third wave, probably some effect of that kind of herd immunity might have been there. That is a guess. But staggered opening probably helped us to have. And of course, we had basic precautions observed everywhere. That is a part of preparedness and prevention. Those were also there. And as I said, best part was the vaccination. So these kind of informations kept on coming. Basically, we didn't need to go into details of other things. And this was another thing, because sequencing was essential, because we need to know which virus is there, so which vaccine will be appropriate. That will obviously be helping us even in future. So we had a sequencing, and accordingly we had so many other aspects to be learnt about that. So as I said, last minute I will tell this, and I started pointing out to myself what preparedness I have done. So when I was in KM in the first wave, we tried to have some preventive policies, which hospital did not accept later on for some reason. But patient care, of course, some cesarean sections were there done at that point of time. Many patients came for this thing. They were not diagnosed, there were no testing, but just because of clinical symptoms, we took a lot of care. Of course, we were flooded with telephonic advices from all the corners, just because everybody was in so much panic in first wave. Telephonic counseling, even doctors needed to be counseled at that point of time, because doctors at periphery did not take much part in first wave. So that gave me opportunity to, the second wave was imminent for sure, and unfortunately for us and unfortunately for US, the second wave preceded our second wave in most of the Western countries. So that was definite indication, and this question was constantly being asked by even non-medicals, is the second wave going to be there? And we said, yes, it's going to come, because it is there already in the Western. So second wave, I had a chance to communicate with most of the peripheral intensive care colleagues who were practicing like at Lonand, Baramati, Shirur, Daund, Sangamner. So I had a lot of people, and I said, hey, see, if the second wave comes, it is very bad in US. So we're going to have more numbers. We need to have more ICU beds. So accordingly, I had a opportunity to talk all of these people put together, and about 500 ICU beds were added, and they were ready to do that. Later on, they were happy because it gained them a lot of opportunity, as well as economical benefit was also there. So 150 additional beds were created around the Pune city, so that decreased the load which is coming in the city, anyway, which were very short in the beds. Public meets and this thing, because I was involved in this creation of these beds peripherally. Shantilal Mutha, one of the notable socialists, took me to Sangli for some giving lectures to other people how to prepare, etc. So I took part in that also. In hospital, Dr. Saleh gave me opportunity. We had expanded ICU to 75 beds. Out of that, 55 beds were ventilated, and half of it was under my care. So that was also continuously being going on. As I said about Pune platform, it was already there. And ventilator, I got opportunity to devise a ventilator with my friend with that company, and which is actually reasonably a good, this thing, 500 of them already said. It's a modern ventilator, you might see in some conference. And of course, we had some publications from Noble Hospital where we tried to communicate and tell, especially about tocilizumab. Recently, question was asked whether tocilizumab could be used in H1N1, which was currently prevailing. It is still going on, actually. So I discussed in national group that we are using, because we thought it is COVID, we used it, we found the response is there. So I convinced them there is no scientific evidence whether tocilizumab can be used in H1N1 ARDS, but corollary is there. We had similar ARDS. So that paper is yet to come, but these were 2-3 papers from our side. So are we going to go be prepared really for future? That remains a question, and I do not know the answer. But most probably we are not yet prepared. We do not know. These people are predicting years before, but still failing. We do not know what is kept in future for us. But to summarize, we were not adequately prepared despite clear warnings years before. As you can say, Obama, whether it is Fauci or whether it is Bill Gates, etc. What is possible to have lesser mortality? Probably yes, because we tried in that direction, including vaccination probably saved us. At all the levels it was there. And second wave due to Delta wave was a nightmare, basically, in that we were not really prepared for it. That should remain in our mind. That something of that kind comes in, are we going to be really prepared? And we need to be better prepared, basically. Vaccinations probably will continue, and in the United States, every year there's a new vaccine coming, and flu shots, what they call it, as every year it is given. Influenza mortality up to 50,000 per in US is continuously on. We don't have that. In our case, it is only the pediatric age group patients who receive flu shots. And my answer to this is we are not really prepared, and we need to have better. And preparation is not only at WHO level, but it starts at the citizen level. And as a professionals, we have a larger responsibility to continue our efforts in that direction. Thank you so much. We have a conference at Jalgaon. It is a critical care conference, and there are a lot of workshops. If somebody is interested, Dr. Haran Khedkar is here, so he can help you for the registration if you go on. This is ISCCM State Conference. Thank you so much.
I request chairpersons Dr. Yogesh Gauri and Dr. Sureka Shinde ma'am to please felicitate Dr. Bande sir. I call upon stage Dr. Harshit Dongre for our next session.
Any questions for Bande sir, or we'll take it at last, ma'am? Okay. So for next lecture, I would like to invite on stage Dr. Tanima ma'am for use of HFNO in COVID-19.
Good morning, everybody. I'm glad Dr. Bande addressed the topic of preparedness because honestly, there were state, national and international task forces looking into this matter, and stalwarts like him are just the right people to address this. I'm a humble worker who worked at the ground level, and so probably this practical topic is more suited to me. And of course, I would like to credit all the people here who've been on this job. And of course, we have our chairperson, I have our esteemed Khedkar madam, Bande sir, and I think every one of you have been involved in the management. So I'm sure all of y'all have your own insights on this topic. And कशाने करायचं? आणि इथे तर दिसतच नाही आहे असं. तिथूनच करायचं का?
Actually, our speakers are not giving us the opportunity to introduce themselves. I think that they are such people from task force. They directly go on to task, like all anesthesiologists are,
I'm so sorry. I mean,
no, it's good. Actually, that's our motto, and that's our
work, I guess.
That's our training. Yeah, she doesn't require any introduction, but that's our training, as anesthesiologists. So, lage jao, bas.
I'm so glad I'm following your legacy.
I'm good about that.
The green one? Yeah. So let's begin now. COVID-19 took the world by storm. And it took the entire world by storm. And even though the tidal wave or the tsunami is really behind us, I think the ripples of it are still being felt by all of us. And it was a very trying, testing time. And innovative and lateral thinking became the key in that period. And yes, of course, there are a lot of lessons that have been learned and which will hopefully hold us in good stead in the future to come, maybe for the other pandemics that are in store for us. And also, it did something good that it brought the anesthetists to the forefront of clinical care. People sat up and took notice of the responsibility that anesthesiologists hold. And so 3 cheers to that. And now let's begin with our talk. I'm not getting into the real details of the injury that was caused by COVID-19. Of course, we did see the typical features of lung injury and ARDS, but there was something specific to COVID-19, and that was that there was a systemic vascular pathology which differed from conventional ARDS, resulting in substantial endothelial damage with micro and macro emboli formation, which was seen in diffuse thrombi, which would affect any organ system because of this process. Let's quickly have a look at hypoxemia and the pathophysiology of it. Hypoxemia is usually caused because of either VQ mismatch, and the point to note would be that increasing the concentration of inhaled oxygen generally improves this condition. And the other pathophysiology is, of course, shunt, where blood flows from the right side of the circulation to the left side without really coming in contact with oxygenated alveoli. And the hallmark of this pathophysiology is that it's extremely poorly responsive to increased levels of oxygen. And now let's see a new term that got coined in this COVID era, and that was happy hypoxia. And what was this? Usually, the COVID patients, when they came with typical features of flu, had fever, had body ache, anosmia, taste getting affected, diarrhea, URTI, common features which would warrant them to probably isolate themselves, sit at home. But as we managed more and more patients, it came to the fore that these patients dropped their saturations very easily with hardly any symptomatology. And they were comfortable. They were comfortable with 75, 80 saturation and didn't feel the need to come to the hospital till they finally felt the need to come to the hospital. By then, probably it was too late. So what is this happy hypoxia that we're talking about? And the pathophysiology, of course, we've already talked about shunting and the disease per se leading to impaired diffusion capacity and all. But what happened was, when there was hypoxia, the natural response of the body is to increase the tidal volume, which in turn increases the negative intrathoracic pressure. Now this, when it was coupled with increased lung permeability due to inflammation, it led to progressive edema, lung flooding, and the entity called patient self-inflicted lung injury. And as this progressed, the shunt fraction progressed, and hypoxia, which finally could not be corrected by increased levels of FiO2, came to the fore. What was more interesting was that in the initial phases of the disease, these patients had relatively preserved lung compliance, which could explain why there wasn't much of dyspnea. In addition, they also had a dysfunctional hypoxic pulmonary vasoconstriction, which is actually the defense mechanism to maintain the oxygenation. So impaired HPV and vasoplegia increase the severity of hypoxemia. And another unique difference in the ventilatory control and dyspnea perception was seen. That was, this virus had a direct effect on the peripheral oxygen sensing and response. It acted on the ACE2 receptors in the carotid body, and this limited the ventilatory response to hypoxia. Also decreased and abolished the sense of dyspnea in the midbrain and the higher cortical centers, because of which these patients were extremely happy with their low saturations until they were finally not. And so what we saw was a rapid deterioration, though in actuality it was a continuum, but we saw it as a rapid deterioration. And what were these signs? There was hypoxemia driven by tachypnea. Finally, there was tachypnea. There was hyperapnea, there was altered oxygenation, and eventually the compliance got affected. The reduced surfactant also affected the dynamic compliance of the remaining ventilated lung. The dead space was affected because of the intravascular thrombi, and as work of breathing increased dramatically, eventually dyspnea became apparent. By then, probably it was already kind of late. And this hypoxia, coupled with the dysregulated hyperinflammation, subsequently led to multi-organ failure and mortality. So, finally, when these patients came to us, it became our responsibility to try and amp up the oxygenation as fast and as soon as possible. And what were our goals at that point of time? Saturation, attempt was made to maintain the saturation above 92% in acute hypoxemic respiratory failure. A saturation, of course, of 88 to 92 was acceptable in patients with premorbid condition where they had CO2 retention like COPD, etc. an attempt was made to basically decrease the work of breathing by decreasing the respiratory, and this was seen in the form of a decrease in the respiratory rate, heart rate, and improvement in hemodynamics, etc. And also an improvement in ventilatory mechanics was our goal, which could be seen with improved blood gases and decreased lactates, etc. So various oxygen techniques came into play in this period. Of course, we had the good old conventional oxygen therapy. HFNC was another modality which came into prominence. NIV, both in the form of CPAP and BiPAP, was used. Finally, of course, there was the good old conventional invasive ventilation and certain novel techniques like maybe high flow two-way jet ventilation, supraglottic jet oxygenation and ventilation, and of course the veno-venous ECMO, etc. were also advanced modalities which were tried, but they aren't, it isn't possible to cover them in today's session. So let's move forward. Conventional oxygen therapy is always the initial step for oxygen therapy. It is simple to use, does not incur too much of cost, minimal aerosol generation, which was of course a concern when we talked about spreading of the virus, and awake proning was an entity that came into play during COVID-19, and it definitely was well tolerated by these patients. So what are the conventional oxygen therapies? Nasal prongs. We all know that it has the ability to give up to 0.4 FiO2, and but of course, in low flows, the prediction rate is not very good, and it requires humidification if you're using high flows like 6 liters per minute, and it is definitely not very well tolerated by patients having such high flows. So it cannot provide efficient oxygen therapy in patients with severe hypoxia with significant lung damage. Venturi masks, again, can provide up to 60% at flow rates of 12 to 15 and may not be effective in severe hypoxia and may not succeed in reducing the patient efforts, which was again a primary concern. NRBM, or the non-rebreathing bag mask, had a reservoir bag and is capable of giving up to 100% of oxygen at flow rates of 10 to 15 liters. Again, has a limitation that it does not increase the oral and pharyngeal pressures, therefore may not be enough to treat hypoxia with severe lung disease and significant alveolar collapses. So then where do we stand? HFNC was another modality that was tried in this period. High-flow nasal cannula is a non-invasive, high-concentration oxygen delivery interface that circumvents some of the problems of conventional NIV. It has been historically used in neonates, but was already making its advent into the adult ICU for acute hypoxemic respiratory failure, even in the pre-COVID period. So this is a technique, like I already said, whereby heated and humidified oxygen is delivered to the nose at high flow rates. The circuit consists of a flow meter with the oxygen blender connected to a humidifier. Flow rates up to 60 liters is possible through a heated circuit. FiO2 can be titrated from 21% to 100% independent of the flow rate, the crux of the matter, and HFNC does wash out CO2 out of the upper airways, resulting in a reduced anatomic dead space, which then reflects in the reduced work of breathing by lowering the respiratory rate as well. Now, the high flow rates generate a level of positive pressure in the upper airways, thereby reducing the physiological dead space, and also by a creation of some amount of PEEP, which in turn improves the lung volumes, resulting in alveolar recruitment, and this definitely works towards improving the VQ matching and therefore improves the gas transfer. Yeah. Indications, of course, even in the pre-COVID period were acute hypoxemic failure. It has been used in the post-operative respiratory failure to avoid re-intubations, and has also been used for short procedures like bronchoscopy, endoscopy, etc. So it definitely had a place pre-COVID. Now probably it enjoys a more important place. What were the advantages that we already knew about? It decreases the rate of intubation, improves oxygenation, improves CO2 clearance, better patient communication because the patient is still able to talk while having the cannula in place, less anxiety and claustrophobia as compared to the masks of NIV that are used, superior comfort compared to the mask, easier oral suctioning and expectoration, Another important point, heated humidified gas improves epithelial mucociliary function, thereby improving the airway clearance. This is a definite advantage. Reduced cost of breathing because it brings down the breathing rate. Less invasive, so the complications of invasive methods like nosocomial infections, DVT, delirium, etc. can be avoided. And of course, lower cost than the conventional invasive therapy. So it definitely has its own advantages. Yeah. Disadvantages? Very important is a false sense of security that it may provide, thereby delaying intubations. And the delayed decision to intubate can result in increased mortality and prolonged mechanical ventilation. So what are the signs that actually portend need for IMV? They are persistently high respiratory rate, ongoing hypoxia, despite the use of HFNC, thoraco-abdominal asynchrony, and the presence of non-pulmonary organ failures. This should tell you that probably something more is required. Now, various clinical indices have been used to see whether the patient is doing well on HFNC or would ultimately require IMV. The ROX index is one such score, and you can see the ratio there. The ROX index of more than 4.88 after 12 hours of HFNC tells you that this patient is probably not going to require IMV. But then it has drawbacks, that it's only useful in acute hypoxemic respiratory failure due to pneumonia, cannot be used before 12 hours. So you have to wait for a good 12 hours before you can use this. And so clinical judgment ultimately remains paramount. Now, we've already talked about HFNC so much. In the pre-COVID era, there was a landmark trial. I'll just briefly touch upon it, not go into the details. The Florali trial was already conducted in the pre-COVID era to see the efficacy and to see how it performs when it's compared to conventional oxygen therapy and NIVs. And the primary endpoint was, of course, how many patients got intubated at day 28. And the secondary outcome was the all-cause mortality at 90 days and ventilator-free days at 28 days. And just have a look at the first results, the intubation rates. In the high-flow nasal group, the intubation conversion was 38% as opposed to 47% in conventional oxygen therapy and 50% in the NIV group. So it definitely did, even in those times, tell us that probably intubation can be avoided if rightly used. And ventilatory-free days also, HFNC had a brief advantage, and 90-day mortality remained significantly lower in the HFNC group. And a post-hoc analysis that was conducted, especially in those patients with severe ARDS where the PF ratio was less than 200, intubation rate was significantly lower than in the other two modalities. So yes, HFNC did show its advantages, and the conclusion that was drawn was that in acute hypoxemic or non-hypercapnic respiratory failure, HFNC is here to stay. And in failure of NIV was also a result of excessive mortality because of delayed intubation. Again, that false sense of security that comes in. So whether you're using NIV, whether you're using HFNC, have a high degree of vigilance to see whether your patient's really doing well on that. I'm not getting into the further trials because we would really run short of time then. Coming to the COVID era, we all know we've all used various modalities, and we all know that we initially started with conventional oxygen therapy, and if the patient was not doing as well as we wanted him or her to do, we moved on to HFNC. Subsequently, if we were not convinced with the results of HFNC, we moved on to non-invasive techniques like CPAP and BiPAP. And ultimately, I mean, if all modalities were exhausted, we did move on to mechanical ventilation. So what does data from the COVID era tell us about the use of HFNC? Of course, experientially, all of us, we are convinced that HFNC did work for a large number of patients, but then we have to corroborate it with the data that we've got from the international community. So this recovery RS trial, this was again a big trial done in the COVID period. It is a randomized control trial. It was published in JAMA. And here they found, basically they were comparing non-invasive ventilation vis-a-vis HFNC as opposed to, I will be taking 5 minutes, as opposed to conventional oxygen therapy. And what they found was that the outcome of tracheal intubation or mortality within 30 days occurred to the tune of 36% in the NIV group as compared to 44% in the conventional oxygen therapy group. So here they were able to prove the efficacy of NIV pretty significantly, statistically significantly, but they couldn't do the same for the HFNC group. But when you see their conclusion, you know that the study was probably underpowered for the comparison of HFNC versus conventional oxygen therapy, and the early termination and crossover among groups should always be considered when you're considering these findings. And also in the post-hoc analysis, they definitely found that those patients with a PF ratio of less than 200 did reasonably well with a decreased intubation rate in the HFNC group. Another trial was the high-flow COVID trial, where they compared HFNC with conventional oxygen therapy, and they definitely found that the use of high-flow oxygen through a nasal cannula significantly decreased the need for mechanical ventilation support and time to clinical recovery compared to the conventional oxygen, low-flow oxygen therapy. This is another trial, Henivot trial, where they used a helmet instead of a mask for NIV, and they compared it with HFNC, and they found that the results were more or less comparable. So then, even if data has not been able to prove that HFNC was significantly better, a few things do come out. That it is definitely, the ease of use is definitely there. It's definitely better tolerated by the patients. It definitely brings down the anxiety levels. It brings down the work of breathing, which is very important. It brings down the respiratory rate. The mucociliary clearance continues to be better because it's heated and humidified gases. And in addition, awake proning, the compliance was much higher with HFNC as compared to NIV. So it definitely had its distinct advantages. There was this concern of exhaled aerosol dispersion when you're using high flow rates, and I would not get into the details, but this is explaining by itself that if it's a good fitted cannula, the dispersion was not very high. But when it was a loosely fitting cannula, yes, the dispersion was a concern and should be looked into. I'm going to skip all these, but I'll come to the conclusion of all these studies. HFNC may reduce the need for invasive ventilation and escalation of therapy compared to conventional oxygen therapy in acute hypoxemic, not hypercapnic respiratory failure. This benefit, of course, must be balanced against the unknown risk of airborne transmission. And the reason for that is that there is only low certainty experimental and observational data that is available with very mixed findings. And so this has to be taken at our own discretion. So what is the status of HFNC in the COVID-19 era? The burden of COVID-19 related respiratory failure definitely strains the ICU resources, and evidence suggests that mechanical ventilators may be insufficient to meet the need of all the patients that require ventilation. Significant reduction in the need of invasive ventilation with HFNC may be of a substantial benefit. Against this benefit, however, there is the unknown risk of nosocomial transmission, and therefore any strong recommendation in its favor cannot be made. Use it at your own discretion. The question whether HFNC can aerosolize particles is not whether it can aerosolize, but whether it translates into an increased infection risk. But this has to still be answered. We do not have enough data. And how this risk compares with alternate respiratory supports also needs to be seen. Of course, adequate PP is foremost in the risk mitigation. Now, it's a very poor slide. I'm very sorry. I tried to fit it in. It doesn't come. But this is actually published in Anesthesiology Journal. And this is a recommendation from various organizations regarding HFNC and NIV. This includes the American Association of Anesthesiology, the Australian and the New Zealand Intensive Care Society, NHS, the military organization, the COVID task force panel, etc. So we have numerous, but I'll just shorten it for you and simplify it for you. It says for acute hypoxemic respiratory failure, the consensus or the commonality is use it in acute hypoxemic respiratory failure, but with adequate PPE and in a negative pressure room, so that the risk of aerosolization can be minimized. Or if you cannot do that, at least cohort the patients together and put them in a common place so that you can use it safely. So that was the consensus that came out of this, and NIV should definitely be used only in hypercapnic patients was the commonality in that. So coming back to, I'm just highlighting certain of those, that garbled table that you saw. On COVID-19, HFNC is not recommended by NHS England, although it is recommended by other guidelines. COVID-19 guidelines of the Surviving Sepsis Campaign recommends using HFNO over conventional oxygen therapy in patients with acute hypoxemic respiratory failure. If conventional oxygen therapy fails, an additional recommendation is made that HFNO be used over NIV in these patients. And New Zealand ANZICS definitely recommends the therapy for hypoxia, HFNO therapy for hypoxia associated with COVID-19 illness, as long as the staff is wearing optimal airborne personal protective equipment. So that's where we stand as far as the data is concerned. And I think this corroborates with our own experience among all the esteemed people sitting here. So I think that issue is pretty... मागे जाता है का? नहीं जाता है? Okay. So, yeah. So, no, one more मागे जाता है का? Okay, so this is the COVID-19 treatment guidelines for non-mechanically ventilated patients. High-flow nasal cannula versus non-invasive ventilation. What do the recommendations say? For adults with COVID-19 acute hypoxemic respiratory failure despite conventional oxygen therapy, the panel recommends starting therapy with HFNC oxygen. If patients fail to respond, NIV or intubation and mechanical ventilation should be initiated, and this has a grade B2A recommendation. For adults with COVID-19 and acute hypoxemic respiratory failure who do not have an indication for endotracheal intubation and for whom HFNC oxygen is not available, in that situation the panel recommends performing a close monitored trial of NIV. Again, a B2A recommendation. So this is where we stand as far as the HFNC status stands. And of course, awake proning, I just thought I'd add in a slide, but awake proning came into, I mean, we always knew the advantages of proning in ARDS patients in terms of recruitment strategy, but awake proning came into play during COVID-19. And what are the recommendations? For adults with persistent hypoxemia who require HFNC oxygen and for whom endotracheal intubation is not indicated, the panel recommends a trial of awake proning. Again, a B2A recommendation, and more important than that is the panel recommends against the use of awake prone positioning as a rescue therapy for refractory hypoxemia to avoid intubation in patients who otherwise may meet the indication of intubation and mechanical ventilation. So if your patient is due for mechanical ventilation, please go ahead and do write that. Yeah, and that is our A3 recommendation. And with that, I think I come to the end of my... the only thing is, this is the summary of where we stand as far as HFNC is. So based on the knowledge of HFNC, use in acute respiratory distress syndrome, this method of respiratory support may reduce the requirement of mechanical ventilation. Guidelines on respiratory support provided by multiple national bodies, of course, differ in their stance, so we need to take it at our own discretion. An evidence gap exists between the demonstration of aerosolization and its impact on the healthcare workers, particularly if they're wearing PPEs. So again, the question of aerosolization is not really answered. Clinicians should make every effort to mitigate risk to themselves and to other healthcare workers. Again, a priority. Although negative pressure room is preferable, resources may be limited, and so like I said, you can use single rooms or cohort these patients together to be able to use this strategy. In deciding not to use HFNO because of aerosolization concerns, the clinician may be committing to alternative therapies which have their own associated risks. And for patients deemed suitable for endotracheal intubation but who are deteriorating despite nasal oxygen or face mask oxygen, HFNO or CPAP are the only remaining options. So look at these options of HFNO vis-a-vis NIV. And of course, while doing this, keep in mind the ongoing, you should constantly be monitoring the situation of your oxygen supply, because in the pandemic, using these high flows was a concern because oxygen was also of short supply. So you need to be aware of the robustness of your oxygen supply chain. And if that is in place, HFNC is here to stay. So despite all the ifs and buts, I think HFNC is a robust modality which has come into play in a big way in acute hypoxemic respiratory failure and is here to stay with or without the presence of the pandemic. Thank you.
Thank you, Tanima. It's such scientific deliberation in such a short period of time. Just a small comment on this. When HFNC was given as a guideline in COVID in the first place, we were also happy. It's a panacea, all of us thought, and everybody must have purchased so many HFNC, including we at Sasur. Initially, the problem, as you said, was only aerosol formation, but then that COVID oxygen deficit came. So whatever data we could have produced, we could be not successful because all HFNC were just lying in place because the second guideline what we received was not to use HFNO. But still it's a very good modality, and now I think oxygen is in abundance and we can start using our HFNO and produce more data, I think. Thank you so much.
Thank you. And yeah, I'm quite honored to Dr. Prachi is not here, but I'm really honored to tell you that we at Ruby Hall actually were instrumental in the designing of an HFNC as well. These were IIT Kanpur students who came to us asking about the know-how, and we gave them the know-how, and the NOCA HFNC came into existence thanks to our input from the Ruby Hall Intensive Care. So yeah, we feel quite happy about that.
Thank you, ma'am. I now request Dr. Surekha Shinde and Dr. Yogesh Gowli to please felicitate Dr. Tanima Baronia.
For the next lecture, almost from the start of the pandemic, right from the anti-helminthic, ivermectin to most recent remdesivir, almost all drugs in the armory have been tried in almost all possible doses. But I will here request Dr. Bose sir to enlighten us on recent drug therapy on COVID, myths and facts. Thank you.
Now let me introduce him at least. Okay? Yeah. So, Dr. Borse sir is the senior most professor in BJ Medical College, Medicine Department, and he is the one-man show right from day one. When the first COVID patient was in Corona was managed by him in Ruby Hall Clinic, and since there is no comeback. You know, the patients came pouring in. We started treating them, admitting them. And we together were working anesthesia department and medicine department along with pulmonary medicine in Susan Hospital. So we have a lot of together memories. We had some happy moments when patient used to go home after ventilation. Many moments of despair. I would say breakdown, burnout. So many things we have experienced together. But sir was constant force for all of us, being the physician in charge. Anytime used to call sir at 2 o'clock also. Night, he was always available for us, and he was the main person who used to guide our DMER sir, Dr. Lahane. He used to have all queries. Anywhere patient is admitted, which is a little bit complicated, sir used to call Borse sir, and he used to always at his toes to help. So I think this much is more than enough because he's done so much COVID now, and sir is back to his routine medicine, and he's still guiding us. And he's given so many awards also for COVID. I think rest, Dr. Gowli would like to
One thing, most importantly, he is the first consultant with whom our Honorable Prime Minister Narendra Modi ji personally talked with him. And he was really appreciated for the work which he has done.
Thank you so much. Good morning, everybody. Let me thank the organizers of this PROACT Pune conference. Inviting me to have a talk in front of you. I find all the anesthetists, I think they were also geared up in treating the many cases of the COVID-19 during at least second wave and the third wave. Thanks to our BJ team, anesthesia, who were all the time with us in managing the cases of the let it be oxygen therapy management, let it be some drug treatment management, etc., etc. There were some conflicts, those were going on in between, but then those were happy conflicts, I can say. But then really I should give a big thank to the anesthesia team in BJ Medical College. Right, what we observed in the first wave, what we observed in the second wave, what we are observing now in the third wave. Don't think that third wave is declared as over as on today by the either WHO or the competent authorities. It is still going on. Friends, all right, this is a global scenario that is there. Almost more than 445 million cases, those already have happened, and deaths almost more than 5.9 million have happened so far. This is as far as the India is concerned. Total cases so far are 4 crore 45 lakh 25,937, and deaths almost have occurred almost to the tune of say 5 lakhs. This is the situation that is there in Maharashtra as on 17 September 2022, and what we are observing total cases almost 81 lakh 14,309, and the death ratio is almost to the tune of 1.83, and discharge ratio is 98.11%. Friends, this is the proper care pathway that should be practiced in a patient in the management of the COVID. Care, what we call it as CARE, is confirm the diagnosis that it is COVID, SARS-CoV-2 infection, then assess the symptoms, risk factors and severity, and respond with appropriate care and treatment, and is evaluate the clinical response and say recovery. As already suggested, told by the previous speaker, two main pathophysiological processes that are going on. One is the replication of the SARS-CoV virus that is going on in the early stages. That is there in the early stages. And later in the clinical course, there is what is there is the dysregulator cytokine immune response that lead to further massive and uncontrolled inflammatory response. And this inflammatory response is caused by the pro and anti-inflammatory cytokines. There is going to be extensive alveolar and interstitial inflammation, vascular endothelial inflammation, and myocardial other organ damage. This is how the severity of the illness that can be classified into severe illness, critical illness, or non-severe illness. In between, this is what the WHO classification that is there. But then in between, so many task forces, the Pune task force, Maharashtra task force, the Ministry of Health and Family Welfare, time to time they have classified the illnesses, this illness particularly in various categories. And this is what was basically followed during the COVID wave 1 and COVID wave 2. This is the mild illness that can be classified into group A, B, C. A is asymptomatic, COVID positivity is there. Mild is mildly symptomatic without comorbidity, and 1C is symptomatic with comorbidity. Needless to go into the details of all these things, the moderate illness that was there again was stage 2A and stage 2B with pulmonary involvement in stage 2B and without pulmonary involvement in stage 2A. Now, as far as pathophysiological phenomena are concerned, whatever treatment that we are supposed to adopt in these individuals are basically two. One should target the SARS-CoV-2. So one first thing is, whatever number of viruses those are there, either in the early stage or late stage, first thing one should be very clear is that whatever viral replication that is happening in the initial 4, 5, 6 days of the symptomatology. And then what is happening is the immunological phenomenon is taking over, and dysregulated immunological phenomenon of inflammation. By the time inflammation sets in the body, in any organ, the virus, load definitely has gone down in almost 90% of the patients. And in only 10% of the individuals, simultaneously hyperinflammation that is going on in the virus replication will also be given in a peculiar category of the patient, like say HIV infection patient or a CKD patient, or those who are receiving steroids in them. What will be happening is the viral replication that will be going on. And hence, basically, two modalities of the therapies are going to be helpful in these individuals. One is to kill the virus by certain antiviral drugs, and to take care of the whatever hyperinflammation that is going on with certain immunomodulators or say modifying agents. So this is a basic thing, and that's why the category of the drugs that we are supposed to use in this particular, obviously the hypoxemia that is there, neatly and cleanly dealt by the previous speaker about when the oxygen therapy is to be used and when this FNOC therapy is to be used in these individuals. Now, as far as the antivirals are concerned, there are so many plenty in the beginning, What was the antiviral? Those were really not the antiviral. Those were the, something like say antibiotic that were in use, some antimalarial or antiparasitic agent that was in use, as if everybody knew that this antibiotic is going to work in this patient of antiviral illness. As if this antiparasitic agent is going to work in this particular patient of viral. Nobody knew what actually this COVID-19 is going to do, and because there were no studies. Those were, specifically for for this COVID-19. So whether it is HCQ or azithromycin, HCQ plus azithromycin, nitazoxanide, lopinavir, ritonavir, there was, consensus ritonavir. We came across in the first wave, and the discussion used to happen, the COVID-19 is happening, and this lays in patients with the HIV infection because the patients are receiving lopinavir and ritonavir, this combination, and that's why the lopinavir and ritonavir might be useful in this particular individuals. This again was tried. Remdesivir, ritonavir boosted, nirmatrelvir, Paxlovid, what we call a molnupiravir. These are the antivirals, those were tried. Once, say, first wave, second wave, nobody was sure. So everywhere in India also and all over the globe, many trials were conducted about these particular drugs, HCQ, azithromycin, and so on and so forth, molnupiravir, and so on and so forth. So this is one category of the drug that can be antiviral drugs. Second one is the anti-SARS-CoV monoclonal antibodies. And these monoclonal antibodies could be bebtelovimab, casirivimab plus imdesivir combination, sotrovimab, and other monoclonal antibodies. Then COVID-19, say, convalescent plasma. Then are the immunoglobulins, specific immunoglobulins, and anti-CD6 monoclonal antibody, that is itolizumab. And then another category of the drugs to take care of the inflammation that is happening are the immunomodulators, like, say, corticosteroids, methylprednisolone, prednisolone, etc. Then interleukin-6 inhibitors, like, say, tocilizumab or sarilumab. Then Jacques kinase inhibitors, like, say, baricitinib. And so many immunomodulators that have come in the market that have been tried during the second wave, at the end of the first wave, and when we were in dark, we started coming to know that we started learning so many things from the whatever trials those were going on in the world, and then we could start this particular treatment in our local hospital, that too in Sassoon. Might well in Sassoon during the second wave at a time. One day was there. In Sassoon, there were 650 patients were there in a day admitted, and that too in a critical stage. Remember, we had 120, almost more than 120 bedded ICU, which were, with the ventilators. And you can imagine being a tertiary care hospital, what category of the patient. It's not only the lung inflammation, that was the patient used to come and requiring only oxygen and oxygen, but it will be kidney failure also. It will be pancreatitis also. It will be encephalopathy also. It will be so many multiple organ dysfunction in the septic shock and so many. And at the tail end of the second wave, we started coming across one of the complication presumably because of the certain type of treatment the patient has received, and that was, say, some certain fungal infections like, say, mucormycosis. We have come across cases of the aspergillosis also. So the friends, these are the drugs those can be used. Importantly, one of the things that is happening in this particular individual is the endothelitis, inflammation of the endothelium. And whenever there is endothelitis, what is going to happen is there is a blockage. Is going to be a platelet formation is going to be there in the vessel, and microvascular complications. The macrovascular, what sort of complication we have come across? We have come across aortic thrombosis. We have come across iliac vein thrombosis. We have come across cerebral venous sinus thrombosis. We have come across renal vein thrombosis, mesenteric artery thrombosis, such type of thrombotic complications that we came across during the second wave, and mind will, even today, in spite of such a knowledge that is there of the pathophysiology and various treatment modalities, those are there. As on today also, we have the almost 5 patients, those are there. Obviously, very less number as compared to what it was into 6, right? 5 cases. One of the cases having extensive thromboembolism, not only in the lungs, but also there in the DVT is also there, and the peripheral artery that is also blocked. So such type of cases still we are coming across. So obviously, we have to take care of the whatever thrombus that is getting formed with the antithrombotic agents. Antiplatelet agents were also tried in few studies. One of the important thing, antibiotics. Patient आला आपल्याला काय fever दिसला काय complications दिसली की what we used to consider, irrespective of thinking much on it, we start the patient on antibiotics. But mind well, this is the illness where it is a mild and moderate disease when it is there. There is no need of starting antibiotics in these individuals, except in a patient with severe critical illness, that too when ARDS septic shock. or the patient is in hypotension, or the patient perhaps are not, satisfactorily responding to the expected period of time when they are supposed to respond to a specific antiviral treatment or with the immunomodulators and so on. Then we are supposed to start the patient on antibiotics. And obviously, the concomitant medications if the patient is on, what is to be done. Friends, I won't be going into the details. As far as the antivirals are concerned, HCQ, so many trials went on, but then this has proved. Initially it was there, and it was the thing that was there. HCQ, symptomatic, asymptomatic, give as a prevention therapy, and then a time has come, it was labeled that the HCQ is not at all useful, not at all. It is thrown out of the whatever compartment that is there, placed in this particular HCQ. So but surprising thing that is that today also we are finding the prescriptions of the HCQ that patients are receiving of the COVID-19. Latest 2 months back, I came across 2 prescriptions where HCQ was written for the treatment of the. So this has no place as far as the COVID-19 management, either prophylaxis. Azithromycin plus minus. काय नाही आलो ह्या काळामध्ये क्यूटी प्रोलॉंगेशन अहो काय म्हणजे काय त्यावेळेस असं झालं होतं की क्यूटी म्हणजे इतका महत्त्वाचा फाइंडिंग आहे ECG मध्ये की प्रत्येकाने ECG बघायचा आणि क्यूटीचा शोध घ्यायचा. म्हणजे क्यूटीचा शोध कसा घ्यायचा हा तर लोकांना माहिती नव्हता की इतक्या वेळा त्यांनी क्यूटीचा शोध घेतला की हा वाढला थांबवा असला प्रकार त्या काळामध्ये हा सुरू झालेला होता. आणि रिअली दिस हॅज हॅपन्ड. This has happened. QT prolongation has happened. Sudden deaths have happened, and that's why so many trials have also. We also, thrown out this particular azithromycin. No, we don't start even today. Today we are not considering at all this azithromycin or HCQ in combination. Right? Ivermectin. Oh my God, this ivermectin also has created havoc in treating cases of, ivermectin. नहीं मिल रहा है, कहाँ जाना है, उधर जाना है, इधर से लेके आओ, किधर 50 रुपए का मिल रहा है, नहीं 400 रुपए दे दो लेके आओ. अरे काय चालू काय. आयव्हरमेक्टिन इज अँटीपॅरासायटिक ड्रग आणि काय कुठं इज व्हायरल इन्फेक्शन आहे ना अँटीपॅरासायटिक ड्रगचा एवढा मोठा काय हॅवॉक काय म्हणजे आणि किती मिळेल 12 ग्रॅमचा डोस द्या आणि एवढा करा म्हणजे ते काय so many trials then we also used it. असं नाही आम्ही सुद्धा वापरला पण ओव्हर अ पिरियड ऑफ टाइम वी स्टार्टेड रिअलाइजिंग की दिस इज युसलेस ड्रग. This is a useless drug. It is not going to benefit to the patient. Over the period of time also we started, completely thrown this particular drug. Lopinavir, ritonavir, I told you about this thing. Nitazoxanide, this also anti. हा ड्रग तर अँटी एल्मिंथिक म्हणून वापर म्हणजे काय नाही उरलं हो. अँटीबॅक्टेरियल पण झाला, अँटीव्हायरल एखादा तो झाला, अँटी पॅरासिटिक झाला, अँटी मलेरियल झाला आणि आता अँटी एल्मिंथिक उरलेला होता म्हणून त्यांनी काही लोकांनी हा पण ट्राय केला या लोकांनी आणि then the study came up, these many studies did not improve the time to resolution of the symptoms. So this is also gone out. So the nitazoxanide. What about the interferons? Those were out of question as far as our Sassoon is concerned. We didn't use it, but then so many trials those were conducted. Again, is not at all useful. Favipiravir हा एक अँटीव्हायरल फ्रेंडली अँटीव्हायरल म्हणायला गेलेत लोक. स्टार्ट पण केला आणि त्या फॅव्हिपिराव्हिरचा डोस म्हणजे इतका फनी डोस होता तो. 200 मिलीग्रॅमची टॅबलेट असते ती 9 कॅप्सूल ॲट अ टाइम. ज्यांना कधी भूक लागत नाही जेवण अहो म्हणजे तो 9 टॅबलेट आज सकाळी द्यायचे आणि संध्याकाळी द्यायचे पुन्हा म्हणजे 18 आणि त्यानंतर मग काय तो 800 मिलीग्रामचा बीडीचा डोस. मग तो 5 दिवस द्यायचा की 7 दिवस. एव्हरीबडी सगळ्यांना अगदी आश्चर्य किती दिवस द्यायचा हा सुद्धा प्रश्न. पण आय टेल यू दिस फॅव्हिपिराव्हिर is not at all, this is my experience that I am telling you, this favipiravir is not at all useful in the critical cases. Throw it out. As far as the mild and moderate illnesses are concerned, could be useful in 1% of the cases. Only in 1% of the cases. Otherwise, we have seen patients started on favipiravir and then immediately after second day, the renal parameters are increasing. Serum creatinine is increasing. Like this thing that has happened. And ultimately, होतंय काय की आपण हे फॅव्हिपिराव्हिर चालतो, पेशंट आपल्याकडे येतो डे 4ला, आपण 3 दिवस देण्याचा प्रयत्न करतो आणि त्यानंतर 7 दिवस उलटून गेलेले असतात आणि मग आपण विचार करायला चालू करतो की आता रेमडेसिवीर लावूया का. बाय द टाइम द रेमडेसिवीरचा आपण विचार करतो 7 दिवस निघून गेलेले असतात, 8 दिवस निघून गेलेले असतात. इम्युनॉलॉजिकल फिनॉमिनन जो काय आहे तो अल्व्हिओलायटिस काय, किडनी फेल्युअर काय, आणि मग आणखी प्रश्न येतो रेमडेसिवीर द्यायचं ते रिनल फेल्युअरमध्ये द्यायचं का. मग प्रश्न येतो, वी हॅव सीन पेशंट्स लँडिंग बिकॉज ऑफ दिस फॅव्हिपिराव्हिर लँडिंग इन टू थ्रोम्बोसायटोपिनिया, लँडिंग इन टू रिनल फेल्युअर, अँड अल्टिमेटली वी हॅड टू स्टॉप दिस पर्टिक्युलर. सो दिस इज ॲक्च्युली व्हेरी कॉन्फ्लिक्टिंग डाटा ॲज फार एज द फॅव्हिपिराव्हिर इज कन्सर्न. दिस इज ओके ॲज गुड ॲज दिस इज ॲज गुड ॲज प्लॅसिबोज. कारण एखाद्या पेशंटला वाटत असेल की त्यांनी जर डिमांड केली की मला जरा जास्त प्रमाणात गोळ्या द्या, टॅबलेट जरा जास्त प्रमाणात द्या, म्हणजे मग 9 टॅबलेट तुम्हाला, सॉरी आय विल रिक्वायर सम टाइम. ओके, forget about this is ritonavir boosted nirmatrelvir is good drug as far as the antiviral activity is concerned. It can be recommend. What about remdesivir? Oh, remdesivir असं काही मॅजिक बुलेट त्या काळामध्ये ते आलं की ते म्हणजे साधारण ऑगस्ट 2020च्या दरम्यान हे बुलेट आलं. आणि बुलेट आलं तर सगळ्यांना असं वाटू लागलं की आता कोविड-19 काय होणार याचं, या जगाच्या पाठीवरनं हा लगेच निघून जाईल की काय. अरे पण नंतर असं लक्षात सगळ्यांनी, अहो रेमडेसिवीरसाठी 40,000 रुपये दिलेलं आम्ही पाहिलं. रेमडेसिवीरसाठी अर्ध्या रात्री 2 वाजता नंबर लावलेलं पाहिलं आहे आम्ही रेमडेसिवीर मिळवण्यासाठी. अहो काय नाही पाहिलं या रेमडेसिवीर. आणि शेवटी अल्टिमेटली काय आलं, अल्टिमेटली हे आलं की रेमडेसिवीर, सो मेनी ट्रायल्स दोज आर देअर. रेमडेसिवीरने काय सांगितलं आपल्याला, मला तुम्ही वापरा पण मी फक्त मॉर्टॅलिटी तर कमी करणार नाही, मॉर्टॅलिटी मी कमी करणार नाही. मी काय करणार आहे, तुमचा हॉस्पिटल स्टे 1 दिवसाने कमी करणार आहे. आणि 1 दिवसाने कमी करणार आहे तो कुठं, वेस्टर्न कंट्रीजमध्ये. आपल्याकडे 4 दिवस पेशंट राहिला आणि 5व्या दिवशी जरी राहिला तरी आपल्याला काय खूप फरक पडत नाही. म्हणजे 5 दिवसानंतर डिस्चार्ज झाला काय आणि 4 दिवसानंतर डिस्चार्ज झाला काय, हे एक करामती या रेमडेसिवीरने करून दिल्या. नो क्लिनिकल बेनिफिट, बट माय पर्सनल एक्सपिरियन्स आय टेल यू इज गुड ड्रग इन अ मॉडरेट इलनेस केस. दिस कॅन बी, मे नॉट बी, very much useful when the patients are started on mechanical ventilator or say NIV type of things. But then this is a good drug, and again, if it is used, almost 7 days of the symptomatology, before the 7 days of the symptomatology, even at the 9th day, people have tried this drug for how many days? People have tried it for 1 day. The people have tried it for 3 days. The people have tried it for 5 days. Funny thing is the people have tried it for 21 days also, this remdesivir. We have come across it, and ultimately the patient could land into acute renal failure, and we had to dialyze such type of patient. Because of this remdesivir, what had used to happen was again the thrombocytopenia, very, very bad thing. That 1, 2 or 3 cases I have seen. Remdesivir आज पहिल्या दिवशी दिलं आणि इन्फ्लेमेटरी रिस्पॉन्स तर अजूनच वाढला. म्हणजे मग आमच्या डोक्यात ती कल्पना आली की whether it is iris that was there, the way that we get, in patients of the HIV. So iris that was, so could be because of the basic thing. But this remdesivir, if it is given within 7 days, appropriately, without any hyperinflammatory changes, those are there, finding out. हायपरइन्फ्लेमेटरी चेंजेस हे नाही येत हो, 7 दिवसाच्या आधी नाही येत, मी तुम्हाला सांगतो. ते येतात ते 9व्या-10व्या दिवशी किंवा 8व्या-9व्या-10व्या दिवशी, आणि सो मग काय उपयोगाचं काय आहे when it is started on 8th or 9th or 10th day. So this remdesivir, again, WHO doesn't recommend this remdesivir, but this is a personal experience, and one of the panel of the COVID-19 big panel that considers this remdesivir as the important drug in certain specific situations. Right. अहो हे असिम्प्टोमॅटिक काय आश्चर्य किती वाटावं. म्हणजे एखाद्या पेशंटचा नातेवाईकला काहीतरी कफ सोर थ्रोट वगैरे झाले त्याने रेमडेसिवीर, तो जाऊन डिमांड करतोय की मला पण रेमडेसिवीर द्या, ज्याला सिम्पटम्स नाहीत, काय नाही हो, फिवर नाही, काय नाही, तो जाऊन डॉक्टरांकडे डिमांड करायचा त्या काळामध्ये की मला पण देऊन टाका असिम्प्टोमॅटिक, कारण मला व्हायला ना. अरे प्रोफिलॅक्टिक थेरपी नो. अँड सर इम्पॉर्टंटली मेनी ऑफ द डॉक्टर्स दे हॅव गिवन दिस ड्रग टू दी असिम्प्टोमॅटिक इंडिव्हिज्युअल्स ऑल्सो. And asymptomatic individual coming later, after say 3-4 days, coming later with the kidney dysfunction. This thing also we have observed. So not to be certain specific. So take care when you are giving it in patients with the thrombocytopenia. Take care in patients with the renal impairment. EGFR one must be knowing how to calculate, and so on and so forth. And this आता हे HCQ and chloroquine यांच्याबरोबर कॉम्बिनेशनने दिलं तर म्हणतात की रेमडेसिवीरचा जो काही कॉन्सन्ट्रेशन असायला पाहिजे ते कमी असायला पाहिजे. बट आय थिंक द क्लिनिकल इट इज नॉट मच सिग्निफिकंट. येस, दिस इज अ गुड ड्रग. Molnupiravir is a good drug. We had an opportunity to use this particular drug almost in 20 to 25 patients, not a big number. But then whenever it was used in a moderate illness, those patients who were requiring actually oxygen of say 2 liters. And then this molnupiravir reduced the rate of the death by almost 30%. And there was no significant difference between the arms as far as the adverse events in the comparable group that is concerned. This molnupiravir is very, very important drug. So this is as far as the antivirals are concerned. So antiviral, which one? Preference, if at all given to me, no preference. I will consider molnupiravir. Then I will consider what second one is the remdesivir that I am going to consider. I am going to throw out all those particular, azithromycin, HCQ, what doxycycline. As far as the monoclonal antibodies are concerned, there are so many, casirivimab plus imdesivir, sotorubab. I had an opportunity to use this casirivimab plus imdesivir. Even the madam also is having this particular experience of using casirivimab. I haven't used this sotorubab or bebdelovimab and so on and so forth. The funny names, those are there, very, very difficult tongue twisting names, those are there. And, we cannot use this thing in tongue twisting patients also. So for, what about the casirivimab and imdesivir? Yes, they... sorry. Right, this casirivimab and remdesivir. I'll tell you my experience. This drug I have used in the ambulance, standing outside the casualty in a situation at a time when there were 35 patients landing, were waiting in the casualty. 35 patients just requiring, O2 therapy. And then this patient used to come to us with some sort of mild to moderate illness. Obviously, those were the days, we were not able to give to each and every patient having mild to moderate illness. But then VIP patients, एखाद्याचा मंत्र्यांचा, संत्र्याचा, कोणाचा नगरसेवकाचा फोन आला की असं त्यावेळेस by the time it was because it was very popular, काहीतरी अँटीबॉडी मिळतंय आपल्याला म्हणून हा ड्रग चला जाऊ ससूनमध्ये आणि मग we have given this casirivimab and remdesivir in almost 8 to 9 patients outside the casualty in the ambulance. We have given this thing intravenously also. I used to, just stand for 10 to 15 minutes. No need of, funny things doing, monitoring and all this. Very safe drug. And 600 milligram of this combination when it is instilled intravenously and observed just for half an hour to 1 hour. Nothing used to happen. And काय म्हटलं ते एखाद्या पेशंटने मला थोडी चक्कर आली बाकी काही नाही एक अर्धा तासाने पेशंटला चांगलं वाटायचं आणि पेशंट used to go, very easy. We could come across not a single case having any further deterioration in the COVID-19 manifestation after giving this. This is a good drug. Obviously the cost issue is going to be there. So this is a good drug as far as the sotorubab is concerned. Can be considered for the, because it has reduced the deaths in almost many patients of the COVID-19. WHO recommends it. This is inadequate data that is there of the bebtelovimab and so on and so forth. So it's not available with us. This combination is also not, there are so many. Convalescent plasma. अरे बाप रे, या convalescent plasma ने काय म्हणजे काय कोणत्या लेवलला म्हणजे सेंट्रल लेवलला काय स्टेट लेवलला काय सगळे सेक्रेटरी काय कमिशनर काय सगळ्या लोकांना फोन करा ज्यांना कोविड झालेला आहे 2 दिवसापूर्वी डिस्चार्ज झाले की त्याला बोलवा आणि त्यांच्याकडे प्लाझ्मा काढून घ्या आणि त्या प्लाझ्माचा वापर करा ॲज इफ दॅट प्लाझ्मा यूज टू कंटेन लॉट ऑफ अँटीबॉडीज अगेन्स्ट दी कोविड-19. Oh, guys, दिलं. I was a part of one of the trial in the COVID-19. That was a solidarity trial. And what was observed was useless. Absolutely useless. And I tell you, there was no benefit. And so many trials. अरे इतके ट्रायल असूनही मी तुम्हाला सांगतो एक latest must be some 4 months back I came across one case who has received this convalescent plasma in the private. And then the patient obviously deteriorated, has landed into ARDS and so on and so forth, and the patient passed away. So this is the story that is there, convalescent plasma, and you must have already experienced all these things. इटोलिझुमाब मला वाटतं खूप लोकांनी वापरलेलं असेल. KMला वापरण्याचा प्रयत्न केलेला दिसतोय. आमचे डॉक्टर कदम म्हणून होते, त्यांनी ते सिंहगडला वापरण्याचा प्रयत्न केला. आम्हाला फक्त 2 लोकांना हा वापरण्याचा अनुभव आहे, खूप जास्त नाही. पण दिस इटोलिझुमाब रिअली हॅज वर्कड इन 2 ऑफ द पेशंट इन whom we had given this was a moderate illness cases, those were there, and we could save the life of. हे झालं डेल्टा झालं काय सेकंड वेव्ह झालं डेल्टा आता काही नवीन आलेलं आहे का म्हणजे अमंग्स दिस कॅझिरिविमा आपण म्हणतो कॅझिरिविमा प्लस एमडीची व्हेरी गुड ड्रग व्हॉट अबाउट दिस ओमिक्रॉन दॅट इज गोइंग ऑन व्हेरी आणि इतक्या सबजाती तयार झालेल्या आहेत कोविड या ओमिक्रॉनच्या इतक्या सबजाती तयार आहेत की म्हणजे आता कोणत्या सबजातीला या द्यायच्या हा प्रश्न पडतोय पण हे सगळे नाही ह्या ओमिक्रॉनच्या याच्यामध्ये हे सगळे जे ड्रग्ज आहेत ना हे सगळे युजलेस ड्रग आहेत. We are not supposed to use this Casirivimab and Remdesivir also, right? What about the immunomodulators? Yes, I'll just cut short myself. So many immunomodulators, corticosteroids, interleukin-6 inhibitors. Dr. Bande already mentioned about the tocilizumab. I'll go into colchicine. अरे याने पण अजून एक धमाल केली बरं का या colchicine ने म्हणजे असं वाटायचं की या colchicine म्हणजे काय आपण गाऊटला वगैरे कोणाला तरी वापरतो तो ड्रग आणि आज त्याचा अनुभव काय माहीत नाही आपल्याला गाऊट म्हणजे पण या ड्रगने इतकी म्हणजे धुमाळ घातली होती मध्ये ओव्हर अ पिरियड ऑफ 4 ते 5 महिन्यापर्यंत कॉल्चिसिन नाही बाबांनो हा ड्रग पण इतका युजलेस ड्रग आहे की म्हणजे इम्युनोमॉड्युलेटिंग प्रॉपर्टी आहे हो त्याला पण ते किती असणार आहे इट इज व्हेरी व्हेरी माइल्ड इम्युनोमॉड्युलेटिंग प्रॉपर्टी दॅट इज देअर आणि मग काय उपयोग नाही याच्या उलट काय करतं हे माहिती आहे का जास्त 30 to 40% लोकांना डायरिया तयार करत असतो आणि चान्सेस ऑफ पल्मनरी एम्बॉलिझम chances of pulmonary embolism are going to be very high with the colchicine. So again, this is I am not going to go into the what about this is so forget this rituximab and tofacitinib. Again, these are useless drugs. Protons useless drugs. All these ibrutinib or all these are useless. What I find is the useless again this one. Again, all these are useless. Inadequate data that is there. This is one means inadequate data that is there. Systemic steroids. Oh yes, systemic steroids. And importantly, what we need to take care of is the hyperinflammation that is there. Hyperinflammation. मग हे पहिल्या दिवशी देऊन चालणार आहे का दुसऱ्या दिवशी सिम्प्टोमॅटॉलॉजीचे जाणे सोरथ्रोट यायचा अहो तुम्हाला सांगतो असा एकही फिजिशियन असा एकही क्लिनिशियन नसेल की ज्याने स्टिरॉइड हे दुसऱ्या दिवशी दिलेलं नाही या लोकांना दिस इज अ फॅक्ट दॅट आय एम ट्राईंग टू टेल यू आणि म्हणून जे काही कॉम्प्लिकेशन्स ऑफ हायपरग्लायसेमिया कॉम्प्लिकेशन्स ऑफ म्युकॉरमायकोसिस कॉम्प्लिकेशन्स ऑफ ॲस्परजिलॉसिस that had happened because of this particular drug. Hyperglycemia to the tune of ketosis, developing ketosis, yes, has happened. आपण वापरायचं तर मग किती दिवस वापरायचं ते 1 दिवस 2 दिवस 3 दिवस 4 दिवस 5 दिवस किती दिवस लोकांनी 10 दिवस 15 दिवस वापरले स्टिरॉइड्स काय त्याला लिमिट आणि दॅट टू जो म्हणजे काही पॅथोफिजियोलॉजी न समजता हायपर इन्फ्लेमेशन आपल्याला केअर घ्यायची आहे म्हटल्यानंतर 7व्या 8व्या दिवशीचं चाल ऑलवेज बेट सो now not less than 5 days not less than 5 days of symptomatology definitely works if it is appropriately used in appropriate patient in appropriate doses for appropriate period of time if it is used the hyperinflammation is taken care of and the function of the organs they definitely improve with these steroids so I think I need not go into the details take care of whatever right moderate severe illness critical illness shock when it is there but कुठलं वापरायचं आहे आपण कुठलं डेक्सामेथाझोन वापरायचं मिथाइल प्रेडनिसोलोन वापरायचं पिझा काय हायड्रोकॉर्टिसोन वापरायचं मला वाटतं काय आपल्याला जर कंपॅरेबल डोसेस माहिती असतील ना काही 6 मिलीग्रॅम ऑफ डेक्सामेथाझोन म्हणजे किती मिथाइल प्रेडनिसोलोन की किती आपल्याला हायड्रोकॉर्टिसोन लागतं मला वाटतं सेम काही फरक जास्त पडत नाही ठीक आहे वन इज शॉर्ट ॲक्टिंग लॉंग ॲक्टिंग अँड सो फोर्थ पण ते एम पी एस म्हणजे ह्या जगामध्ये एम पी एस शिवाय दुसरा कुठलाच ड्रग स्टिरॉइड अवेलेबल नाही अशी एकदा परिस्थिती होती म्हणजे इतकं ते एम पी एस त्या काळामध्ये वापर सुरुवातीला लेट मी कन्फेस माय सेल्फ इवन in the beginning also in the COVID wave also I have used this MPS in a dose of 500 milligram also in one patient 1 or 2 patients and then many people they started criticizing and so we started learning and no 1 milligram 1.5 milligram per kilogram per day maximum period that should be given is 5 days stop it abruptly can we stop it abruptly Can we stop in COVID-19? Yes, we can stop this particular, but then over a period of time we started learning, and then MPS created a problem of the hyperglycemia. Then we started using the Dexona, so many trials of the Dexona. But Dexona पण किती 6 मिलीग्रॅम की 12 मिलीग्रॅम, डबल डोस की एकदा काय दोनदा द्यायचा, याचंही पण ते कॉन्फ्लिक्टिंग सुरू झालं, आणि मग पण कित्येक लोक 12-12 मिलीग्रॅम. अहो पण रिझल्ट काय सांगतोय आपल्याला? रिझल्ट हे सांगतोय की 12 मिलीग्रॅम वापरा, नाही तर 6 मिलीग्रॅम वापरा. ॲट द एंड ऑफ द 15 days the whatever benefit is to happen the same. So म्हणजे काय, फक्त 6 मिलीग्रॅम म्हणजे 12 मिलीग्रॅमने आपण हायपरग्लायसिमिया आणि ॲस्परजिलोसिस करून घेण्यापेक्षा, ॲस्परजिलोसिसमध्ये मरणारा पेशंट करून घेण्यापेक्षा कोविड राहिला बाजूला आणि ॲस्परजिलोसिसमध्ये मरतो, हे अशी परिस्थिती येऊ नये म्हणून आय थिंक द 6 milligram is going to be the enough. I need not go into the details. Systemic steroids. Yes. MICC. MIS, multiple inflammatory syndrome, multi-organ inflammatory syndrome, that is there in childhood. That is also there in adults also. This is a condition where there is hyperinflammation that is happening in children. That is happening. And आमच्या क्लिनिकर मॅडमने IVIG वापरलं. IVIG वापरलं, त्यांना चांगले रिझल्ट्स मिळाले, नाही असं काही नाही. शी इज गोइंग टू पब्लिश अ पेपर ऑन दिस. बट देन what other studies they show? She has the experience. I don't have the experience, but theoretically that I can say that nothing like steroids when they are used in appropriate doses for appropriate period of time. That's all as far as the MIC is concerned. What about, yes, wonderful drug, tocilizumab. डॉक्टर बांडे ऑलरेडी इट सेल्फ हॅज मेड, राईट. पण याचा प्रॉब्लेम काय होता की कमी प्रमाणात अवेलेबल होतं. 80 हजाराला एक मिळायचं, 80 हजाराला. आमच्या ससूनमधून हे टोसिलिझुमाब एका पेशंटने आणलेलं चोरीला गेलं, आणि मग ते विकलं गेलं. जे काय आणलं असेल ते 80 हजाराला. नंतर तो चोर सापडला, नंतर मग त्याला काय जे करायचं असेल ते केलं आपण. पण this all cause mortality and shorter stay that caused there. But wonderful drug in presence of the moderate 2B and in a critical illness cases. This प्रश्न असा पडतोय की किती डोस वापरायचा, म्हणजे आणि काय म्हणजे जर हेपॅटिक इम्पेअरमेंट असेल, रिनल इम्पेअरमेंट असेल, थ्रोम्बोसायटोपेनिया असेल, तर जर आपण बघा यू कॅन गो, स्लाइड्स आर गोइंग टू बी देअर इफ यू वॉन्ट टू गो इन टू द डिटेल्स लेटर ऑन यू गेट्स. बट देन अशी वेळ होती की 800 मिलीग्रॅम द्यायचं असा सुरुवातीचा समज होता. कधी लोकांनी 3 डोस 400 मिलीग्रॅमचे 3 डोस वापरलेत, आणि 3 डोस वापरल्यानंतर काय झालं, त्या लोकांना सेप्टिक शॉक बसला, आणि मग ते मेले असं झालं. मग ते किती वापरायला काय किती पाहिजे, तर ते म्हणजे टोसिलिझुमाब इज टू बी ओनली 1 डोस अँड दॅट टू ऑफ 400 मिलीग्रॅम, आणि संपलं. थांबवा. नाही त्याच्याने फायदा झाला तर चांगलं आहे, नाही फायदा झाला तर पुन्हा देण्याचा प्रयत्न करू नका. सो दिस इज वॉट बट देन इट कॅन ऑल्सो बी युज्ड अलॉंग विथ स्टिरॉइड्स. असं काही नाही म्हणजे दोन्ही इम्युनिटी सप्रेशन ड्रग्ज आहेत म्हणून दोन्ही देऊ नये. बेटर रिझल्ट्स आर गोइंग टू बी देअर वेन इट इज कंबाईंड with the steroids. So this is how the tocilizumab is a good drug. It can be used in severe illnesses. Right. Certain contraindications, those are there. I need not go into the details. Sariluzumab comparable आहेत म्हणजे tocilizumab आणि हे comparable आहेत. I don't have any experience of this. Baricitinib. Oh yes, this is wonderful drug. This is very good drug. I will say better than the tocilizumab. Right, taking care of the critical illness cases. This definitely reduces the mortality in hospitalized adults. Baricitinib, this is IL-6 blocker that is there. And baricitinib, very good drug. Okay, antithrombotics. I'll really cut it short. Antithrombotic. One thing is clear. द्यायचं आहे. कोणाला द्यायचं आहे? ज्यांना थ्रोम्बोटिक प्रॉपेन्सिटी आहे त्यांना तर द्यायचंच. लेट इट बी माइल्ड इलनेस ऑर मॉडरेट इलनेस. थ्रोम्बोटिक प्रॉपेन्सिटी आहे ना एखाद्याला, प्रेग्नन्सी आहे, somebody, I was very happy, listening the talk by Dr. Pandya, the discussion that was going on about the thromboprophylaxis. Mild illness आहे, प्रेग्नन्सी असली द्या की आपल्याला थ्रोम्बोप्रोफिलॅक्सिस द्यायला पाहिजे या लोकांना. Similarly, so many other conditions those are. Definitely, yes, clot when it is there, once it is a proved clot. The problem that is there is to prove that it is a clot. To prove that, and for that thing, what is required are the specific investigation. We'll require CTPA. We require, the Doppler study in the lower limb. We require angiography here and there. And so this antithrombotic, when it is simple principle, मी जास्त डिटेल मध्ये जाणार नाही. Simple principle, when it is a thromboprophylaxis, 0.4, 0.6 milligram of the say enoxaparin that can be given as long as the patient requires thromboprophylaxis. That means as long as the patient has got that comorbid condition precluding for starting the thromboprophylaxis. That is one. And second thing is the therapeutic dose when it is given, Q as minimum as possible. minimum as possible means 0.4 to 0.6 milligram subcutaneously, that is to be given either OD or maximum BD doses are to be given over a period of how many days? Either 5 days, 7 days, 10 days. But it all depends on what is the underlying condition for which you are. Obviously, if it is pulmonary thromboembolism, the protocol that you need to follow. So there are so many things, anticoagulants, yes, right, heparin, fondaparinux, enoxaparin that can be used. Specifically, I will divert your attention if my risk factors thrombotic, age more than 60 and so forth. Right, this is recommended. Antiplatelet, aspirin मध्ये एवढं thrombosis चालू आहे मग antiplatelet द्यायची की नाही, aspirin द्यायची की नाही. So many studies have proved that no, this has no role as far as the COVID-19 is concerned. What about the other drugs? Vitamin C, vitamin D, and zinc 50 milligram, OD or BD, vitamin D किती द्यायचं? या लोक अरे द्या म्हणजे studies say that plus minus, you get, you don't give it. Maybe useful, may not be useful. This is what the studies they say, right? But then मग आता द्यायचंच जर नाही एखाद्या COVID-19च्या पेशंटला, काहीच जर द्यायचं नाही, फक्त पॅरासिटामॉलने कधी खुश होत नाही पेशंट. पॅरासिटामॉल नुसतं दिलं जा, तू आता 2 दिवस घरी थांब आणि मग पुन्हा तुला सिम्पटम्स वाढले की मग तुला टॅकिपनिया झाला, ऑक्सिजन मोजत बस घरी आणि ऑक्सिजन तुझा खूप ड्रॉप झाला की मग ये आणि मग आपण व्हिटॅमिन सीचा विचार करू आणि मग व्हिटॅमिन डीचा विचार करू. असं नाही करता येत. म्हणजे काय प्लस मायनस आहे ना, आपण देऊन टाका की पहिल्या दिवशी देऊन टाका, व्हिटॅमिन सी देऊन टाका, व्हिटॅमिन डी देऊन टाकायला काही हरकत नाही. ॲज फार ॲज दी सप्लिमेंट्स आर कन्सर्न, अँटीबायोटिक्स आय टोल्ड यू, फ्लुइड्स आय थिंक आय डिड नॉट गो इन टू द should not be extra fluid, should not be low. Low fluid in the body will create a problem of thrombosis here and there. Very high fluid, already hyperinflammation in the muscle, in the heart, myocarditis. So many cases of myocarditis we have seen, right? So when it is like this, myocarditis and so forth, then the chances of the failure, and then once the patient, झाले काय myocarditis, lungs are flooded, आणि मग काय होतंय, lungs are flooded म्हटल्यानंतर CT स्कॅन केला जातो, CTSS बघितला जातो, आणि CTSS मध्ये 25/25 दिसतं आपल्याला. अरे it is not because of the alveolar inflammation, it is there because of the fluid that is there because of myocarditis. And damn, I tell you, if the fluids are washed out, that 25/25 CTSS, if you do it on next day, will turn out to be 0/25. 0/20, because once the fluids are, we have experienced this particular thing also. As far as diet, I will not go into the details. Supportive treatment, fast, feeding, analgesia, and so forth. Chronic medication when the patient is on. Chronic medication. Somebody is on ACE inhibitors, ARBs. Somebody is on statin. Don't stop. Don't make an attempt. Don't think that it is what ACE receptors where the COVID is, attached. ACE. आणि म्हणून हे ACE आहे. असा काहीच विचार करायचा नाही आहे. We can ACE inhibitors definitely we can continue. ACE inhibitors we can start in this individual. Statins we can keep. As far as anti-diabetics are concerned, glitazones or say SGLT2 inhibitors should be stopped. Forget about this HCQ and all, corticosteroids and so on and so forth. Underlying condition, take care of diabetes, hypertension, hypothyroidism, and so forth, because this is how. Hello. This is how going to be. This is my last slide, madam. Yeah. And that's all. Thrombophlebitis, oxygen therapy, corticosteroids, tocilizumab, baricitinib, these are good drugs. And then what is there is medium-sized drugs are the calcium, imdesivirine, and no, zero, red cross, that is there. Is all they are the drugs. This is the additional thing that if you at all you want to go into the details, you can read this particular thing. Thank you so much.
Thank you, sir, for such honest deliberation. And I congratulate Pradna Bhalerao madam and Saroj Bande madam to choose sir as a chief speaker. I think nobody else than Borse sir to speak on medical management of COVID. त्यांना खूप मोठा नैतिक अधिकार आहे जो आम्ही सगळ्यांनी पाहिलेला आहे. आणि whatever could come in COVID as a new, he was always used to guide everybody across the Maharashtra as well as at country level also. So congratulations, sir. And it's nice to go back to the timeline to what you experienced. We all experience, all of us experience. Thank you so much, sir.
Working in the government hospital, you know a lot of burden that is going to be there from the higher authorities, from the secretary, from the director, from the government, from the Nagar Sevak, from the ministers and so forth. And then we used to have almost daily VC with our director and secretary. Daily VC about what happened today, what are the drugs that you are, and then updating that used to happen. And equal sharing that was there from the anesthesia, Surekha madam, Prajna madam, Naik madam. They used to contribute, like anything, and it used to be a fun But then let us hope that this fund doesn't come again.
Question, please. Can I ask only one question? In the COVID era, most of us suffered from this disease, dreadful disease. So, may I ask if you suffered and what treatment schedule you followed?
Sir suffered. Basically, I tell you, when the vaccination started, before vaccination, I did not have any symptoms. But when the vaccination started, I was the third person to receive the first dose in the Sassoon.
No, it doesn't.
Doesn't matter. So I was the third person to receive the first dose of the vaccine, Covishield. I had a little bit of fever for only one day, and that I attribute it to because of the vaccine itself. And then, importantly, I took this particular vaccine on the way while going to the COVID-19 building, where almost 600 patients were waiting for me. So I took this thing, then I went for this work. During the second wave, I got COVID, but then fortunately, it was mild. It was a symptomatology that was there only for 3-4 days. Absolutely okay. I didn't require even antiviral. I didn't require even the steroids. Not inhaled steroids also. I didn't take anything. After 5 days, I was perfectly okay, and I was back almost after 7 days of the waste.
And besides, sir, suffering himself, I think we had many VIP cases, like all doctors, nurses, paramedicals, and judges, and whatnot. I mean, all senior citizens, previous teachers, everybody used to come to Sassoon, and that was a tremendous pressure on all of us to treat them and send them back home. I think that was a big toil. And sir sir was ill because of his hypertension, maybe, because so much pressure he was undergoing, because from everywhere, from patient level as well as from higher authorities, till PM level also. That was the biggest difference what COVID was to others than to Sassoon Hospital. Yeah.
Thank you so much, sir. I now request our chairpersons, Dr. Surekha Shinde and Dr. Yogesh Gowli, to please felicitate Dr. Borse, sir. Thank you so much, sir. I now request Dr. Sarita Swami and Dr. Shalini Sardesai to please come on dais to felicitate our chairperson. Thank you, ma'am. I now request Dr. Surekha Shinde and Dr. Yogesh Gowli to please felicitate Dr. Harshad Dongre, sir.
We'll now be moving on to our next session. The evolution of neurosurgical practice is accompanied by new challenges for the anesthetist, with greater focus on functional and minimal invasive procedures. And with the increasing popularity of awake craniotomies, there is even more emphasis on this skill. In the light of this, I request Dr. Sangeeta Chandrasekhar to come up on stage and commence our next session on neuroanesthesia, the learning curve.
Thank you very much. We are cutting off the tea break due to shortage of time. So moving on to neuroanesthesia. Research, clinical innovations, and advanced technology has changed the face of neurosciences and neuroanesthesia in the last 2-3 decades. We have chosen two topics, awake craniotomy and neurointerventional anesthesia. These are the two topics where we thought the anesthesia techniques, they need very fine anesthesia techniques, coordination with the surgeons, as well as the outcome of these two patients, they depend on the expertise of anesthesiologist. To chair this session, I invite upon Dr. Shalini Thombre, Madam. Madam is very senior anesthesiologist, everyone knows about her. She was instrumental in establishing the anesthesia department at SKNMC as well as emergency medicine department and D.Y. Patil Medical College, and has many awards and publications in her name. I invite upon Dr. Roshan Thomas, Madam. She is a senior consultant at Jahangir Hospital, has extensively worked in transplant anesthesia, has interest in neuroanesthesia and orthopedic anesthesia. Both of these, along with our eminent speakers, both of these consultants, dignitaries have extensive experience in neuroanesthesia. I hand over to them to invite our speakers today. Dr. Vikas Karne, sir. Slide.
Dr. Karne is a senior consultant and head of the Department of Anesthesia in Sahyadri Specialty Hospital. Rest of the introduction is there. I think because the visual impression is better than the auditory, so the organizers have wisely decided not to introduce verbally but in a visual form, audio-visual form. So this is the introduction. Dr. Karne belongs, and I request Dr. Karne to start his deliberation.
Thank you, madam. Good afternoon to chair and to all my seniors, my teachers, and my dear colleagues. Today I'm going to talk about, the session is learning curve, and I'm going to talk about awake craniotomy. And the topic given to me is awake craniotomy, what is AAA? So we'll start now. So this is just a small representation. I have cut off the audio for the sake of confidentiality. So this is one of our patients who is undergoing supratentorial tumor excision, and this has been recorded when the actual tumor is being excised. So it's about neurosurgery in a patient who is awake, and this is what my topic is. And why do we do awake craniotomy? Because we are dealing with a lesion which is close to the eloquent area. So we want to have maximum resection without causing any damage to either Broca's area, Wernicke's area, or primary sensory or motor area. But primarily the awake craniotomy was proposed and conducted for epilepsy surgery. So that again remains one of the major indication for awake craniotomy. Now it is also commonly done in deep brain stimulation, which is performed in patients with movement disorders. When we are dealing with awake craniotomy for epilepsy surgery, we do something called as ECOG, that is electrocorticography, where most of the anesthetic agents have their own influence on electrocardiography. So that is where awake craniotomy plays a great role, because we can avoid the influence of anesthetic agents on corticography. So when we are conducting awake craniotomy, what all things we can evaluate? So we can evaluate speech, where patient can do number testing, patient can name the objects. We can evaluate the upper and lower limb movement, that is motor testing. Along with that, there can be electrostimulation, where we can do brain mapping, speech arrest, ECOG, and also we can have neuronavigation to support. So this is one of the patient. I want to draw your attention to his foot. So this is taken from the head end. And this is how the upper limb is being evaluated. So this is all during the resection of the tumor that is going on. So we know where it is to be done, but when it should not be done, that needs to be understood first, because that is the key point, the patient selection. So when patient says, no, I don't want to be awake, obviously that's the end. But when there is a problem with the communication with the patient, coordination with the patient, like there's altered consciousness, psychiatric disorders are there, there's a cognitive disorders are there is a severe language barrier. Patient who is severely anxious, or there is a poor tolerance to the pain, and when there is a claustrophobia, these are the common contraindications. Along with this, extremes of age can also be a contraindication, but now in last half a decade, we have seen many young children also going. The youngest that we have operated upon is a 12 years girl who had undergone epilepsy surgery, awake craniotomy. Along with this, some pathological conditions like difficult airway, big no, morbid obesity and obstructive sleep apnea. We need to be patient specific when we are selecting the patient. Uncontrolled coughing, significant dural invasion, and highly vascular lesion. These are more of a surgical contraindications to awake craniotomy. So how do we proceed for awake craniotomy? So what is AAA? So conventionally, since the awake craniotomy is performed, the AAA stands for asleep, awake, asleep. So patient is sleeping in the first part. When the tumor is being resected, patient is awake. And when the closure is performed, patient again is in a sleeping state. But before we get into this concept, okay, we just briefly look at the steps. So when you're going for AAA, the patient is given general anesthesia, and then the patient is positioned. Then the craniotomy is performed, durotomy is performed. Then patient is got into the awake state for the neuromonitoring. And after the resection is done, then maybe patient is put on general anesthesia again or sedated, and the closure is performed. Now, these are the simple steps just to understand. So when we are dealing with awake craniotomy with general anesthesia, conventionally it is an endotracheal intubation that is performed. So that can be oral or nasal. Nasal is a problematic because if we have to awaken the patient, at the time of extubation there can be bleeding. And when we are making the patient awake and if you are extubating the patient, one of the things that we can do is there is a thin tube exchanger which can be kept, but the problem is if you are assessing speech during the tumor resection, that tube exchanger can be a problem. So when we are extubating, what are the problems that we may face? So there is a risk of coughing, gagging. Obviously that itself will increase the intracranial pressure, and the cranium is open, so risk of herniation is there. Risk of loss of airway, hypoventilation apnea, dangerous thing to happen which can lead to hypoxia and hypocarbia, so that itself can increase the intracranial pressure. There is a risk of aspiration if the patient is in partially sedated state and if the airway reflexes are not intact. And difficult access to the airway because the head is fixed in a fixed position and there are drapes around, and many a times it is not a neutral position. So whatever said and done, it is going to be a difficult access to the airway. So as an alternative to this, when we are performing general anesthesia, awake general anesthesia, that is AAA for awake craniotomy, the alternative that has been used in last 1 decade more commonly is supraglottic device. And the advantages that we get is with supraglottic devices, LMAs, we can have either spontaneous respiration or it can be a control or support ventilation. It is well tolerated by a patient. There is ease of reinsertion. It avoids laryngoscopy and avoids head extension. So in given position, we can insert the supraglottic device. And because of all these things, there is a reduced coughing and gagging upon the emergence, which we want to reduce as much as possible. So now, before we get into it, I want you to understand one important concept. This is what is going to be the reaction of our patient. When the surgeon says that you are going to be awake when I'm going to resect the tumor or I'm going to operate upon you, it's going to be a severe anxiety. Patient is going to be very nervous. There will be fear of getting pain, fear of getting discomfort. So what is required? What is required is a good counseling of the patient. Counseling of the patient along with the family by the surgical and anesthesia team. This counseling should be focused on psychological preparation of the patient to go through this process, because the patient is going to be awake throughout the process, and any discomfort, any agitation during the process is going to affect the whole purpose of this procedure. So what ultimately we want is a complete involvement of the patient. We need to develop a very good rapport with the patient, because we as an anesthesiologist are going to be in continuous touch with the patient when patient is going to be awake and the surgical procedure is being performed. We have to assure the patient that he will be comfortable completely, and we have to ensure him that we are going to be there to support him in case he gets pain, in case he gets discomfort. That kind of rapport needs to be developed. That's the key to conduct a successful awake craniotomy. So the pre-op assessment is it's going to be the conventional assessment, but then we should be focused on whether the patient has got epilepsy, what type of epilepsy, if it is going to be an epileptic patient, and what are drugs, how many drugs which are there, and whether it's to be continued or not. That decision needs to be taken with neurologist or epileptologist in loop. We have to look at the comorbidities and we have to optimize them, and any pre-existing neurodeficit needs to be recorded. In preoperative medications, anti-emetic prophylaxis in terms of pantoprazole and ondansetron, that is what we practice, but then institute to institute it will vary, and anti-epileptic prophylaxis to be continued. Now, whether to give glycopyrrolate or not. So it should not be given, preferably avoided, because it causes a lot of dryness of mouth, and that itself can be one of the major reasons for discomfort during the procedure. Same with benzodiazepines. Benzodiazepines are preferably avoided because it causes significant sedation, and other alternatives should be used. So preferably what we need to have a direct connect with the patient, where patient should feel comfortable while coming inside the operation room along with us without any sedation. That should be the aim. And it does happen. So we don't require a central venous cannula, we don't require invasive lines unless there is a specific indication. So what we need is a 2 good IV cannula in place, and no sedatives preoperatively. And this is the standard monitoring that we conduct. So I would like to insist upon ETCO2, whatever state, the ETCO2 is going to be the key guide for us. Depth of anesthesia monitoring in any form, people are using it, depends on availability, but it is not must. But if it is available, it can help us in titrating the doses in a better format. And what we need to prepare in addition to our routine preparation is emergency airway card. Preferably what we should have a video laryngoscope, a ventilating bougie, or a tube exchanger, and supraglottic devices in our armamentarium there. Whatever said and done, in case if we land up in a situation where there is an airway emergency during awake craniotomy, remember it's a danger zone. It's really a dangerous situation. So how we go ahead? So on operation room, on the door, there has to be a board that our patient is awake. So don't just rush inside. Okay? There are some specific operation room etiquettes which need to be followed. We need to make sure that the OT is quiet and ambient temperature is comfortable for the patient without hampering the surgical requirement. The light should be kept at the minimum required level, and the minimum traffic is allowed inside. While giving position, the table cushion should be in a way where patient feels comfortable, because this is going to last at least 3-4 hours. I'm saying at least 3-4 hours. And while giving the position, the neck extreme extension and extreme flexion or extreme rotation should be avoided. We have to make sure that while giving the position, we have a full access to the patient's face, patient's airway, and patient's vision. We need to maintain eye-to-eye contact when the procedure is being performed. And ultimate aim of anesthesia is to have a comfortable, immobile, and a cooperative patient. And how do we achieve it? So it all depends on the kind of analgesia that we are going to give. So that analgesia can be obtained with individual nerve blocks, or we can give a scalp block. We can give Mayfield pin site block. I'll come to this, and surgical incision site infiltration. So if we are giving all these things together, you can imagine kind of volume of the local anesthetic that we require. And there is a risk of local anesthesia toxicity. So we should be wise enough in calculating the maximum allowable dose, maybe combining different anesthetics local anesthetics and decide how we are going to proceed. And we should aim specific nerves rather than giving a global skull block. So we all know that these are the 5 nerves: supratrochlear, supraorbital, zygomaticotemporal, auriculotemporal, and greater and lesser occipital nerves. So these are the specific nerves. Every nerve will require at least 3 ml. So 18 ml itself is over here. And the red points we can see. So these are nothing but the local infiltration given to fix the 3 pin while giving the head position. Now what happens, like we have to customize this for a patient, we also have to customize it to the surgeon and the surgical technique. For example, if we are going to use a brain navigation intraoperatively, the surgeon would like to have head position fixed before the navigation is done. But if you are going to infiltrate local anesthetic, the swelling that occurs because of the infiltration is going to interfere with the neuronavigation recording. So what we have to do, we have to sedate the patient probably and fix the head, get the neuronavigation recording done, and then we should giving a nerve block. So different local anesthetic that we can use, we can dilute the concentration, we can use bupivacaine and ropivacaine as a combination for different nerves. And we can keep xylocaine available for dura, because few surgeons, they use 4% xylocaine in a diluted format for dura. This is we all know the maximum dose allowed. So this is about asleep, awake, asleep. So we give general anesthesia with endotracheal tube or LMA, awaken the patient, and towards the end, either we reinduce or we sedate the patient. Over last decade, the concept has changed to monitor anesthesia care. So what we are going to do is, without giving general anesthesia, we achieve a moderate level of sedation where patient is comfortable and with which we avoid any manipulation of the airway. So same steps that we have seen, but here there is no airway manipulation, there is no general anesthesia, but we are giving sedation. So it becomes easy to get the patient from state of moderate sedation to awake state and still keep the patient comfortable while the procedure is conducted. So with moderate sedation, the advantage that we get is spontaneous breathing, spontaneous airway control, and responsive to call. So we are more in a comfort zone, but obviously this is more challenging. So monitor anesthesia care is gaining popularity because there is a short-acting titrable sedatives available, rapid onset, rapid recovery, lack of drug accumulation, and a predictable dose response. Few adverse effects are there as compared to general anesthesia. And the most important thing that I have already told you, that decreased possibility of respiratory and airway complication as the airway is not being manipulated. So during the procedure, we supplement oxygen either through nasal prongs or mask and EtCO2 cannula. So for even awake patient, we need to have a EtCO2 cannula, and we should be, so that will guide us the respiration of the patient. So it is not only about the EtCO2, but mainly about the respiratory drive of the patient. So this is one of our patients, just to give you an idea. So this patient has been given sedation with fentanyl and dexmedetomidine, and I just want to highlight the EtCO2 tracings in an awake patient. And I'm sure most of us have started doing this in complex cases. So the choices left to us for sedation is remifentanil is obviously not available, but fentanyl, propofol, and dexmedetomidine. So we know the advantages of all the drugs. I'll just highlight with propofol, there is a decrease in the ICP, decrease in cerebral and metabolic rate. I'll need a couple of minutes more. Anticonvulsant effect and antiemetic effect. However, it can cause respiratory depression at higher doses and can cause hypotension, and there is no added advantage of analgesia with propofol. Dexmedetomidine provides analgesia, has less effect on ICP, and it is also sympatholytic. However, in higher doses, it can cause bradycardia, hypotension, and dryness of mouth. So if we compare both are effective, both are safe, and what is the key is good local anesthetic or good nerve block is going to be the essence of the awake craniotomy. So propofol and dexam, though we saw that there is comparable with dexmedetomidine, we can have some advantage, that is, it gives a constant state of sedation and analgesia, which is not happening with propofol. Decrease opioid requirement, it provides better hemodynamic stability, and there is no respiratory depression. That's the beauty of dexmedetomidine. These are the doses. So fentanyl can be given at 0.5 to 1 microgram, propofol in a 50 to 150 microgram per kg per minute, and dexmedetomidine bolus is given 0.5 to 1 microgram per kg, followed by an infusion of 0.3 to 0.7 microgram per kg per hour. This is the standard dosing that we are using for any case. So which technique is better? Whether the asleep, awake, asleep technique is better or monitor anesthesia care is better? So there is no consensus. There are no reports to say that one is better and one is bad. But what is need to be done, it needs to be customized to the patient. We need to look at the patient. What is his pain threshold? How is he psychologically? How much involvement he is ready to give? And how he is going to take? So we need to have an assessment of the patient's psychological profile and decide. This is the progress of awake craniotomy from this GA to monitor anesthesia care. So complications that are seen is, highest seen complication is seizures intraoperatively. And please remember, whenever there is a seizure, don't give midazolam to these patients. Okay, the simplest thing that we should be doing is pour cold saline. Okay, midazolam is going to again affect the whole purpose of this particular procedure. Propofol can be given if it is not responding in a small doses. It can cause excessive sedation, hypertension, can cause nausea, vomiting intraoperatively. There can be postural discomfort if the procedure is prolonged or the odd position is given. There can be agitation and pain intraoperatively. Respiratory depression can occur. And brain swelling can occur intraoperatively along with LA toxicity, the risk of LA toxicity. These are the possible complications. So this is how the awake craniotomy is, progressed from general anesthesia to awake state to only monitor anesthesia care with a good local anesthetic blocks. Okay, so what all advantages that we have seen in last 3 decades with awake craniotomy? So with this, there is a greater extent of tumor resection, which facilitates enhanced recovery, fewer neurological deficit as compared to the craniotomy under general anesthesia. Patient may require only monitoring in the high dependency unit as compared to ICU. Shorter hospital stay, shorter ICU stay. It reduces post-operative morbidity. Longer survival has been reported in few of the cases. And in addition to this, for us, it is also turning out to be cost effective. So with these advantages, there is a growing trend of conducting awake craniotomy, and people are finding reasons, not only which we discussed at the beginning of this session, which are related to the lesions related close to the eloquent area or epilepsy, but other than that, where a simple small brain tumor, which is on the surface of the brain, ventriculostomy, then stereotactic procedure, even the cranioplasty has been performed as awake craniotomy. So this is a new trend, this is a changing trend. So when this was told to me that I have to talk about AAA, I was just thinking that what I am going to discuss with you all, that GA, which is now is not a routine technique. So how we are going to move ahead? So I want to bring in this thought, which has been coming in very largely, that people are trying to conduct awake craniotomy as a complete awake patient with only LA. But that is also going to be a challenging thing, because that requires a lot of cooperation from the patient. So from moderate sedation, we can come to conscious sedation and give a good nerve block, and this could be a possibility. So that is going to be a future. That is how we should be, we should be hopeful. So from asleep, awake, asleep, probably we are moving to another AAA, that is awake, awake, awake. And probably that could be the future of awake craniotomy. So just to summarize, awake craniotomy, the techniques are getting evolved, but no technique is better than other and needs to be customized to the patient. Plan needs to be customized as per the psychological and physical status of the patient. And we need not forget that we need to be equally awake. We need to be equally vigilant, because This is not where our patient is on ventilator and monitor is beeping. This is where we have to be on our toes and be prepared to handle any emergency, which is a reality. We have seen emergencies happening during atherectomy, but it's a challenging but enjoyable job, definitely. So I thank you all for your kind listening. If there are any questions, I'll be happy to answer.
What is the role of saline for the epilepsy?
Yeah, see, during epilepsy surgery, those foci which are throwing the stimulus, okay, they easily respond to the cold saline irrigation. So the electrical stimulus is coming out is controlled with the saline.
So surgeon will be doing it?
Yes, surgeon will be doing it, obviously. So it requires a good coordination between surgeon, anesthetist, patient, and if you have a neurophysiology monitoring person. So these four people needs to be, in continuous coordination. So there has to be a continuous dialogue between these four people.
Anytime you require to convert the local into general?
Only once that was, but that was in a very early phase. So patient had seizures on table just at the time of craniotomy. So we still had enough time in our hand to convert it. But in that case, we had used supraglottic device. LMA was used in that case. But we have seen seizures happening. We have seen other complications. We have seen certain patients getting hypoventilated, but then titrating the doses. But with dexmedetomidine, there has been a huge difference between what we used to see only under propofol and fentanyl and dexmedetomidine now. But we have to, titrate it to the patient. Yes, ma'am.
What is to be done if the seizures don't get controlled with saline irrigation?
Then we have to use propofol. And if it is not, yes, ma'am.
But if at all we don't want to use any sedative drug, can you use some other anti-epileptic?
No, because that point we have to abort the seizure. So what we'll have to do is, in that case, if it is non-responding or it is refractory, then we might have to use benzodiazepines there with a preparedness to handle the airway.
Okay.
Sir.
Three different local anesthetics. What you mean to say is the toxicity effect is not additive.
No, I didn't mean that. I just mentioned three different local anesthetics, keeping xylocaine available only for the surgeon, using levobupivacaine or bupivacaine, whichever is available in a concentration of 0.25%. We are regularly using 0.25% bupivacaine, and it works well. There is no problem that we have to use only 0.5%. So with that, we get a larger volume. So 40 ml is enough. We can adrenalize it so that the effect lasts a little longer. That we have been doing regularly. And xylocaine we are keeping as a, for surgeon, because they need to sometimes infiltrate or inject around the dura. Ropivacaine, rarely it is required, specifically if the incision is coming very close to this area where the temporal muscle also needs to be infiltrated, because that becomes a painful part during the surgery if they have to retract too much over the temporalis muscle. So there, if you need something more than 40 ml, it is not fitting into that, then we use 0.2% or 0.5% ropine. But usually 0.25% bupivacaine with 4% xylocaine for the surgeon is usually enough.
But three different LAs don't have to be normally used.
No, not at all. Those were the options that were displayed.
Dr. Karne, what is the longest procedure you have performed under this?
Awake craniotomy? I guess it was like some 7 hours.
7 hours?
7 hours.
Do you have to repeat the local infiltration?
No, in cases which are difficult cases, what we do is we use adrenaline, and to that we add dexamethasone.
And have you come across any local anesthetic toxicity?
No, not.
Doesn't fatigue set in 7 hours?
Yes, yes. These are the cases where we have to use sedation to its maximum. Especially once the tumor is relieved, because patient has a lot of patience till we say the word, okay, it is done. The surgeon announces it is done, and then patient starts getting restless, and that is where we have to use the sedatives. Otherwise, the cases which are lasting less than 4.5 hours, we most of the times now what we are observing is, even after the tumor resection or the epileptic focus has been removed, patient still remains cooperative during the closure if the local effect is good. So you don't have to sedate them in the third part.
So if at all you expect that the surgical time will exceed, do you catheterize the patient?
Yes. So that catheterization is done preoperatively, preferably before the patient is shifted from the ward to OT, because we don't want to have an stimulus, painful stimulus, at least an hour before the patient is taken inside the over.
Have you tried any music?
Yes. Most of the times, it's not there in the slide, but most of the patients, they enjoy some background music. And we give them a choice what you want to listen. We had one patient who was singer. She did not sing during the procedure, but she really enjoyed listening to the Marathi classical music. No, we have to give a bolus and then continue as a drip. We usually give 0.5 to 1 microgram depending on the patient, and then the infusion is 0.3 to 0.7 microgram.
In the beginning, before starting the
Before
surgery,
starting.
you give.
So what
How
we
much
do-
time before?
See, I'll tell you, what we do is, we usually, once things are ready, we sedate the patient in the recovery room. So what we do is, we usually give fentanyl, 1 microgram, and we start the dexmedetomidine drip, and it's given over 20 minutes. So after 10 minutes, we start shifting the patient inside the OT. So by the time patient comes on the table and monitors attached, a good level of sedation is achieved with a adequate ventilation going on. And once this is done, then we continue with the blocks and other activities.
And sometimes the surgery is started in local. And then in between the surgeon said, "Madam, give me something, sedative or something." What is the preferred drug at that time?
Propofol.
Propofol.
Yes,
But
low dose.
if there,
It depends on patient.
hypertension and pain also. For pain.
Depends on patient. We can use fentanyl and propofol combination also. But usually it doesn't happen that we have started only in local, because in the first part, we need some sedative to make the patient comfortable.
No, specifically for burr holes and something emergency surgeries, they prefer sometimes doing in local.
No, but in emergency surgery, we cannot offer anything. See, because giving sedation can cause deterioration, neurological. So we will be losing that.
So only propofol is preferred that
I
time.
request
Only
the
propofol.
No, preferably avoid anything or convert to GI.
I request the audience to have the questions in the lunch session because we are already running short of time.
Thank you. Thank you, everyone.
I request the chairpersons, Dr. Shalini Thomre and Dr. Roshan Thomas, to felicitate Dr. Vikas Karne.
काही नाही सर, इथून फक्त प्रेझेंटेशन सुरू करणार आहे. इथून प्रेझेंटेशन सुरू करणार आहे फक्त. हां सर, त्यांनी कुठं प्लेस केलं?
Another controversial topic for us is always conscious sedation versus general anesthesia in cath lab for mechanical thrombectomy. I will invite upon Dr. Joseph Monterio to deliver his lecture on challenges in anesthesia for management of acute ischemic stroke in radiological interventions too.
Full slides.
होल्डिंग स्लाइड होती है. का वाटत सुरू कर. Up next, back. Up next, back. Slide
Dr. Joseph Montero, Senior Neuro Anesthetist of Hinduja Hospital and Medical Research Center, Mumbai.
Yeah, okay. This is only one. Yeah. Okay, enough. Go to the. No, where is it? Is it going to start? Thank you very much for this opportunity, and I'm very privileged to be in Pune. It is for nothing that Pune is called the Oxford of the East, and I'm happy to be here. This is my first time at PROACT. I like to see the vibrant and quite a homely discussion going on since morning and very good speakers. So I have been asked to speak on anesthetic challenges in the management of acute ischemic stroke in the interventional radiology suite. Can you display the slides? Yeah. And this will not work? So greetings to you from Mumbai. I practice at Hinduja Hospital, Mumbai. And What is the problem we face? Acute ischemic stroke is seen in about 9 million cases, causing more than 3 million deaths per annum. In the US alone, ischemic stroke is the cause of more than 87% of strokes. And currently, 67 million stroke survivors are present throughout the world. It's a growing problem. We have got a larger geriatric population, and we have seen from the previous session, COVID is also causing a lot of thromboembolic diseases, and that is also added to the problem of ischemic stroke. So very often we see a lot of foreign data, and I was very keen to see what the Indian data we have. So this is an excellent review article published by Sarabjit Khurana et al., Burden of Stroke in India during 1960 to 2018, a systematic review and meta-analysis of community-based surveys published in Neurology India. So the details are very small there on the front, but I just want to tell you that the prevalence is quite high, both in urban and rural India. And interestingly, the incidence and the prevalence and the mortality is less in the rural population as compared to the urban population. Probably they're less stressed and they have a better lifestyle. So ischemic stroke is defined as an episode of neurological dysfunction caused by focal or global cerebral, spinal, or retinal infarction. And ischemic stroke occurs when the blood flow through an artery supplying the CNS with oxygen and nutrients becomes severely impaired. So this is a very nice North American clinics on acute ischemic stroke, and the authors were Kate Perry et al., and they have tabulated very beautifully the causes and the categories of ischemic stroke, type, etiology, and the risk factors. So the most common is thrombotic, which is the etiology is atherosclerosis, and the risk factors being hypertension, diabetes, hyperlipidemia, obesity, lack of exercise, smoking, and carotid stenosis. And the embolic causes are the etiology being cardiac, most importantly, atheroembolic, and dissections. And the small vessel diseases also contribute to stroke, that is CADASIL, and the others being hypercoagulability, vasospasm, and to that I will add COVID, I think. So this is an excellent seminar by Bruce Campbell et al. From Melbourne, Australia. And they said stroke is a major cause of death and disability globally. The diagnosis depends upon the clinical features and brain imaging to differentiate between ischemic stroke and intracerebral hemorrhage. Now here we come to this non-contrast CT can exclude a hemorrhage, but the addition of CT perfusion imaging and angiography allows a positive diagnosis of ischemic stroke versus mimics and can identify large vessel occlusion targets for endovascular thrombectomy. So this is one big game changer that has occurred in the last 10 years. So along with the treatment, what's very important is the quality of diagnosis that's available and the development of radio diagnosis. You can see the quality of the images here, the contrast CT, the digital angiography. You can identify the lesion, you can delineate the target, you can prognosticate the disease, and you can also initiate the appropriate type of therapy depending upon the advanced technology that is providing us with such excellent imaging, and that has changed the level and the quality of care. Now, this is a little busy slide just to show you that people who are treated in stroke units and who are treated for stroke, they have a better outcome. Very interesting. So now here we go. Not treatment and a conservative treatment is followed by poorer outcomes. But patients who have undergone treatment for stroke, they undergone an emergency treatment, as is when indicated, they have a better outcome, and preferably in an institution that is doing this on a daily basis, the quality of treatment is better. So this is an anesthesiology meeting, and what are the main neurological procedures we do in the interventional radiology suite? So it's cerebral and spinal cord angiography, super selective anesthesia functional examination. The therapeutic procedures we do is opening procedures, that is chemical and mechanical thrombosis in acute ischemic stroke, and many others. So all of you all who have been to the interventional radiology suite have done some of these procedures. So when it comes to the brain, every minute counts, and time is brain in stroke. The ischemic brain cells die at a rate inversely proportional to the blood flow, and restoring blood flow halts stroke progression. So now we are focusing on what we call sight to sweet time. That is the moment it is identified and you're in your home or wherever you may be, the quicker you're taken to the, not only to the hospital, back straight into this interventional radiology suite, and the treatment is initiated, that makes a big difference to the treatment. Of course, in cities like Bombay and Pune, I don't know, but traffic could be an issue. But here, I want to focus on awareness. People should be aware. This treatment is possible, this is treatable, and you can get a better good outcome. So awareness, education of the people, and also setting up stroke units in hospitals. So you press a number, a code number, and with that, the whole system gets activated. So the moment the patient is activated, he comes to the hospital, he's whipped up into the interventional radiology suite, the anesthetist is already there, treatment is started. So this is one thing we must focus on, trying to decrease this sight to sweet time. For if any students in the audience, I would like to say the thrombolytic agents, that is fibrin specific, which they may come across. Good to know the dose, the half-lives, and the salient features of these drugs, like atteplase, tenecteplase, these are also like tongue twisters. And so you will encounter them in your practice. So you must know the treatment, the dose, and the side effects, okay? And when you give any treatment, you must also know when not to give it. So what are the contraindications to the treatment, and what are the risks involved? You can get a head bleed, you can get a coagulopathy. So in such cases, you'll think twice before using these drugs. And suppose you use this agent and you get a bleed, then what do? So you stop the infusion, proceed with the laboratory test, do a CT of the head, start a cryoprecipitate transfusion or tranexamic acid, a hematology and a surgical consult, and manage the blood pressure, okay? And the antiplatelet medications which we commonly encounter here in practice are, of course, we are all aware of them. So once again, just to make it complete, and the oral anticoagulants you may encounter are these. So now, how many of you all have actually worked in interventional radiology suite? Yeah. So now, ideally speaking, it should be very close to the operation theater. But in my hospital, unfortunately, I purposely made the site small, remote. It is very far. We are in the operation theater suite, which is on the 3rd floor, and our interventional radiology is on the 1st floor. I have counted the number of doors, 3 floors. If you rush down, you can't get a lift because the patients and the relatives are taking it. So what is called the staff lift, they were available to us. So you have to run down 3 floors. I counted there are 8 sets of doors which you have to dart through, and then you reach the interventional. So, you know, planning also should be good. The prospective planning of your suite, that is also important, rather than retrospectively activating these systems. Here we've got a very good set of neurointerventionists who work in our hospital, state of the art. But I'm showing you this picture because here, they are all interested in the imaging, they are all interested in the treatment. Where is the anesthesiologist in all this? Can you identify them? So you're very distant, you're very remote. It's a very peripheral state. And another thing that happens very often, the junior most anesthetist is sent here. Understood? The seniors are busy doing very exclusive cases in the theater. And the junior most poor houseman or registrar is sent there. And he is so isolated, there's no telephone signal there, the mobiles don't work. So if he wants for help, they say, call me if there's any problem, but the poor chap should be able to call. So just to make you see the real picture. Once again, you could be disconnected, very lonely. Not only you, the patient too. Patient is whipped into that place, is cold, is almost remote and very lonely. And here, once again, you see that all the attention is on the screen. There I found my student. She's my 3rd year neuroanesthesia student. Important here is also the radiation. When you go there, you must have your dosimeter on, wearing the appropriate thyroid shield, and look after yourself, because nobody's going to look after you except yourself. And important to have the crash cart activated. All the drugs should be checked. The emergency drugs should be checked. And familiarize yourself with the place. Now, I will also go to this very interesting article by Denise Battagliani, Chiara Roba, Adriana Lopez de Silva et al. See, there's a very important thing is brain-heart interaction after the acute ischemic stroke. There's a thing called, we call brain-heart crosstalk. So all these patients also have a cardiac dysfunction underlying. You can see there's a very good interaction between the autonomic nervous system, the brain and the heart. They are in continuous concert with each other. And now if you see the right-hand panel, different parts of the brain have different sort of cardiac issues. So let me go closer. So let us say the medial temporal lobe, it can cause tachycardia, cardiomyopathy. The insular cortex can cause arrhythmias. The parietal lobe can cause cardiac arrhythmias and myocardial infarction. So depending upon which part of the brain is affected, you can have a different kind of a cardiovascular complication. And here there's, once again, we're going to this endothelium inflammation. So the brain-heart sympathetic activity causes an inflammation at the endothelial level, and there's a catecholamine burst and a sympathetic burst causing an overdrive, and that leads to the complications. So one must always suspect that when there's a stroke, there can be an underlying cardiac event. So as anesthesiologists, how do you go about this? So it's very important to do your goals properly, and that's what I even give my juniors. So specific, measurable, achievable, realistic, and timely goals in your anesthetic management. And the brain requires hemodynamic stability, maintenance of the cerebral perfusion pressure, avoid secondary insults, patient immobility, rapid complication management, and smooth and rapid recovery. So what are the pre-procedure considerations? It can be an elective or emergency procedure. You review the preoperative status. You treat the intracranial hypertension, optimize the pre-existing conditions, and the impact of neurodysfunction, which is factored in your plan. Monitoring is important, vascular access, anesthetic agents, vasoactive drugs, muscle relaxants, and the airway control. So in vascular access, it depends upon the preoperative comorbidities. I prefer short, large bore catheters, which can be peripheral only. And if the patient has concomitant coagulopathy, you don't want to stick in a central line, because, of course, we all do this ultrasound guided sometimes, but you have to think twice before insert. The way the risk versus the benefit of the central line, especially if you don't have ultrasound. And arterial cannula can be side stream or dedicated. Now, very often, the neurointerventionist, he has got an arterial transduce, but they're always fighting for that use. So I normally ask them to put yet one more for me, so that I can see the pressure when I want to see it. The pros and cons of GA versus MAC, this is another question. So for GA, the benefits are immobility, high quality imaging, airway control and protection, and control of hemodynamic and respiratory variables. And the pros for MAC are reduces time delay, hemodynamic stability, intraoperative neuromonitoring can be done, and the rapid post-procedure recovery and short monitoring periods. And the cons are for GA. And so there's a lot of deliberation whether you should go in for GA or monitored anesthesia care. So there are many trials. I won't go into the details of all, but I must tell you that general anesthesia versus conscious sedation for endovascular treatment of acute ischemic stroke, the ANSTROKE trial published in 2017, they said that local is better than GA. And you can see the effect of hypotension is less, risk of desaturation is less, risk of aspiration is less or none, and the neurological examination is possible, and the groin puncture time is less. But now, which patients will you give GA, which will you give local? So this is yet another study by Bruce Campbell's group from Melbourne, Australia. The effect of general anesthesia on functional outcome in patients with anterior circulation ischemic strokes having endovascular thrombectomy versus standard care, a meta-analysis of individual patient data. So here they have seen no GA, GA, and standard of care. And you can see on the right panel, the modified ranking score showing the outcomes which are better. So once again, they have shown here when there is no GA, the outcomes are better. Yet another trial is going on, sedation versus general anesthesia for endovascular treatment in ischemic stroke, but the results are not yet declared, the SEGA trial. So anesthetic technique, the technique of choice depends upon your situation. So the choice of agents is based on the principles of neuroanesthesia, availability, and comorbidities. We can see here in the right top panel, the orange panel, ketamine and nitrous oxide both increase the cerebral blood flow and increase the cerebral metabolic oxygen consumption. All inhalational agents cause a dose-dependent increase in cerebral blood flow. So, and I put it in that order. So sevoflurane the least, isoflurane, desflurane, and halothane the most. And in the left lower panel, those drugs that decrease the CMRO2 as well as the cerebral blood flow, all the induction agents, dexmedetomidine is not an anesthetic agent, but it helps to decrease your anesthetic requirement. And so propofol, fentanyl is what we use mostly. Fluid management, It is CPP, goal directed therapy. I like the use of PPV, which is a non-invasive monitor, which you get from your arterial line. So that helps me to guide my fluid management. I find it more useful than having a central line sometimes. There are two types of trespasses, the neurological trespass, which is anatomical, and the anesthetic trespass. Most neurosurgeons and most neurointerventionists will always focus on the anesthetic trespass. Let me assure you, all of you are excellent anesthetists, and I'm sure you don't have to be told to avoid hypertension, increase the oxygen content and hypoosmolality. Don't be on the back foot. Teach your students also. So you must keep a watch on the trespass that the surgeon does or the interventionist does. So what he can do, direct vascular injury, ischemia, thrombosis. He's not going to come and tell you that, I've done this. But they'll always look at the anesthetist, tumne aisa kiya, whatever. Samjha na? So this is a nice slide for the students to see. Non-pharmacological neuroprotection. The focus always should be on physiological homeostasis rather than using magical pharmacological agents. Just a couple of pictures to show you a 37-year-old male presented with sudden loss of slurring of speech and giddiness. In the left MCA territory infarct. So the first image is pre-procedure angio, suggestive of occlusion as MCA bifurcation, and the second image is showing after the intervention it has improved. And a 74-year-old male, acute onset left ICA thrombotic occlusion, pre and post pictures. And the peri-procedural complications of endovascular procedures, cerebrovascular, peripheral and systemic, occlusive and hemorrhagic. So the Enchanted trial, I will go to it a little faster. Yeah, here. So the Enchanted trial, they described patients with acute ischemic stroke receiving treatment with IV at a place were randomized to receive intensive blood pressure lowering and usual care. The conclusion is, among patients with acute ischemic stroke undergoing IV at a place therapy, intensive blood pressure monitoring was not associated with improvement in functional status versus the usual care. I was happy to be a part of this group of the Indian Society of Neuroanesthesiology, where we framed guidelines for the treatment during COVID, both for anesthesia as well as for critical care. And this is available on the net. You can always watch it. We gave our recommendations. As the previous speaker, Dr. Bursi, said, it is not yet over. COVID is not yet over. So very important, simple techniques of before endovascular therapy, signs, symptoms, exposures, and how you go about it. Now here, what I want to say, there's no cookbook recipe. There can't be an Indian guideline, a foreign guideline, an American guideline. You have to do what's available in your institution, according to your protocol, according to your patient situation. So it's good to have institutional protocols in place and follow them. And yet another review by Ahab Frag saying where you can use GA and when you should not use GA. So very interestingly, they have said here, probably patients with anterior circulation strokes, you should use MAC. And posterior circulation strokes, general anesthesia. So now, once again, a little better idea and a little more objective way of approaching this problem. It's not about what you're forced to do. So you choose your patient in which you're going to give it. So to conclude, time is of the essence. TPA is a viable treatment option, and the risk versus the benefit should be balanced. The anesthetic techniques for mechanical thrombectomy are chosen to balance time to reperfusion versus time to need to support the airway. Commonly, LA versus or MAC versus a slick GA does not affect outcome. A high volume center with a dedicated neuro intervention team is required for efficient high quality management and outcome. Thank you. Knowledge is a treasure, should be shared and not hoarded. Thank you.
I request the chairpersons to felicitate Dr. Joseph Monteiro. I request Dr. Kalpana Kerkar and Dr. Maya Jamkar to kindly felicitate our chairpersons, Dr. Shalini Thomre and Dr. Roshan Thomas. request our chairpersons, Dr. Shalini and Dr. Roshan, to felicitate Dr. Sangeeta Chandrasekhar.
Perioperative and intraoperative fluid strategy is an important part of patient management and seldom poses various challenges. So here we have our next keynote address on prediction of fluid response, what's new. And I humbly request Dr. Saroj Bande to come over onto the dais and begin with our session.
Hello. Our keynote address speaker is Dr. Indrani Hemant Kumar. And next one, her slide. I want to. And she's Professor Emeritus at SET GS Medical College. And she's held many important prestigious positions at prestigious organizations. And because I've seen her videos of dance, I can, you can read that she has been awarded this Natya Kalaimani award and all. And I think probably God Almighty has given her more than 24 hours a day, perhaps. And as the Master of Ceremony was saying, we can't manage any of the cases without IV fluids. And today I'm sure she's going to enlighten us on the fluid responsiveness in all the situations. Welcome, Madam.
Respected Chairperson, Dr. Mrs. Bande, Dr. Pradnya Balerao, organizers of PROACT, PuneCon, my dear friends, I see many seniors over here, my humble obeisance to all of you. Today, I would be talking on a very clinically relevant topic, that is dynamic indices of fluid responsiveness, which all of us should adopt, not just in the critical care, but also inside the operation theater. Decreases in intravascular volume is common, especially in children, because of preoperative fasting or vasodilatory effects of anesthesia or because of significant blood loss. Patients are often fluid loaded perioperatively due to use of static methods of monitoring, causing established florid organ dysfunction, like gut and organ edema, with poor outcomes, while too little fluid causes organ hypoperfusion with worsening of organ function. Now, how much to fill in these patients? What methods should we adopt to determine the volume status of these patients is the question. Well, the heart and the lung interactions are influenced by the volume status of the mechanically ventilated patient alongside the lung compliance as well as the ventilatory settings. So we have to depends upon the tidal volume, the PEEP, etc. Now, these changes in stroke volume in response to changes in venous return and subsequent preload and the right atrial pressure can be depicted in the very well-known Frank-Starling curve. Now, if you look at this curve, it plots the stroke volume against the preload. And here, if you see, as you increase the preload, the stroke volume goes on increasing. Now look at this point A and point A dash. You will find that there is a vigorous response to this fluid bolus. And coming between A dash and B, you will find that there is a feeble response to the fluids. And between B and point B dash, you will find that in the Frank-Starling curve, you will find that there is absolutely no response to the fluid bolus. So this principle is utilized for getting all the dynamic indices. So the dynamic indices of fluid responsiveness, we can talk in terms of based on a self-fluid challenge, based on arterial blood pressure or the 8 arterial line, or you are having monitoring the cardiac output, based on plethysmography, based on ultrasound parameters. So the value of dynamic parameter is the ability to predict fluid responsiveness and obviating the need of unnecessary fluid loading. Coming to the first one, where we talk about an autofluid challenge. So that is passive leg raising. So what is PLR or passive leg raising? It's a test that predicts whether the cardiac output will increase with volume expansion. By transferring a volume of around 300 ml of venous blood from the lower body towards the right heart, the PLR mimics a fluid challenge without any fluid being infused. It is not very useful in the pediatric population because obviously you don't get a massive fluid challenge as in an adult. But it can be used in older children. The sensitivity is about 70% and specificity is 92%. So how do I do it? The first step is you should start from a semi-recumbent position and not a supine position. So this is the first position to start with here in a semi-recumbent position, because adding the trunk and lowering, adding the trunk lowering to the leg raising should mobilize venous blood from the large splanchnic compartment, thus magnifying the increasing effects of the leg elevation on the cardiac preload. So the PLR effects may be assessed by a direct measurement of the cardiac output and not by a simple measurement of blood pressure. That is very important. So it's not just that you have a leg raising and you measure the blood pressure. That is not done. You have to monitor cardiac output in these patients. So this is how you do it. The patient is in a semi-recumbent position and then the patient is having a leg elevation. So next step is PLR effects must be assessed by a direct measurement of cardiac output and not by, as I said, by blood pressure measurements. The arterial compliance and the pulse wave amplification could be altered during PLR, impeding the use of pulse pressure as a surrogate of stroke volume to assess PLR effects. That is the reason blood pressure cannot be used for measuring the PLR effect. The third step is the technique of monitoring cardiac output should be highly sensitive to transient changes and should be quick as the effect disappears within a minute. So you cannot have a PA line and then you inject a cold saline and wait that long and all. So that kind of measurement is not the one which should be used. The measurement, the monitor should be real time, such as arterial pulse contour analysis, an echocardiograph, or an esophageal Doppler. The PLR can even be assessed by the changes in end-tidal exhaled carbon dioxide, which reflects the changes in cardiac output in the case of a constant ventilation. Or the best is to have a non-invasive bioreactance cardiac output measurement, and with this it's very promising because it is completely non-invasive and only uses 4 electrodes in the thorax. Step 4 is cardiac output must be measured not only before and during the PLR, but also after the PLR when the patient has been moved back to the semi-recumbent position in order to check that it returns to the baseline. Because these changes in PLR need not be only because of fluid responsiveness, it can also be because of other conditions in the patient, such as abdominal, hypertension, intra-abdominal hypertension, or cardiac lesions. So all these can change. You may not get the same level of cardiac output as we started in the beginning. So therefore, you need to measure the cardiac output even after ending the test. So the rules. This rules out PLR changes due to inherent disease and not associated with preload challenge. And the last step is PLR must be performed by adjusting the bed and not by manually raising the patient's legs. Bronchial secretions must be carefully aspirated before the PLR, and if awake, the patient should be informed of what the test involves. So pain, cough, discomfort, and awakening could provoke an adrenergic stimulation, resulting in mistaken interpretation of cardiac output changes, and sympathetic stimulation will unduly increase the heart rate. So what are the advantages of PLR? So it's a self-transfusion Therefore, it is reversible. You can do it as many number of times as possible. It works regardless of breathing activity, tidal volume, lung compliance, heart rate, or presence of cardiac arrhythmias. There are no side effects. It's reversible. It is recommended in the latest sepsis guidelines. The disadvantages are the hemodynamic effects of PLR cannot be measured on simple blood pressure, measured invasively or non-invasively. You will need a high-end cardiac output monitor. Changes in arterial pulse pressure, which is best related to stroke volume, only imperfectly follows the effects of PLR on cardiac output, as is the case of a fluid challenge, and it is not useful in case of intra-abdominal hypertension or in a case of venous compression stocking in the patient. So what's new with monitoring the PLR? The perfusion index, which all of us know, derived from the plethysmography signal of pulse oximetry, is a surrogate for fluid responsiveness. So increase in perfusion index by more than 9% during the PLR and the pulse contour cardiac output of more than 10% is a sign of fluid responsiveness. So the perfusion index calculated by the ratio of the amplitude of the pulsatile signal, this is the pulsatile signal over the non-pulsatile signal, was shown to have an acceptable predictable ability to assess the fluid responsiveness. Now look at the perfusion index over here. So this is a case of hypovolemia where there is a fall in stroke volume and increase in systemic vascular resistance. The perfusion index is obviously very low in these patients. And in cardiac failure, again, the stroke volume is low, the patient is cold and contracted. There also the perfusion index is low. So here, now let us see in a patient who is fluid responsive and who is not fluid responsive, what happens to the perfusion index. Look at this, the first curve, the first curve over here, you will find that no sooner a PLR is performed, there is a small bump on the curve. Or once, and it returns to the baseline, once the PLR is finished. Now you have given fluids. Now once you give the fluids, you find that the PI is jumping again. And then it reaches a plateau. Whereas, look at a fluid non-responder. The PI, after you perform the PLR, the PI remains the same as with a volume challenge. So you find that the PI does not respond, does not increase. So this is typical of a fluid non-responder. Next thing which can be a surrogate of measuring a responder or a non-responder is capillary refill time. So you do that before and after a PLR. A decrease in capillary refill time by almost 25% should follow the PLR. So in that case, you find that he's a responder. A change in CRT is more predictive than absolute value for peripheral perfusion. And as you all know, we cannot use this in all those patients who are on noradrenaline drip and such patients we cannot use capillary refill time. So the next is the heart-lung interactions as basis of fluid responsiveness in mechanically ventilated patients. As I already said, fluid responsiveness is because of an interaction. It can be measured with the heart-lung interactions. The IPPV produces cyclical changes in intrathoracic pressures and which change the loading conditions of the ventricle. So one such thing is the stroke volume variation. The stroke volume, as seen in the arterial waveform, is area under the wave up till the dicrotic notch. Here you find it up to the dicrotic notch. That is the stroke volume. So stroke volume variation is the percentage beat-to-beat variation in stroke volume, which we look at as an indirect measurement of a cardiac output. So for this, you need patients with a regular tidal volume of at least 8 cc per kilogram with a regular rhythm. An increase in stroke volume variation more than 11 to 13% predicts fluid responsiveness. So you find that the stroke volume is varying from beat to beat. And here is one single breath is being given. In this one single breath, you find that the highest stroke volume is here, and then you find the lowest stroke volume here. So there is a difference. There's a percentage variation in the stroke volume in these patients. So that is called stroke volume variation. So let us look at the physiological basis. The CVP, as we all know, is just one data on the Frank-Starling curve, and it gives very little information on volume responsiveness. And I fully agree with Dr. Montero. He said, I don't look at the CVP, I look at pulse pressure variation. Yes, that is what we are supposed to look. So CVP is a static index, and it is no more considered important. So let us see. Now we have the CVP over here. So we have is just one data on volume responsiveness in this Frank-Starling curve. Now, if we can introduce a physiological change in the preload parameter. So this is the preload parameter. Let us introduce a physiological change in the parameter and monitor the cardiac output. We can determine where they are on the Frank-Starling curve and if they are volume responsive. So when I say, what change we can give? The change can be in the form of giving a transfusion. The change can be by increasing the intrathoracic pressure. It can be anything. So let us just produce one change on this parameter and let us measure what the changes in the Frank-Starling curve. So this change which we produce with a breath, with one single breath, positive pressure breath on the CVP is what we are looking at as stroke volume variation. So stroke volume variation is very accurate for predicting volume responsiveness than the CVP, and there are many, many, many studies which has proven that CVP is not the right parameter to measure, and one has to measure dynamic parameters such as stroke volume variation. So here we look at the heart, the lung. The thorax contains the heart, the lung, the systemic, and the pulmonary circulations. All of them are present in the thorax. So when we give one positive pressure breath, what happens? The intrathoracic pressure increases, the SVC and the IVC collapses, the preload decreases, and there is a transient decrease in the cardiac output, isn't it? So this parameter is utilized in the stroke volume variation. So the ventricular preload decreases, afterload increases during inspiration, and because of the right ventricle and through the ventricular interdependence, the left ventricle, so with an increase in SBP. So if we conceptualize several positive pressure breaths, this is what happens with one breath. Now we are conceptualizing several positive pressure breaths now, several positive pressure breaths. What is happening to the cardiac output? With every breath, there is a dip, then it increases. So you find that there are perturbations in the cardiac output, isn't it? So when you're giving multiple breaths, you will find that there is perturbations in this cardiac output. So if the patient is volume loaded and not volume responsive, as you find over here, you will find that the perturbations are extremely damped, isn't it? So by measuring the cardiac output, we can decide whether the patient, where the patient is standing on this Frank-Starling curve. And here is a patient who is on the upstroke of the Frank-Starling curve, and he is fluid responsive, and he is showing a lot of perturbations in the cardiac output, whereas this patient who is fluid loaded is not showing much of perturbations. He's on the straight, the plateau of the Frank-Starling curve. So then we come to what we call a systolic pressure variation. Now, all of us don't have cardiac output monitors, but we can always put an arterial line, isn't it? So if we have an arterial waveform, we can measure the difference in systolic pressure during the respiratory cycle with an assumption that the systolic pressures are surrogates of cardiac output. So those who don't have cardiac output monitors can put in an arterial line and then measure the surrogate of cardiac output, that is the systolic pressure. So here you find that the variables with the breath, that there is a increase, decrease, increase and decrease. So this variable is called systolic pressure variation. So here you find that the systolic pressure with every respiratory cycle, there is a virtual preload challenge here. So the difference between the maximum and the minimum systolic pressure over one respiratory cycle. So if you see that, and that is the percentage of that is the systolic pressure variation. So you will find this is at the end expiratory phase, you find that is the reference systolic pressure. The difference between the highest and the reference is the, what do you call, the upstroke or the delta up. And the difference between the reference and the lowest is the delta down. The delta down is more important in fluid responsiveness because how much low the SVC and the IVC collapses with the respiration, that determines the fluid responsiveness, isn't it? So the delta down is very important while measuring the arterial pulse waveform. So in the context of hypovolemia, the delta down effect is exaggerated with positive pressure ventilation because of a decrease in right atrial pressure and superior vena cava collapse. Then we have what we call as pulse pressure variation. What is that? We can also measure pulse pressure by tracking the systolic and the diastolic pressures. This is a very good surrogate again of cardiac output and very sensitive to volume responsiveness in any patient. So any value about 12% is highly predictive of fluid responsiveness. So therefore we have all the important, the systolic pressure variation, the pulse pressure variation and stroke volume variation, all of them measure the maximum and the minimum values over a full respiratory cycle and strike it over a percentage. So this is how you have, it's very pronounced. The pulse pressure variation, systolic pressure variation is very pronounced in the fluid responsive patient who is on the upstroke of the curve and who is non-responsive. And the variations are minimal in the flat part of the curve. So anything bit above 10%, we can say that they are fluid responsive. So there are many studies which have said that the sensitivity and the specificity is above 90%. So the stroke volume variation, pulse pressure variation is an excellent index of fluid responsiveness. So now we come to the various monitors which are available. As I said, you have non-invasive cardiac output monitor. We have the Vigilio, we have FlowTrack. We have non-invasive monitors like Cheetah, that is a bioreactance method, wherein it sends an electrical signal at certain frequency and to the heart and measures the changes in frequency as the blood rushes out of the aorta. So all these are various monitors which are available. If you look at this monitor, you will see that the cardiac output is 2.9, and I think the stroke volume variation is how much? 19%. Here, it is 19%. And if you look at this pulse pressure variation, if you look over here, there is, here the patient is properly fluid loaded and suddenly it goes up, which means here is patient must have had hemorrhage or something like that, needed fluid, and then we get the thing back, the curve back. So that is how we have to monitor the various, the stroke volume variation and pulse pressure variation in these monitors. The stroke volume index and SVV is based on bioreactance measured using non-invasive cardiac output, as I already said. So non-invasive cardiac output monitors are available nowadays, and we can use them for measuring any of these parameters even for cardiac surgery. The only problem with cardiac surgery is because the heart and the lung and the heart are open, so the kind of self-transfusion or the auto-transfusion which we are giving, or the increase in pressure which we are giving may not be very adequate, very accurate. So what are the limitations? Controlled mechanical ventilation must be present to induce the required changes in preload. Tidal volumes have to be large enough to facilitate significant changes in preload. Both the left and right ventricle must function on the ascending portion on the cardiac function curve in order to be fluid responsive. So you cannot have a patient with severe pulmonary hypertension or right ventricular failure who can have this happening. So with very high PEEP levels also, you may not have an accurate reading, and it is unreliable in cases of spontaneous breathing, cardiac arrhythmias, and doubtful in cases of low tidal volume, low lung compliance, and intra-arterial hypertension. So you need a challenge. So altered SVV which is not related to fluid, could be because of a small tidal volume, a high PEEP, pneumothorax, cardiac tamponade, pericarditis, intra-abdominal hypertension, NTG or SNP therapy. So how to overcome the limitations of SVV and PVV? What we can do is we can have a tidal volume challenge test. So if the patient is on a low tidal volume, increase the tidal volume to 8 ml per kilogram for 1 minute, and you look for the PPV. So at least a 3.5% change or SVV of at least 2.5% during a tidal volume challenge will reliably predict fluid responsiveness in case of low tidal ventilation. So transiently increase the tidal volume and check the PPV or SVV. So the next is the end expiratory occlusion test. So whatever I'm telling you now is all that which will increase the intrathoracic pressure. So one is by tidal volume, you can use it by end expiratory occlusion, or you can use the lung recruitment maneuvers. So end expiratory occlusion also does the same thing. Again, lung recruitment maneuvers, as intensivists, we know we have the 40 centimeter for 40 seconds. So you use the lung recruitment maneuver, we are doing the same thing by increasing the intrathoracic pressure and looking for changes in SVV, PPV, etc. So all these are other tests which can help you in determining whether its patient is fluid responsive. Now we have a very good monitor called Massimo. This Massimo monitor gives us what is called as breath variability index. It is a continuous non-invasive measure of relative variability in the photoplethysmograph during respiratory cycle that may be used as a dynamic indicator of fluid responsiveness. So if you see over here, the pulse index, the pleth index goes on varying with respiration again over here. So here in the Massimo monitor, they have given a number to it, a number from 0 to 100. So anything above 20 means that the patient is fluid responsive. So it uses the detected pleth amplitudes to automatically calculate the dynamic changes that occur during the respiratory cycle. Higher variability in the pleth form has been associated with preload dependence and fluid responders. So as I said, so a meta-analysis was conducted, and it concluded that the pleth variability index is a reliable predictor even in the pediatric population, except for the fact that you should ensure that there is a good contact force between the pulse oximeter sensor and the measurement site. So that they have found that the PVI, which is measured in the Massimo, is a very good indicator of fluid responsiveness. Here you have the PVI of about 24% as against a non-responder of about 10%. So what are the limitations of plethysmography-based indices? PVI can be influenced by peripheral perfusion. As I already said, a shocked patient, microcirculation is affected, sampling site and contact probe problems. All these are the patients in whom you have had vasopressors. These are the patients in whom these pleth-related monitors may not work very well for determining fluid responsiveness. Then we come to the last, that is the parameters derived from ultrasound. So transthoracic echocardiography assesses cardiac structures, function, as well as hemodynamic indices. We all know that it is non-invasive, it is feasible and can be repeated. Fluid responsiveness can be assessed with transthoracic echo by either volume expansion, which is actual or virtual, or respiratory variation. Virtual will be respiratory variation. So when we are using the ultrasound, so what we try to do is we try to look at the ventricles. In profound overt hypovolemia, preload is insufficient to allow adequate cardiac filling, and both ventricles appear small. But here you please rule out hypertrophy of the ventricle, and they are hyperkinetic. So this means it predicts a fluid responsive state of the ventricle. In severe cases of hypovolemia, the left ventricle is seen to collapse. In systole referring to as a kissing ventricle. Next we look at is the IVC distensibility index in mechanically ventilated patients. A small IVC diameter may, however, predict a positive response to fluid challenge. The IVC distensibility index is a percentage variation of the IVC during inspiration versus expiration in these patients. A distensibility index of more than 18% offers 90% sensitivity and specificity in discriminating fluid responders over non-responders. Distensibility index is measure the diameter of the IVC maximum and minimum and Stryker percentage. And measurement errors can easily occur in an IVC with a small diameter. That is how in children you have to be very, very precise. So we talk about collapsibility index in spontaneously breathing patient. Similar to that, see, look at the diameter of the IVC and look at it collapsing over here. And over here, you will find that the IVC is hardly collapsing. This is a non-responder. This is a responder. Again, here again, you will find this. You will find that there is hardly during inspiration and expiration, there's hardly any collapse of the IVC. So here is again a non-responder. One of the most important measurement, which is very useful, is measuring the maximum velocity in the left ventricular outflow tract. So a beat-to-beat variation in the LVOT maximum velocity during the respiratory cycle of more than 20% predicts fluid responsiveness to volume expansion. So what you are supposed to measure the aortic blood flow peak velocity, and that can be done by putting the probe on the suprasternal notch. And here you find a beat-to-beat variation over here. Here this is VT max, and this is minimum. This is the flow velocity, which is maximum. This is flow velocity, which is minimum. And then we strike a percentage. So notice that in this respiratory variation in aortic blood peak flow velocity is augmented in the fluid responder. Look at this. It is augmented like that, whereas it is same in the non-responder. Same thing, just extending it to a Doppler. Measurement of transcranial Doppler via the transfontanel approach in pediatric patients. So we are just taking advantage of the fact that the fontanels are open in pediatric patients and provides a window to not just evaluate the brain, but also to evaluate the various arteries and see the peak velocity in these arteries, like internal carotid, basilar artery, anterior cerebral artery, pericolossal artery, and middle cerebral artery. All of them can be measured using a transcranial Doppler, and it provides other information such as intracranial abnormality and cerebral blood flow in addition. So this, again, measuring the respiratory variation and measuring the peak velocity in various parts, various arteries in the pediatric patients is very useful to know whether these pediatric patients are fluid responders. So if you come to pediatric patients, this is the best approach to know whether the patient is fluid responsive or not. Whereas we have umpteen other approaches available in adults, in pediatric, this is the best approach. So again, VTI, measuring the velocity time integral in the patient using the long parasternal long axis view. So what you do is the machine computes the area under the curve for each heartbeat, which is the VTI, and the LV stroke volume can be calculated from the VTI. And these repeat VTI measurements on 3 to 5 consecutive beats to calculate the average stroke volume. And for stroke volume variation, increase the sweep speed because we don't know what the heart rate is. So increase the sweep speed and then measure the VTI in these patients and then see whether the patients are fluid responsive based on how much the area under the curve is. Here you find the area under the curve is more, here the area under the curve is less, here it is less. So it's like that. So abdominal compression induced SVI change in children. So now that we cannot do a PLR in a child, what we can do is ape a PLR by giving an abdominal compression in the liver. So a maximum of about 22 to 26 millimeter of force can be given on these mechanically ventilated patients, and then you can measure the cardiac output or stroke volume in the children. So that can be done, and that will tell you whether the child the SVI change is there or not, and where the child is there in the Frank-Starling curve. So what are the limitations? In patients in atrial fibrillation, a rapid heart rate, loss of atrial contraction, and irregular ventricular ejection can affect the hemodynamics, resulting in an intrinsic beat-to-beat variation in stroke volume. So that is the limitation of using the transesophageal, transthoracic echo. So we can also similarly use the transesophageal echo to determine and esophageal Doppler indices to determine the fluid responsiveness in a similar fashion. Coming to the last few slides. So a mini fluid challenge. That is what we are all used to, right? Even in anesthesia, in critical care. What we try to do is we give them about 500 ml or 300 ml to 500 ml fluid challenge. Well, a classic fluid challenge of 300 ml to 500 ml is not a challenge. It is a treatment itself. So if there is a preload responsiveness, if there is no preload responsiveness, then what do? Then it is so difficult to withdraw all the infused fluids, and we end up facing all kinds of complications due to overinfusion, isn't it? So what we now do is a mini fluid challenge. You give 100 to 150 ml of crystalloid or colloid over 60 to 120 seconds and measure the response of cardiac output or one of its surrogates. A 6% increase in pulse contour cardiac output induced by this mini fluid challenge over 2 minutes could predict fluid responsiveness, and a microfluid challenge is giving 50 ml over 1 minute. However, it needs, again, don't go by blood pressure, it needs cardiac output measurement to assess the effect, and that and again it has no further advantage over PLR. So PLR is easier to perform, therefore PLR is better. So what are the differences between pediatric and adult population? Pressure-based parameters such as PPV and SPV is a poor indicator of volume management in children due to differences in anatomical and physiological characteristics, like compliance of the blood vessels differ. Blood vessels become stiffer with age, and therefore the peripheral and the proximal arterial wall distensibility decreases with increasing age, which affects the SVV, SPV, and PPV. Respiratory compliance of children can be larger than that of adults because the compliance is changes in intrathoracic pressure transmitted to the vascular system may be less when applying the same tidal volume per weight to the pediatric population. So the pressures which we are giving may not be adequate enough for children. Cardiac ventricular compliance is decreased in the neonatal heart. The presence of preload responsiveness does not mean that fluid should be infused. Remember that. Just because there is a fluid responsiveness doesn't mean you give the fluid. Evaluation should be done to the usual indices such as skin mottling, CRT, lactate, venous oxygen saturation, and carbon dioxide derived indices. All these are other indices which have to be considered before you can give a fluid challenge, and do not give fluid if risks exceed the benefit. So to fill or not to fill is the question frequently faced by anesthesiologists and critical physicians in hemodynamically unstable patients, and dynamic indices provides the answer and is considered the gold standard in critical care and in anesthesia. Thank you very much.
Thank you, madam, for telling us about so many ways to know about the fluid responsiveness. May I call the master of ceremony now?
Thank you so much, ma'am. I now request Dr. Saroj Bande to kindly felicitate Dr. Hindrani, ma'am. I request Dr. Nilima Gande to please come on stage. I request Dr. Nilima to felicitate Dr. Saroj Bande, ma'am.
Now we come to the most awaited session of the PROACT Pune Conference 2022, the AM Deshpande oration. I invite Dr. Joy Shankar Jana to take over the proceedings for the next session.
Thank you so much. This is the most awaited moment of ISA Pune City, and we are conducting this oration every year since the time we started PROACT PuneCon. And till now, we have never missed an oration. And for this oration, we have always invited the best faculty to give this oration. And it is an honor for ISA Pune to start with the oration. I request that nobody leaves the hall during the oration lecture. So I invite Dr. Pradnya Bhalerao, Honorary President of ISA Pune, as a chairperson. And it is indeed honor as a President of ISA Pune to confer the oration lecture today. So Dr. Pradnya Bhalerao. Then I invite Dr. Sunita Khedkar, Honorary Secretary of ISA Pune, for organizing this oration, and Dr. Sade sir, who is the President-elect of ISA Maharashtra, for this. So here on, I request Dr. Pradnya to carry on the oration lecture.
I will directly go to the introduction of Dr. Anant Madhav Deshpande. He was a larger-than-life figure, a numero uno among anesthesiologists. He was popularly known as Bala Saheb Deshpande. He was born on the 3rd of September, 1932 in Karad. He graduated from the BJ Government Medical College and did his residency in the Sassoon General Hospitals from 1959 to 1960. He completed his diploma in anesthesia from the Bombay University in 1961, worked in UK for 2 years and achieved his DA London. Later on, he was an honorary associate professor at the BJ Medical College from 1965 to 1970. Got his degree in anesthesiology from the Pune University in 1970, was an honorary professor thereafter, and after 1996 to 2012, he was a professor emeritus. The only national conference which was held in Pune in 1976 was under his guidance. He was the founder member of the Pune City branch, the founder president of MSCISA, that is the Maharashtra state chapter of ISA, and the chairman of the board of studies. He was always a prominent figure in the state, national, and international anesthesia conferences. And as you can see, many of us got opportunities to present along with him. A pioneer who established the concept of cardiac anesthesia in Pune, he had several distinctions to his credit. He was compassionate, helpful, and strived for the best. And he brought out the best from the ordinary. The AM Deshpande oration has been held in his memory in the various PROACT conferences which we had to date, and this is the 7th oration. I would like to call upon our orator for today, Dr. Anjali Kusurkar. We would like to pay our respects to Dr. A.M. Deshpande. I request Sade sir and Dr. Sunita Khedkar to come on stage. Now let us begin with the oration. Now I would like to introduce Madam only in brief. She has been an excellent teacher for us all who are here. And she's an academician par excellence. These are the two sentences. And later on, I will be introducing her in detail in the citation. So I request Dr. Anjali Kusurkar to come here and give her oration. The topic of her oration is Reflections Through Time, Lifelong Learning.
Good afternoon, everyone. It's such a pleasure for me to be here today in my own hometown. Thank you so much, the organizers of this PROACT conference. When I was asked to do this oration, there was no way I could have refused, because it was in the memory of somebody that I've always considered to be a father figure in anesthesia. It's not turning. It's not. Yeah. No, it's not moving. Hey, Babruka. Yeah. I first met Dr. Deshpande when I was only 7 years old. Can you see me? No.
Yeah, we can hear you.
Right. We had just come to Pune, and he was physician to my aunt's family, as both families hailed from Karad. Now, I didn't know then that he was an anesthetist, let alone an anesthetist, the topmost anesthetist of Pune. It was only much later that I learned that. And little did I know then that my little footsteps would be following his gigantic ones into the Department of Anesthesia one day, where he was honorary professor of anesthesia. Now, although I didn't have the good fortune of Dr. Deshpande ever actually teaching me anesthesia, he knowingly or unknowingly played a very prominent role in some of the very epochal moments in my own anesthetic career. So I joined anesthesia in 1977. It was not a very sought-after branch for specialization, and girls seemed to favor it more, so we were 6 girls to 1 boy who joined anesthesia. What a sea change there has been in 45 years in every aspect of anesthesia. And today it is one of the most sought-after specializations, especially in the United Kingdom. Yes. And I believe in the BJ Medical College Sassoon Hospital, now the intake is 3-1 in favor of girls. So think about that as well. And worldwide as well, where once they didn't even know that we were doctors. Today, recently, one of my patients said to me that, I believe you're the most important person in theater. And I very quickly assured her, it isn't me, but it's you. And recent events have actually catapulted our specialty into the public eye. The world watched this amazing rescue operation where this young football team was trapped in the flooded caves in Thailand. And it was actually masterminded by the anesthetist cum diver, Dr. Harris from Australia, who devised this ingenious plan of sedating them with ketamine, aprazolam, and atropine, and incremental doses given by non-medical people, the divers. And each child was carried by one diver with a mask fitted to, a tight-fitting mask connected to a cylinder of air, and through the flooded caves, through narrow channels, to safety. I mean, it was absolutely brilliant. Have any of you seen the movie 13 Lives? Hands up. If you haven't, I would strongly recommend you see it, because it makes you really proud of our specialty. And then the pandemic of 2020, when worldwide anesthetists came to the fore, saving lives in intensive care units. And this is our very own team from Sassoon Hospitals, Pune. You really did us proud. So here was I joining anesthesia in 1977, not having a clue about the specialty. But these, my seniors, held my hand and taught me everything I needed to know about anesthesia. And one in particular led me to this treasure trove, which was our library. And I devoured all the books one after the other, including, of course, the Bible, The Practice of Anesthesia by Wiley. And over time, I got to understand the subject a bit. I got to like it. And then I knew that I had made the right choice. So on to the exit exams, and it seemed but natural that I should join the faculty as a lecturer. Now, the ethos in the department in those days was working hard and helping our trainees achieve their maximum potential. But in addition, we, the staff members, were given administrative responsibilities, and under the guidance of our senior staff members, Madam Mure and all the rest of them, Tobre Madam as well, we gained a lot of leadership qualities as well as organizational skills for which I am ever grateful. Along the way, I also became vice president of the Pune City branch of ISA in 1980, and then I was honorary secretary for 2 years. Tomre Madam was treasurer then. But to me, the high point of my 14 years in the Department of Anesthesia was teaching and interacting with our residents, the registrars, the trainees, the postgraduate students as well. And that is when I realized that teaching is the best form of learning. Because if you are to teach a topic to anyone, especially a set of brilliant students like these, you want to go into the nitty-gritties of the topic so that you're able to answer all the difficult questions that these trainees are likely to put across to you. So these are some of our trainees in those days who were very successful anesthetists all over the world, actually. Now, I don't have all the photographs, I'm sorry for that, because if I did, that would have been a presentation in itself. And then in 1984, Dr. Deshpande led a group of us over to Manila in the Philippines to attend the 8th World Congress of Anesthesiologists. And that is when I got the opportunity to present my first paper at an international conference. I was very fortunate that in the audience listening in to my paper was Professor John Dundee from Queen's University in Belfast. And he seemed to be interested in my presentation and actually came to talk to me afterwards because my topic was ketamine and he was the authority on intravenous anesthetic agents. And he invited me over to Belfast. Unfortunately, that didn't actually work out then, and sadly, Dr. Dundee fell ill and succumbed to that illness. But I think I was destined to go to Belfast, maybe not then, but 10 years later. Now, what happened was that I always wanted to go over to see how anesthesia was practiced in the Western world. So when I mentioned this to Dr. Deshpande, he arranged for me to go to Belfast as an observer for 6 weeks. Now, at the end of the 6 weeks, they asked me whether I would like to come and work there. So my family and myself thought that this was an offer on a platter that I should not refuse. So I took a sabbatical from Sassoon General Hospitals, and I left Pune to go to Belfast. But what was meant to be a 2-year stint for experience turned out to be a career move for me for personal reasons. So when I first went to Belfast, I worked in 2 hospitals, the Royal Victoria Hospital and the Belfast City Hospital, both affiliated to the Queen's University of Belfast, over there. Now, one of the most prominent alumni of Queen's University was Sir Ivan McGill. Now, who hasn't heard of Sir Ivan McGill? On the right, you see a certificate which was given by the Royal Victoria Hospital to him in 1912, which said that he has administered 1 anesthetic after receiving practical training in anesthesia. And that is all that was required for a doctor to give anesthesia for surgery. Can you believe that? Now, McGill qualified as a surgeon, but he developed an interest in anesthesia. And he devised the first endotracheal tube, which practically has revolutionized anesthesia, and went on to develop a whole lot of other equipment related to endotracheal anesthesia, thoracic, and cardiac anesthesia. But it's a little known fact that he had submitted a thesis for MD at the Queen's University of Belfast on endotracheal intubation, and it was rejected on the grounds that it was unlikely to be of any use. Of course, that did not deter him. He went on, he realized that anesthesia needed to be recognized as a separate specialty, so he developed that. He introduced the first diploma in anesthesia. Sorry, I should go back. Okay. And he was also founder member of the Association of Anaesthetists of Great Britain and Ireland. He went on to be knighted, but he never received that MD from Queen's University of Belfast. Now, I went over to the town of Larne, his birthplace, just to take some photographs for all of you. And in front of his house is a plaque which says birthplace of Sir Ivan McGill, world leader and pioneer in the use of anesthetics, medical advisor to the royal family. Another prominent alumnus of Queen's University was Professor Frank Pantridge. Now, he was a cardiologist, and while working at the Royal Victoria Hospital, he noticed that patients who had acute myocardial infarction very often succumbed to their infarction before they could reach the hospital where the defibrillators were located. So he realized that if the treatment could be taken to the patients, more lives would be saved. That's how he went about inventing the first portable defibrillator. And that's the one in the picture on the right. And it was all of 70 kilograms, and it ran on car batteries. But he put it into an ambulance, which became the first cardiac ambulance in the world, forerunner of all cardiac ambulances all the world over. Now, Frank Pantridge has been called the father of emergency medicine and the grandfather of advanced life support. And this is a statue of him along with his portable defibrillator outside the Island Arts Centre in Lisburn, his town of birth. Now, of course, today the AEDs are really compact and they are all over in public places. And how many lives have been saved, we really do not know. But prominent among those was Lyndon Johnson, the ex-president of the United States, who had collapsed at his daughter's house and was successfully resuscitated. And recently, Fabrice Muamba, the Arsenal footballer who collapsed on the football field, and he was resuscitated successfully after 75 minutes. And this is Eamon McCoy, who is presently a consultant at the Royal Victoria Hospital, and he devised this flexi-tip laryngoscope blade, which very effectively brings an anterior larynx into view, and we have it in all our theatres. I think some of you may have used it here. So a bit about the political scenario in Northern Ireland when I moved over. Now, some of you may be aware that Ireland was also colonized by the British. And like India was divided, it was also divided. And the northern part was left with Britain as Northern Ireland, and the southern part, the Republic of Ireland. So obviously, whenever there is a division of nations, there is likely to be resentment. And so it was in Northern Ireland between the two communities, the Catholic Irish and the Protestant British. And this sort of smoldered for a while, but it reached a peak. And for 30 years, they had massive violence. It was called the Troubles. You've heard about the Irish Republican Army, the IRA. And there would be bombings and killings and a whole lot of violence. Now, when I went over to Northern Ireland, it was still there. And it was not unusual to find the army out in the streets, army and police vehicles patrolling the streets. There would be graffiti on the walls. And this picture on the right, you can get that. This was the hospital accommodation. The top floor was occupied by the army. I lived on the 10th floor. And up overhead, there would be a vigilance helicopter at all times. Now, the IRA had a very peculiar and awful punishment for anybody they thought was a traitor. And that was called kneecapping. They would shoot them in the knees. And these young lads would be brought into A&E and then to theatres to repair those gruesome injuries. I was one evening working in the Belfast City Hospital doing an orthopedic list. And I thought I heard a gunshot not too far outside. And sure enough, a man had been shot dead. He was a security man just outside the hospital. So it was as bad as that. Fortunately, in 1998, with the intervention of Americans, both sides agreed to disarm and hold a coalition government. But not before a massive bomb was planted in the city of Omagh, which killed 29 people and injured 220. Fortunately, after that, we haven't had that kind of violence. And in fact, Northern Ireland is very much on the tourist map of the world. You've been here. So here I was in 1994 in Belfast. And I thought to myself, life seems to be like a game of snakes and ladders. because I had risen to become an associate professor at BJ Medical College, and here I was a registrar in anesthetics. But I actually really enjoyed that period because my role at obviously was supervisory as a faculty, and here I was getting a chance to brush up my skills, give anesthesia without any supervision because I was a trained trainee. And so the fellowship exams were straightforward enough. And this is Professor Chris Roberts, who was then the president of the Royal College of Anaesthetists. And he has, of course, authored a number of books in anesthesia. And then I went on to be appointed as a consultant at Lagan Valley Hospital. And a few years later, I climbed the ladder and I became head of department. Now, so a couple of interesting incidents from my one and only consultant interview. When I went into the room, there was this panel of interviewers sitting in front. One of them was a representative from the Royal College of Anaesthetists in London, and he had probably been going through my CV, and he announced to the rest of them that she hails from a very prestigious university, Pune University. What a proud moment that was. But further on, one of the other panelists, who happened to be an Indian, decided to grill me, and he demanded to know how our 3 years training to become a consultant in India could possibly compare with the 6 years that were required in the UK. So I very vigorously and confidently told him that, look, the amount, the volume, and the variety of cases that we see in India during those 3 years are more than enough, not only to give us the experience, but the confidence to practice on our own. I think they probably bought that because I was the one selected out of 12 hopefuls. Now, your first impressions always remain with you. After a while, you get used to any new situation. And of course, this was an affluent country which would have the availability of everything with no dearth at all. But some of the things that struck me then, which were different from my practice in India, one was in terms of logistics. Whatever we needed was looked after by the nurses and technicians, so we anesthetists could focus entirely on patient care. I was actually surprised that drugs actually did what they were meant to do at all times, because because I'd got used to muscle relaxants not always working. Regarding drug requirement, I noticed that the Caucasians seem to need relatively higher doses of intravenous anesthetic agents, opiates, and such like. In fact, there was an occasion when a young Indian girl, actually a girl I knew, had a cesarean section under GA, and the consultant wanted to give her morphine for post-op analgesia. So I just cautioned her, I think you should start with a smaller dose, but she refused to listen to me. She gave her 10 milligrams, and the poor girl was unrousable for several hours afterwards. Now, scavenging was an essential part of every hospital construct and still is. And I found that did make a difference even in practical terms, because I never felt as tired as I would after a day's work in India. And I believe that was because I wasn't inhaling those trace concentrations of anesthetic vapors and gases. I believe it's still not the norm in India. You can correct me if I'm wrong. Yeah? And it was a great boon to have a dedicated nurse or technician for every anesthetic. The disease spectrum was quite different. Now, at emergencies, we didn't see the Bulgur injuries and the badly conserved acute abdomens with gangrene and peritonitis. But what I did notice was a large incidence of vascular disease, especially leaking thoracic and abdominal aortic aneurysms. And I think this was because of the type of diet that the local population indulged in, which was fried, fatty food. Anesthetic care in those days itself was very holistic, intra, pre, and post-operative. In fact, pre-operative preparation and post-operatively, the emphasis on analgesia. And we would conduct an acute pain round every morning, following up all the patients on epidurals, PCAs, and such like. And the anesthetic specialty, I was very proud to notice, was very well respected by all other specialties, and still is. In fact, one of the obstetric consultants would always introduce us anesthetists to his obstetric patients, saying that he or she is the real doctor. What better acknowledgement can you get? And the quality of nursing care the NHS quality of nursing care is absolutely exemplary. And I think that makes a lot of difference to patient outcome. So these are some of our nurses. The one thing that took a bit of getting used to was the long winter nights. When going into work, it would be dark. Coming back, it would be dark. And there was one particular morning that I was rushing into work and I was bleeped by A&E. And I was running, or rather wobbling down the corridor. And I wondered why. When I looked down, I was wearing one black shoe with a 2-inch heel and the other brown one with an inch heel. Fortunately, that didn't happen again. Now, how do Indian anaesthetists integrate within the NHS in the UK? There seems to be a perception that Indian anaesthetists do not get the recognition that they would have got in India. So I sent out an informal questionnaire to 11 anaesthetists who had worked in India before coming to the UK. Now, they had worked for a period of 1.5 to 14 years post-MD in India before coming to the UK. And the types of problems faced, 7 out of 11 said that they had faced some sort of racial discrimination, but they said it was subtle, like microaggression. Regarding language, they all spoke English, yet they said 4 out of 11 said that they had some difficulty in understanding the Queen's English. It would probably change to the King's English now. In terms of knowledge, only one very surprisingly said that he or she had not been taught theory to that extent in India. And regarding technical skills, 2 confessed that there were some techniques that they had not been exposed to in India, which they had to learn, which is fair enough, I think. Now, in terms of discrimination, I asked them whether it exists in either of the countries and how it compares, and regarding recognition, whether they got it, and what factors determined it. So regarding discrimination at work, 45.5% said it was equal in both the countries. Now, this is discrimination on any grounds, not necessarily racial grounds. 18.2% felt it was more in UK, whereas 36.4% felt it was more in India. Regarding performance-related recognition, one person said that he or she had never got recognition in the UK. 36.4% felt that they did get recognition as long as they were on par with their local contemporaries. But 54.5% felt that they needed to be better than their local contemporaries in order to be recognized. So obviously, quality does get recognition, clinical excellence does get recognition wherever you're working, whether it's in the private sector or corporate hospital or government hospital. And should we not all be aspiring for clinical excellence rather than just being competent? Not to get awards, accolades, but because we owe it to ourselves and our patients. So how can we achieve clinical excellence? Now, looking back at my own career and my experience in anesthesia, I thought of 8 areas that would contribute towards clinical excellence. And this I've called the 8-fold path to excellence in anesthesia. So we look at these 8 areas one by one. Staying on top of your game. Now, when we qualify as anesthetists, our knowledge is at its peak. Knowledge is power. But in our profession, it is so dynamic, it's ever-changing. So we need to keep pace with the advances, not only in our own specialty, but also in allied specialties. Because not only it keeps the interest alive, it makes you think, it makes you more credible with your patients as well as your colleagues. And of course, the most important thing, you can adapt that knowledge to your own practice. And that is why CME has been made compulsory, because we cannot be relied upon to do it voluntarily, looks like, right? And there are various avenues for getting the CME. But learning is a two-way process. And unless we are motivated, unless we are receptive, and unless we reflect on what we have learned, it is going to be an exercise in futility. Experiential knowledge is also a very invaluable way of learning your own experience as well as shared experiences, as we have seen in this conference, the PROACT conference, right? But in that situation as well, it is being motivated, being receptive, and being reflective to pick up the learning points and see how it can be adapted to your own practice. Now, why is it that we are considered to be experts at what we do? Why is it that other specialties look upon us if they have a difficult intubation or a difficult venous access? It's because by repetition, by practice, we have become experts. Practice, perfect practice, you add your own little adjustments, nuances to make the technique your own, which is also the reason why we're having subspecialization in anesthesia as well. Because if you focus your area of practice in one particular region, by repetition you're bound to get experts, and that's how you're going to be a safer anesthetist in that area. But on the flip side, if you're not practicing particular technique or an area of anesthesia regularly, you are likely to get de-skilled as well, which is why an occasional pediatric anesthetic by somebody who is not anesthetizing children on a regular basis is not advisable. Also, if you've been away from work, maybe for a period of 6 months, for some reason or the other, when you come back, you do lose some confidence, you can get de-skilled, so there is no harm in that situation to ask for someone to either accompany you or be with you until you get your confidence back. Now, what is ethical practice? Ethical practice is doing what is morally right at all times. So if you're in any dilemma at any time, whether or not to do a certain thing in relation to a patient, the question to ask yourself is, would I do this if the patient was a loved one of mine? Or another question could be, if a loved one of mine was going for an anesthetic, what would I expect from that anesthetist? And all the answers will come pouring in. Right from the preoperative period, you would expect compassion, empathy, that your anesthetist listens to all the questions that your patient has, answers them, and examines your patient thoroughly. So each and every step is important into the intraoperative period, conducting a very safe anesthetic, and into the postoperative period, making sure your patient is comfortable and safe, etc., etc. So every point is important. We should never cut corners, because if you cut corners, those corners are going to come back to haunt you. Not only that, these errors or little omissions and commissions can also add up to a critical incident. So from this point of view also, it is very important. And 3 other points. One is patient confidentiality. That should never be betrayed. Respect for the patient. Never ever pass derisive comments about a patient. And last but not the least, medical photography. Be very careful that you follow the rules and regulations with patient consent, and never ever post patients' photographs on social media where their identity can be recognized. Unfortunately, I've seen this happening. Now, patients, they put their trust in us, they put their lives in our trust. And we, wherever we are working, we work in teams. Now, it is important that we all work in harmony as a team in order to give the best care to the patient. So we need to be on the same page. Now, how do we do this? Now, we need to know each team member, what their role is, respect each team member, know their strengths and their weaknesses. Theater is not a place for any egos or differences. They have to be left outside. Communication is key. We should be able to communicate in a way that that particular person can understand, so be clear and precise, and be always willing to listen to what the other person is going to say. The atmosphere in theater should be conducive to anyone who has any concerns to be able to raise it, because it is all in the interest of the patient's safety. So if each person is playing their part in tune to the others, it becomes so harmonious. It is like an orchestra playing in tune for the patient. Another important thing that can be done is practices, drills, teaching, simulator training as well, so that it becomes a team building exercise. In our theaters, we adapted the WHO checklist, and central to it is the entire team introducing themselves to each other, and then all the patients' checklist is conducted with everybody present, so everyone knows what it is, and everybody is free to raise any concerns they have, all tuned towards patient safety. Now, sometimes things can go wrong. Somebody is supposed to have said that anesthesia is 99% boredom and 1% panic. That must have been a surgeon, right? And we were taught during our undergraduate days about watchful expectancy and masterly inactivity. Well, in anesthesia, that should be changed to masterly activity. Because when things go wrong, you have to get your master act into place. You have to become a leader. And how do you become a good leader? Leading by example, of course. So being prepared at all times, being mindfully present, not just physically present with your mind on the WhatsApp, right? Being vigilant so that you spot the earliest warning signs. So you can be proactive. For example, if there's excessive bleeding, put in an extra cannula or check for blood availability, ask for an extra pair of hands. And what are the best extra pair of hands to help you in theaters? Another anesthetist, right? And then, if things do start turning into a crisis, that is the point when a drama starts unfolding where you are the main actor as well as the director. Screen has gone up. So basically, you have to play your own role as well as instruct every team member to do whatever they have to do in very clear, precise terms. You have to be watching the patient's vital signs. You have to be aware of the clock that's ticking. You have to keep everybody in the loop. You have to think of plan B, C, so you're multitasking. This is where your training and your experience come to the test, and this is a true test of clinical excellence. I know most of you have been there and done it well. And supposing there has been a critical incident in theaters, what do? Patient has recovered well, has moved to ward. What do? Just heave a sigh of relief and say, thank God. You do that as well, but this should be an episode for you to learn from. So it's important that there is a debriefing, that the whole team gets together, and it's very good for the anesthetist to take the lead to bring the team together because surgeons usually don't have the time. And it's important to recapitulate all the events, pick up what the good points were, and commend the people because people like to be appreciated, they should be appreciated. And try and find out what could have been done better, whether there were any mistakes, in order to correct yourself, not to blame anyone, so that in case there is such an eventuality again, you are dealing with the situation in a better way. And if you're working alone and you have a problem, and you're not sure, you can't resolve it yourself, then you should turn to your support group for advice. And I think every anesthetist should have an anesthetic buddy, an anesthetist who's a friend, who understands you and whose judgment you trust. So that together you can sort out any problems. And if you don't have that either, it's a good idea to write it down in a diary, look at it critically, see whether there are any learning points, and adapt them to your practice so that you can move on. Now, with social media invading our lives and everybody putting their lives on them, flaunting all their awards and their achievements, it is quite likely that you might feel maybe envious or get an inferiority complex or even feel you're in competition. Actually, it is good to appreciate, admire, and get inspired. But if it's causing a negative emotion in you, then that is really not the best thing for you. But you have to remember that each one's journey is their own. Each one's situation, their opportunities are different. And if you have to compete with anyone, your competition should be with yourself. To strive to do better and better. And if your patients are happy with the way you're treating them and your results are good, then you are already a winner. And finally, to self-care. Now, ours is a high-demand job. Very often we're working in top gear, which takes a lot of fuel, a lot of battery charge. But luckily, ours is also a specialty where we can have a very good work-life balance, provided we don't overdo it, provided we don't stretch the hours of work. Because we can switch off from our work when we go home and spend that time in a quality way with the family or looking after your own health and nutrition and diet, exercise, whatever. And very important of all is getting a good night's sleep, because that's when your batteries get recharged and you're ready to take on the next day's work. But sometimes there could be stresses, work stresses, are likely to be there. Maybe the working conditions are not great, or you have friction with somebody, or maybe the remuneration is not good. If there are such problems, you should identify them early and try and sort them out. Because if you let these stresses accumulate, over time, they can have a telling effect on yourself, physically, mentally. You can start feeling fatigued, headaches, tired, fatigue, that is, body aches, and maybe even have poor moods or depression, panic attacks, and it might even go over into your performance at work, and you might not feel like going into work. And that complex is called a burnout. And in recent times, it has been noticed that medical professionals, doctors, are thinking of actually leaving the profession altogether, and the commonest cause given is burnout. So try not to reach that level, because there is always help. There are solutions to all these problems, and it's not worth sacrificing your whole career for something that can be corrected. So self-care is very important. And finally, the R word. What is that? Retirement. Ours is one of the professions where there is no mandatory age for retirement. Doctors would love to work. Dr. Bhatia. And we admire you for that. But because functional age doesn't really match chronological age all of the time. But there have been some concerns that some of them may be overdoing it. So it has been suggested that doctors, at later age should have physical tests in addition to their performance tests in the eyes and hearing, and also cognitive testing. Because if somebody is in cognitive decline, you're not likely to know it yourself, and your colleagues are not going to tell you. But the question is, who's going to do these cognitive tests? How are they going to be assessed? So there is a stalemate on that, but it's likely to surface again. But we, anesthetists, we compare ourselves to airline pilots. And airline pilots have a mandatory retirement age of 65. So how are we any different? Do we not also have a best before date? So why is there a taboo against retirement? Is it for monetary reasons? I don't think so, because you'd have earned enough and saved enough. Is it because you can't think of anything else to do? Is it a calling that you feel you're born to be an anesthetist or a doctor? Or is it for the prestige attached to the job? But look at it the other way. You have spent many years working hard. You've earned a life without the burden of having to earn, without the burden and responsibility that goes with our job. And with a bit of luck and longevity, you could get a good 2 or 3 decades of doing something else that you really always wanted to do, leading a quality life of a different style, because there is more to life than anesthetics, believe me. Yeah. So I would say that think about it. There is no fixed age. It is, you will know it yourself when you feel it's time to go. But think about it, prepare for it. And I would say quit while the going is good, quit while you're ahead, quit while people are asking you why, rather than why not. So I did just that. I wasn't planning to retire. I was enjoying the day job. But to be very honest, I wasn't enjoying waking up in the middle of the night and attending emergency calls. And then the pandemic came along. And as we started preparing for this influx of patients, my colleagues said to me that they did not want me to be frontline because I was in a higher age risk group. That is what I felt was a signal for me to pass the baton on to this younger, very competent group of anesthetists. And I did just that. I very seamlessly moved into retirement. And 2 or 3 weeks down the line, I suddenly felt lighter. I felt as if a weight had been lifted off my shoulders, a weight that I had never been aware of because it gets internalized. It's a weight of responsibility. So here I am exploring all the other different things that life has to offer, ever learning in the University of Lifelong Learning. And now I'm sorry your lunch has been delayed, but I sometimes look upon life as a 3-course meal where the starters are your formative years and your training years that build up your appetite for the next course, which is the main course, which is your career, which should be long and fulfilling. But don't forget there's another course, which is the dessert, which is retirement, which even diabetics can enjoy. So thank you all for a very patient listening. And I wish you all the best. Thank you so much.
That was a fantastic oration lecture. Now ISA Pune City will felicitate our orator. So we just 2 minutes.
This keynote address and A.M. Deshpande oration, which we started in 2016. And these are the two sessions in our PROACT, are very, very crucial sessions. And I think so far, since this is 7th year, which we are doing this keynote address and oration. Sorry for the delay today. Maybe because of some technical issues, first session got delayed, and there were important topics. Let's carry on further process. Thank you so much, coming from all the way from this thing to your hometown. Thank you so much.
I request Dr. Pradnya Balerao, Honorary President of ISA Pune, to felicitate our orator for today. I request Dr. Sare sir and Dr. Sunita to join in the celebration.
Wow.
Request Dr. Pradnya Balerao to read out the citation.
Respected Dr. Anjali Kusurkar ma'am, we, the Society of Anesthesiologists Pune, feel privileged to present the late Dr. A.M. Deshpande Oration Award and this citation in honor of your enormous contribution to the field of anesthesiology, both in India and the United Kingdom. Madam, you have had a long association with the BJ Medical College and Sassoon General Hospitals, Pune, as an undergraduate, postgraduate, assistant professor, and associate professor. A board ranker in matriculation from Jammu and Kashmir, you have had several firsts to your credit. A gold medalist for diploma in anesthesia and MD anesthesiology. You were honored with the prestigious Dr. Ambadekar Award at the 26th ISA National Conference. Following this, you cleared the prestigious MNAMS, the National Board Examination, with flying colors. You were the pioneer in starting the first plain clinic in BJMC in 1987-88 when it was unheard of in any other institute. After moving on to Belfast in 1994, the training at Belfast City Hospital, you completed your FRCA in 1995 and joined as a consultant at the Legonberry Hospital. You were head of department from 2008 till your retirement on 1st of July 2020. Your commitment to academic excellence is reflected in your contribution to several articles in reputed national and international journals. You were a keen researcher right from the days at the BJ Medical College and were the editor-in-chief of the Medical Journal of Western India. You have been in positions of Vice President and Honorary Secretary of the ISA Pune City branch as well. Madam, as a true teacher and lead faculty member, you have trained anesthesiologists at numerous state, national, and international conferences and workshops as well. You have been a lead clinician in pediatric anesthesia and difficult airway. During the last 4 decades, you have given many practical and thought-provoking orations and presentations at various forums which have benefited young generation of anesthesiologists. Your philosophy and achievement are a true inspiration to us all. We are thankful and appreciate your acceptance of our invitation at the PROACT Pune conference on the 24th September 2022 and delivering the late A.M. Deshpande oration on the topic Reflections Through Lifelong Learning. We feel honored to present to you the citation and the late A.M. Deshpande Sir Oration Award. Thank you.
I request Dr. Sunita to give the vote of thanks for attending this oration.
I would like to thank Dr. Anjali Kusurkar for taking us through her journey and her lifetime experiences, and also our heartfelt gratitude for accepting our invitation and coming for this PROACT conference all the way from the island. Thank you very much, ma'am. Now we will move to the lunch. Lunch time will be 30 minutes. Next session will be start within 30 minutes.